So, with everyone's permission, I'm starting with today's live now. Greetings and a very warm welcome to all the dignitaries present here. I'm Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for doctors. Clearnet is ready to be chosen as a digital partner for this event organized by Cardiopcon Society Ranchi. So today's focus would be Cardiology Web Conclave 2025. Let's begin today's session for which I would like to invite Dr. Vinit sir to take over. Over to you, sir.
Thank you, Swastika ji. Uh, as rightly said, as we have been doing since few years now, today also we are here. I guess the screen is visible.
Yes, sir.
Today we are here once again for Cardiology Web Conclave. For the first session, before we begin, we'd like to pray God, Vakratunda Mahakaya Surya Koti Samaprabha, Nirvignam Kurume Deva Sarvakaryeshu Sarvada. या कुंदे तुषार हार धवला या शुभ्र वस्त्रावृता या वीणा वरदंड मंडित या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिर्देवै सदा वंदिता सा मां पातु सरस्वती नेशेष जाड्यापहा. Praying Lord Ganesh and Ma Saraswati, and also today is an auspicious day of Indian independence. Vande Mataram Sujalam Suphalam Malaya Sheetalam Shashya Shyamalam Mataram Shubhra Jyoti Snapulkit Yamining Pulla Kusumita Drumadal Shobhinim Suhasining Sumadur Bhashinim Sukhadam Varadam Mataram Vande Mataram. With these prayers, we begin our first session. This conference is organized by FPA Ranchi as a zonal conference of FFPI, the Cardiology Web Conclave, in association with Heights Society, the Hypertension, Ischemic Heart Disease and Diabetes Education Society. For the first session, I invite Dr. Vishmay Parmar and Dr. Sachin Khandelwal as the chairperson. To introduce our speaker, Dr. Aashish Valvani, I request Dr. Vishmay Parmar to kindly take over.
Good morning, friends. So today is Independence Day, and we are going to start our web cardiology web conclave Ranchi APA Journal Conference. The first speaker is Dr. Aashish Valvani he is a pulmonologist from the Michigan, USA. So warm welcome to Dr. Aashish Valvani for first session of our conclave, asthma, bronchial or cardiac. Welcome, sir.
Over to you, Dr. Aashish Valvani. He has been awarded for so many awards like Chief Fellow of Pulmonary Critical Care, Best Intern Award, Best President Award. He has also been top scorer at graduating exam. He also received a scholarship and he is attending physician at various centers in USA. He is also part of assistant professor at Michigan State University. With these words, I request Dr. Valvani to kindly take over from here and enlighten us.
Good morning. I hope everybody can hear me.
You are audible, Doctor.
Okay. Thank you, Dr. Jagnany, for inviting me to be a part of your conference. And I'm getting some palpitations and a little bit of troponin leak to be presenting in front of all the cardiologists where the topic involves a cardiac issue. So I'm not going to bore you with a lot of bronchial asthma, but on the contrary, because there are a lot of cardiologists in the cardiac asthma, we'll talk about that. And both the chairpersons for my talk, Dr. Parmar and Dr. Khandelwal, are esteemed cardiologists, so pardon me for any errors in my presentation, but I'll try my best. So disclosure, I have no personal or professional financial interest or conflicts of interest to report. About me, a little bit, I was born in Mumbai, raised in Indore, Indian at heart still. I did my MBBS at Sion Hospital in Mumbai, then did my MD in medicine at Banaras Hindu University, worked for a few years in India and abroad before coming to the US, had to do my medicine again, then did my pulmonary critical care fellowship, Currently, I live in Michigan and I practice pulmonary critical care both. However, while in India, I did try to get into cardiology, but I was unsuccessful at that moment. So cardiac asthma. I'm going to talk more about cardiac asthma and just relay the comparisons between bronchial asthma and cardiac asthma while we talk. But the slides are predominantly about cardiac asthma because that's the most interesting part. The bronchial asthma is more common, and I could not do justice to asthma as a pulmonologist in a short talk of 15 minutes. So the term was first coined in the 19th century in 1833 by Dr. James Hope. About 20 years later, Stokes defined it as a disease state. And at the end of the century, Sir William Osler described it very well, saying in cases of advanced arteriosclerosis, there are often attacks of dyspnea of great intensity recurring in paroxysms, which are often nocturnal. The patient goes to bed feeling quite well, and in the early morning hours wakes in an attack which in its abruptness of onset and general features resembles asthma. Two other features about this form of attack will attract your attention: the evident effort in the breathing and the presence of a wheezing in the bronchial tubes and of moist rales at the bases of the lungs. So this description still holds true almost 125 years later in, in the 21st century. And just a corollary, when you have a lowering of the degree of the vital capacity of the lungs, generally, a pulmonary cause of the lowering of the vital capacity will cause less dyspnea than a similar lowering of the vital capacity with a cardiac disease. So, as I always tell my patient, dyspnea on exertion has more cardiac causes than pulmonary causes. So, cardiac asthma, the attacks usually occur in a supine position and late at night, a few hours after sleeping. There is concomitant history of hypertension, mitral valve disease like stenosis or regurgitation, or an aortic valve pathology, or any kind of left heart disease predominantly, where there is a left ventricular insufficiency, could be diastolic dysfunction, could be mitral pathologies, and other things. Milder attacks usually awaken the patient, are associated with cough, improve when standing and walking. After coughing up some expectoration, patient feels better. Severe paroxysms can lead to acute pulmonary edema, more severe cough, audible wheezing, and coughing of blood-tinged frothy sputum or pink-colored sputum. Audible wheezing and more commonly moist rales are heard. For the cardiologist, this is very self-explanatory that this is a form of left heart failure or left ventricular failure. However, cardiac asthma could be the first sign of a left ventricular insufficiency, which is a premorbid state before full-blown cardiac failure or congestive heart failure ensues. Generally, you don't see the cardiac asthma symptoms with right-sided heart disease or right ventricular failure. Some general diseases like myocarditis or tamponade can present as this, but again, by involving the left ventricle or impairing the left ventricular function. Talking about the pathophysiology, is generally increasing in the left ventricular diastolic pressure, which leads to passive congestion of the lungs and transudation of fluid. This in turn can produce anoxia or hypoxia of the pulmonary endothelial cells, which increases the permeability of the blood vessels and the capillaries next to the alveoli and further worsening the edema, thus propagating the vicious cycle. Now, why does cardiac asthma wheeze like bronchial asthma? There are few mechanisms that could explain this, like congestion and or edema of the mucosa of the bronchioles, active bronchoconstriction, which has been described in studies and research examinations of these patients with congestive heart failure, compression of the bronchioles by the congested capillaries, obstruction due to the edema fluid inside the bronchiolar or alveolar lumen, causing narrowing of the bronchiole. The relative importance of these and of other unknown factors uncertain, but the obstruction of the bronchial tree is an important factor which contributes to the dyspnea as well as the wheezing. This figure explains that in a normal airway, there is a lumen which is surrounded by a smooth muscle, which is surrounded by the lymphatic vessels, the blood vessels, the cartilage, and the external wall. Now, in heart failure, as you can see, the blood vessels are engorged, the lymphatic vessels engorge and get enlarged because of accumulation of the fluid, compress on the airway lumen, narrowing the lumen. Now, the other theory also says that there is active smooth muscle construction, as you see in this figure, which the arrow is showing, where the smooth muscles actually constrict and narrow the airway and the entire apparatus, thus narrowing the airway. The interesting thing is when expiratory airflow or airway obstruction predominates, just like classic bronchial asthma, COPD, or other pulmonary pathologies where there is inflammation and active disease of the airways, where there is an expiratory airflow obstruction as a dominant pathophysiological marker, it results in elevation of the intrathoracic pressure, which in turn results to diminished venous return by causing compression of the superior vena cava and the inferior vena cava, which may improve the left ventricular failure in theory. When inspiratory obstruction predominates, which occurs in the cardiac asthma, there is a decline in the mean intrathoracic pressure, which increases the venous return, aggravates the pulmonary congestion, and perpetuates the cycle of worsening of cardiac asthma or left ventricular failure, or cardiac asthma is also can as be used interchangeably with paroxysmal nocturnal dyspnea. Now, triggers of cardiac asthma generally include coughing, nightmares, abdominal distension, constipation, desire for urination, eating a heavy meal, hunger, excessive heat, and positioning, which is typically a supine position. Now, interestingly, most of the above triggers act by increasing the respiratory stimulation or causing respiratory stimulation, which in turn lowers the mean intrathoracic pressure, increasing venous return into the right ventricle, which, in the presence of a diseased or compromised or insufficient left ventricle, results in more pulmonary congestion. This causes further respiratory stimulation and a vicious cycle is produced. So, cardiac asthma or left ventricular failure or pulmonary edema generally begets itself. Some comparison, bronchial asthma and cardiac asthma both produce wheezing. There is cough both in bronchial asthma and cardiac asthma. Generally, the mucus production in bronchial asthma is scant, it's mucoid, it's white in most cases, especially in the milder or the intermittent asthma variety. Whereas in cardiac asthma, the sputum is more frothy, sometimes pink tinged, and at times frankly bloody. There is more dyspnea associated with cardiac asthma, and it can be dyspnea on exertion or dyspnea on activity, which is predictable, which a patient can expect every time he does. Whereas in bronchial asthma, this is paroxysmal. Only during the episode they feel dyspneic, whereas most of them describe as chest tightness, wheezing, and difficulty breathing, not as being fatigued, tired on breathing. Triggers for bronchial asthma are exercise, infection, allergen, irritant, pollution, weather, menses, emotional triggers. Symptoms can be nocturnal in both. I talked about the triggers of cardiac asthma. Normal sized heart on the physical exam or on the radiographic exam in bronchial asthma was in cardiac asthma, enlarged heart. Now, in the older literature that has been described many years ago, there was a test called circulation time in which they injected a dye into the venous system and they measured the time where the tongue would sense a bad taste because the dye had a bad taste. So the circulation time in heart failure, which is basically cardiac asthma, is prolonged because the heart is not functioning optimally, whereas in pulmonary pathology like bronchial asthma, the circulation time is normal. So they did it. In the modern era, they do an angiographic study with CT and MRI, which clinically is typically not done. But this is an interesting thing that I found out while reviewing the literature on this. Now, X-ray in cardiac asthma shows cardiomegaly, pulmonary edema, curly B lines, pulmonary vascular congestion or cephalization, sometimes pleural effusion. X-ray in bronchial asthma without other concomitant pathologies, many a times normal. In severe asthma or in long-standing asthma, which is not treated, you could see hyperinflation, evidence of bronchial wall thickening, or air trapping in expiratory film if you get that inspiratory film. When you're auscultating the lungs and your patient starts talking, so treatment for cardiac asthma. I'm only going to talk about cardiac asthma because bronchial asthma can be a whole talk in itself. No well-defined treatment plans or guidelines exist for treating the acute cardiac asthma, typically described as such. You have goal-directed medical therapy for full-blown heart failure and for established heart failure. Now, interestingly, it is commonly seen in practice that bronchodilators like albuterol and ipratropium, which are used for any type of wheezing and do relieve symptoms of bronchial asthma, have not been established in cardiac asthma. On the contrary, short-acting beta agonists like albuterol have been described in the AHA article in 2016 are drugs that can exacerbate congestive heart failure or drugs that can potentially worsening heart failure. Now, this is controversial. Most heart failure patients do have COPD or other pulmonary diseases. Sometimes they also have asthma. So if they have a history of a pulmonary pathology, use of bronchodilator should not be restricted. However, if you can confidently make a diagnosis that this is predominantly cardiac asthma and you have wheezing from it, you may be okay by not using them and treating the underlying pathophysiology, and that itself would give you enough response and improvement in symptoms and the wheezing. So the mainstay is furosemide for reducing the volume status. In the olden days, in the 1800s, they did venesection and tourniquet of three extremities or phlebotomy to do the same thing. Nowadays, we can use furosemide. We use morphine, which reduces the respiratory drive, thus by decreasing the respiratory stimulation, decrease the venous return, and improve that congestion. And nitrates, which are vasodilators, again to improve the forward flow from the left ventricle and decompress the diastolic dysfunction that the left ventricle is facing. Oxygen, non-invasive ventilation like positive pressure ventilation with CPAP, BiPAP, or other modalities does help, and elevation of head of bed and not keeping the patient supine definitely helps. Now, point here is if the patient does not have hypoxemia, adding supplemental oxygen does not help, and on the contrary, can cause more pulmonary edema by irritating and drying the alveolus. So, contrary to the belief, just adding oxygen when the saturations are good, it does not give any benefit and can potentially be deleterious for the patient. Steroids are the mainstay of treatment of asthma, predominantly inhaled corticosteroids, but we also use systemic steroids for patients who come to the hospital or casualty or emergency and are wheezing, and then they are treated empirically with steroids, Lasix, antibiotics, bronchodilators. Everybody who comes with shortness of breath and is wheezing or has RALS is given the same four things: steroids, Lasix, antibiotics, and bronchodilators, without trying to figure out what is the predominant pathology. Now, steroids, as we all know, can cause water retention, sodium reabsorption, potassium loss. Now, understand, when you have potassium losses, hypokalemia is not good for the myocardium or the electrical system of the heart and can trigger arrhythmias like atrial fibrillation and other arrhythmias, prolonged QT, and other problems, which in a patient with underlying cardiac disease is not good. Steroids also cause increased blood pressure, which itself is a risk factor for cardiac asthma. So systemic steroids may not be warranted for cardiac asthma and congestive heart failure, whereas in bronchial asthma, they do have a significant control. So keep in mind when we treat that. Now, I'll end my talk with saying Chevalier Jackson, who was an ENT surgeon, described it in the 19th century. All that wheezes, not asthma, where he described a foreign body obstruction of the airway, which mimicked asthma. I'll end with this quote: live as if you were to die tomorrow, learn as if you were to live forever, by Mahatma Gandhi. I'll open the floor for any questions. Thank you.
Dr. Ashish, by your talk, I could gather that definitely we need to have one thing clearly in mind that when we are treating cardiac asthma, the steroid is one thing which should be avoided, which is very commonly used, specifically the systemic oral steroids or intravenous, and which is very commonly used in pulmonary or bronchial asthma. I guess I could take the correct message out of this session.
I would definitely say that most of the patients, even here or over in India, I could describe a case to you, which I really real-time case. I was traveling to my hometown in Indore. A neighbor who was a physician brought her father to me, saying he's 75, he's been coughing a lot. He did have smoking history many years ago, but he's seen 3 pulmonologists, 2 cardiologists, and he was treated as a COPD. He was given multiple inhalers, he was given multiple courses of steroids, he was given multiple courses of antibiotics, he was even started on theophylline. This is a 75-year-old guy with cardiac issues, neurological issues, and everything. And he said, I continue to cough and I'm short of breath. I cannot breathe and I'm coughing constantly. Can you please help me? He got CAT scans, x-rays, many things. And I read all of the doctor's notes and everything. And what I did for him was I examined him and I put him on a 7-day course of furosemide and said, take this medication, stop everything else, don't take the antibiotics. You've been given 4 antibiotic courses, you do not have a pneumonia. You've been given theophylline, which is not safe for you given your age and other cardiac comorbidities. And if the nebulizations and bronchodilators are not helping you, stop them. Take the Lasix. I came abroad back after 7-10 days and I get a call from them. He feels wonderful. He's lost all the swelling in his lower extremities. His cough is gone. He's walking around and he's breathing fine. So sometimes just because a patient has been a smoker, has a history of asthma or COPD, we just go down that road of it is asthma and COPD exacerbation that is not improving. If their X-ray looks abnormal, we say this is pneumonia, but all they have is pulmonary congestion. And at times, treating that improves the patient's symptoms, which is cough, dyspnea, wheezing, which is all common in both asthma and so at times you have to make the distinction and treat one disease at a time. If the patient is not in extreme situation, somebody who's dying and very sick, I would throw the kitchen sink at them. But if you have time, talk to the patient, examine, get your findings, get your x-rays, get your labs, and try and narrow down what are we dealing with here. I know it's not easy to get an echo immediately within 10, 12 hours after patient coming to the hospital, but you can get a sense by physical exam and some basic labs. What am I dealing with? Just because he's wheezing doesn't mean it is asthma or COPD. This could be cardiac. Let me treat with diuretics. Let me give him some nitrates if his blood pressure is high. And if they improve, you don't even need the albuterol. You definitely do not need systemic steroids. Even in severe asthma, steroids do not play a role within the first couple of hours. It is the albuterol that saves the patient. Steroids typically take 6 to 12 hours for its onset. So even if you give the patient salmeterol, a big dose, it doesn't start working in 30 minutes. The first 30 minutes, what works is the albuterol in severe asthma. So in cardiac asthma, yes, you can try one albuterol, but Beyond that, I would not hang my hat on just the asthma diagnosis and make sure I'm not missing any underlying condition. And diastolic dysfunction is very easy to miss if you're not looking for it. It does not come with overt failure. And as I said, cardiac asthma is usually the early sign or the precursor of overt, full-blown, fulminant heart failure, which is easy to pick, which even with your closed eyes, you can make a diagnosis. But the cardiac asthma is the early onset or the early stage of heart failure, which have to be picked with a good clinical exam and a good history and just paying attention to the details. Then you can treat the patient well.
Thank you. Thank you so much.
You're welcome.
I guess anything else for Dr. Ashish? In that case, we move to our next session. Before we move to our next session, I request Dr. Valvani to kindly accept a token of honor as certificate, which will be posted to him. Definitely, he will receive it. And also to our chairpersons, Dr. Vishma Parmar and Dr. Sachin Khandelwal. Thank you so much for chairing this session. With this, we move to our next session. And to chair the session, we have Dr. A.K. Singhal, who is clinical cardiologist at Delhi, and Dr. Rajni Chaudhary, clinical cardiologist at Dhanbad. To kindly introduce Dr. Mohan. Over to Dr. A.K. Singhal.
A very good morning to all of you and happy Independence Day. So, can I have the slides?
Just 1 minute. Yep.
Is it not?
Not visible. Not visible to me.
Yeah, I just trying.
I'll just share once again.
Yeah.
Is it visible now?
Yes, it is now opening. Still not open. Yeah, now it is open.
Okay.
So, dear friends, we have very eminent speaker with us, Dr. Mohan. So, consultant clinical cardiologist and diabetologist, and especially regenerative medicine for the cardiac disease. So, he's a consultant of ECP and ECMR and nutraceutical specialist, Wellcare Medical Center, Coimbatore. He is the secretary for the Tamil Nadu IACC and ex-vice president of that community. So, warm welcome and please continue, Dr. Saab.
Just 1 minute. Just please hold on.
You can make it in a full way because
Yeah. I'm just coming. I'm just sharing it. There is some difficulty in sharing. Are you able to see my slides?
slides are visible, but the font, this one size is small so far.
Yeah, just 1 minute. Now is it okay?
I think it's okay. So over to Dr. Mohan regarding this ECP and the heart care.
Yeah.
Please, sir.
Am I visible?
Uh, Slides are visible, but yeah, now you are visible, right?
Okay, okay. Thank you. Yeah, good morning, everyone. So I am Dr. Mohan from Coimbatore. So basically, I'm a clinical cardiologist. So I am practicing this non-invasive ECP and nutraceutical medicine since 2008. So almost it is 16 years over, and ECP I am doing it for the past 15 years. So I am basically into a fully non-invasive cardiology like that. So first of all, let me introduce what is ECP and how it helps in heart care and everything. So ECP is a very good system, a very good technique which we cardiologists, clinical cardio-physicians can use in our practice. So that is the thing. So thank you, Vinit Jagnany and everybody from the Cardio Zone 2025 to ask me to join this webinar about this ECP and heart disease, and also a happy Independence Day to everyone. So my logo is that let's regenerate. So I am into stem cells, regenerative, and ECP. So everything we deal with regenerative one. So our emblem is like that. So I'm practicing in Coimbatore as well as. So this is what called the ECP or the ECP. ECP is nothing but it's called the external counter pulsation, where you are giving a non-invasive treatment modality to patients with heart failure or heart blocks who are not vulnerable to any surgical methodology, or those who are having a previous bypass or stent, still they want to have a good improvement in their quality of life, then they are all the persons whom we want to give the ECP therapy. So I am also a member of our executive secretary, our executive member of, and also the leaning episode of the International ECP Association. So now we are formulating all the protocols internationally to get how the protocol will be everything. So according to that, I'm just sharing few of my ideas and the basics about ECP and the heart crash. So what is ECP? ECP is nothing but a non-invasive therapy where there is a refractory angina pectoris designed to symptom relief of angina. So provides mechanical assistance during the cardiac cycle to improve the circulation. And ECP provides little no risk to the patient. It is safe and it's a daycare procedure. So total duration will be 35 sessions, weekly 5 days for 7 weeks. So during that, there is 1 hour therapy is provided on an outpatient basis only. So there is no need for stay or there is no injection given. There is no intervention, nothing. Just they have to lie down on the bed with a cuff muscle and everything is with the cuff with the ECG monitoring and everything. So this is basically the ECP. So coming to the session, what does the ECP do? So ECP increases the venous return, increases the preload, increases the diastolic filling pressure, creates retrograde arterial blood flow, and increases systolic unloading, increases the vascular recoiling mechanism, and decreases the vascular resistance, and decreases the cardiac output. So, and increases the cardiac output. So, at the end of the session or whatever the treatment, what we achieve is during bypass or angioplasty or whatever it may be, what we need is we have to reperfuse the myocardium, which is infected or failed during MI or any unconditional or idiopathic cardiomyopathy like that. So our main aim is to reperfuse the myocardium. So there will be a neoangiogenesis, everything will be coming in the ECP. So that will be beneficial for the patient who are going for the ECP therapy. So who are all the potential candidates for ECP therapy? There are some indications and contraindications for ECP therapy where we can have all this. So the patients with chronic stable angina, that is Canadian classification 3 or 4, refractory to medication, even with nitrates or whatever the anti-anginal you put, still they are having the anginal pain, then they are the typical subjective patients who are fit for ECP therapy. And anginal equivalent, right, shortness of breath, fatigue and exertion are not provided adequate relief with the nitrates, as I mentioned before, or do not qualify as a candidate for invasive. They may be having a poor failure, poor target vessels, or in diabetic, there may be a diffuse, or they must have undergone 2-3 angioplasties or a bypass before. Now there is no need for, or there is no place for interventional therapy. Then these are the candidates who are fit for ECP therapy, that is external counterpulsation. And there are also persons who have exacted invasive therapy without lasting relief of symptoms. Patients who are unwilling to undergo bypass surgery or angioplasty, or patient with comorbid states, they may having other diseases and everything, then they are other candidates. And patients who have become sedentary and have limited physical activity to avoid anginal episodes. So they are all the candidates who are all eligible for ECP therapy. So this is what called the ECP therapy. As you see here, they have a cuff. Near the thigh, they have a cuff. There is abdominal cuff. So what we'll do is we will give you a sequential pressure to the heart. So it is a diastolic augmentation what we give. So it will give you a improved perfusion to the heart, and it will give you a diastolic refilling, because during diastole only we are getting the blood flow to the heart. So all our R wave get it. So it will give like this. So the mechanism is believed to increase the circulation, resulting in improved myocardial perfusion. So whenever chronic exposure to EECP increases shear stress in the coronary circulation, and there's a growth factor which stimulates angiogenesis. So for example, when you are bombarded tissue with repeated pressure inside, what will happen? No, the tissue will revert back with the response that it will create a new angiogenesis, and that will be very beneficial for the patients. So as I told you, this is not the other indication also. So preparation or a chronic CAD, patient refractory to mechanical treatment, target lesion is not a LV dysfunction with the iris CAPG, restenosis, CAPG graft occlusion. So preparation, waiting to some other lesion, they may be waiting for the lot of hibernation to stabilize. So in that period of time, when the subject is subjected to ECP therapy, then they can have a very good vascularization or angiogenesis in the heart. So heart failure, non-ischemic cardiomyopathy, non-ischemic cardiomyopathy, patient with LV dysfunction, patient with moderate to severe level of congestive audiocular and cardiac syndrome. These are all the another indications for ECP therapy. So what will happen now? There will be a sequential inflation and simultaneous deflation in the ECP. So there is increased diastolic pressure, increased intracoronary pressure, increased myocardial perfusion, increased venous return, increased preload, increased cardiac. So there is, when you have a simultaneous deflation during the ECP, what will happen? There is decrease in systemic vascular resistance, decreased cardiac workload, decreased myocardial oxygen consumption, and decreased afterload. So all the pressure is released at the onset of the systole or the diastole. So what will happen now? The pressure is released during systole, but pressure is dying. There will be a pressure going in the diastole. Then again it is released. So you will concentrate only on the diastolic refilling. So the R wave will get. So whenever the R wave is coming into the ECP recordings and everything, then it will go for a diastolic accommodation. So we can see some pictures in the material that where we will get a diastolic augmentation. So it will be in a waveform where you can have a aortic diastolic augmentation. So there will be some inverted like a rabbit hair like things will come. So it will show that the patient is giving this much pressure and it will be giving a this much augmentation. So once you get the augmentation, then the pressure is stable and all the 35 sittings he has to go with that. Or sometimes we can increase to get a good augmentation. So this is called the cuff inflation. There will be top cuff, lower cuff, and upper thigh cuff. So they are all the sequential. Whenever the R wave getting only the ECP work, otherwise the ECP will not work. It will stop once you get the RCP R wave, then automatically it will give you a inflation and deflation. So the R wave, as I told you, R wave is the trigger point because ECG, blood pressure forms and everything. This is the coronary blood flow and this is the coronary flow impedance. So it will be like that. So when it comes to like that, it will be like a systole and diastole. So these are all the cuff usually includes. So upper thigh 5 milliseconds. So when you have a inflation, what will lower thigh 50 milliseconds, then 50 milliseconds later, and deflation to the cardiac and body. These are all the sequential. So when you see and you just put your hand in the cuff like that, you can feel the same ultimately within 50 milliseconds, every diastolic augmentation will go inside. So it's like an intra-aortic pump only where you can see an increased venous resistance and systolic unloading and improve the ability diastolic filling. It is what exactly the ECP is handling. So that's what I told you when the patient is waiting for a interventional procedure which is not filling at all, is not fit for the time. So in between time, what people will do is in some centers, they use the ECP as a intermediate procedure. So what will happen? No, it will prepare the heart to go for a good surgical procedure like that. So that can also be indication of ECP therapy. So these are all the small things what we have the before and after ECP therapy. So the damaged heart muscle is due to the and after that you can have your multiple natural bypass or the angioneogenesis inside the heart. So usually what will I do is so after the 35 sessions we ask the patient to come after 1 month and we'll check the echo before and after, or sometimes we can go for a stress thallium like that. So how much the improvisation, everything, or how much the collateral or the reperfusion will be. But once they ask for angiogram, everything, then I'll ask the patient to go and take a angiogram after 1 year of ECP, because it's a very slow process. It will have some people will have a very good honeycomb like collateralization inside the heart in ECP, but depends on your patient selection and how their heart responds to. These are all the main important factors in getting the ECP. So what are the contraindications when you have a severe AIR? Then you should not do aortic aneurysm, uncontrolled arrhythmias, severe lower extremity venous occlusive. When you have a severe peripheral vascular occlusive disease, please don't go for any ECP therapy because it prevents retrograde play flow, and active thrombophlebitis, bleeding in diabetic patients, diastasis or whatever, decompensated heart failure, very pulmonary edema, so you cannot do, and cardiac catheterization within the past 2 weeks to reduce the risk of bleeding in femoral puncture. Nowadays, now we are not concentrating on femoral here. What we do is most of the time it is the right radial or left radial. So there is no point in getting that. And severe pulmonary artery hypertension, kindly reduce the pulmonary artery hypertension. Then you subject the patient for ECP. Pregnancy, as we know, it is totally contraindicated. So what are all the other system where we can have all this will be? So ECP I used in CVA, stroke patients we are getting, Parkinson's, Alzheimer's, because it's a very different topic. So maybe in some other lectures, I will talk about ECP in cerebrovascular accidents and Parkinson's. So last year I presented in my conference at Delhi. So it's a very good presentation and everything, because Parkinson's, whenever you give a good ECP, because ECP basically works in improvement of blood flow in kidneys, heart, eyes, and brain. So specifically, we have very good improvement in achieving CV and Parkinson, and patients with restless leg due to diabetic, it is a very good treatment. And also for erectile dysfunction, now we are on the trial. There are a lot of papers published, but still we treated for 2-3 patients, but yet to get much more results, because ED the same only with some nutraceuticals we will treat the ED also. So this is how it improves there will be a 200 meter pressure. It increases circulation of the carotid artery by 19%. When you increase the pressure of the ECP, it will be 26% in the brain, and vertebral artery, there is increase of pressure of blood flow of 12%. That is how the CVA is managed, because like the heart attack or everything, it's a brain stroke, so both the common. So here what we are doing is we are just improving the collateralization inside the brain, so it will be very useful. So there are a lot of papers with erectile dysfunction, everything. So just for your sake, I am just telling this. And in summary, so ECP is a very good non-invasive procedure where we don't use any invasive methods. It is very optional for patients. We have no option at all. And also it depends on the clinician to judge whether we have to go for ECP everything. So when you have a very severe left mind, then you don't go for any ECP therapy. Severe AR, no. And with the severe hypertension, severe arrhythmia, don't go for any ECP. Once you settle down or once you control, then everything will be okay. So thank you very much, friends, for your patient listening and everything. So thank you, Jagnany, and all others for just patient listening. So I'm just finishing my talk of ECP. It's just a basic only. So thank you very much. If there are any questions, please kindly ask. Yeah.
Thank you, sir, for the excellent section. So far, what we have gained from this session, it's like a multiple natural bypass, the important point. And number two, what you told ki, so not only it improve the coronary perfusion, unload the left ventricle, but also improve the collateral circulations. And it can improve the symptoms.
Yes.
Approximately, you told ki 35 sessions they are required.
Yes, sir. Yes, sir.
Shear stress is the important mechanism behind the angiogenesis.
Yes.
So
Yeah.
My question is, what is the cost, matlab, you think for this ECP? Maybe there is a variation and people want to know about the cost.
Yeah. Because the cost is around some 2,000 to 3,000 per sitting. So it will be coming around hardly between 75,000 to 1 lakh rupees, Indian rupees. That's all for our entire 35 sessions now. It depends on the centers. Some may be charging up to 2 lakhs also. Depends on place to place, but it starts from 70K up to 1.5 or 2 lakhs. Yeah.
Okay. So it is between 75 to 1.5 lakh rupees.
Yeah. Maybe 1 to 1.5 is the average. Yeah.
But certainly it's non-invasive technique. We ordinary people who are not getting benefit from the invasive one even, right, sir?
Yes. Because we cannot provide ECP to all the patients, but overall beneficial, we have to clinically judge them, and there are some protocols and all the studies and everything. So what we do is we will here measure their pro BNP and everything, and all the echo baseline, everything. Then after the ECP session completed after 1 month, we will recheck everything, and we found out that is there any decrease in the BNP level, then it shows that then the ECP is working good. That's how we clinically judge. But to get a new point, then we have to ask them to go for a angio or angio after 1 year. Maybe after 1 or 2 months, we can go for a stress thallium like that. So where you can hear good perfusion in the non-infracted areas. Yeah.
Thank you, Dr. Mohan. Over to Dr. Meet.
Thank you so much. That was definitely an enlightening session. With this, I request Dr. Mohan to kindly accept a token of appreciation. Also to our chairpersons, Dr. A K Singhal and Dr. Rajni Chaudhary Madam. With this, we move to our next session, for which we have Dr. K Minu Spandan. And to chair the session, we have Dr. Santosh and Dr. Hiren Mehta. So over to Dr. Hiren and Dr. Santosh.
Thank you.
Thank you so much.
Good morning. Happy Independence Day to all. So next is our topic is lifestyle medicine can make your heart fit again. Usually the most ignored thing is lifestyle changes. Am I audible?
Yeah, you are audible, Dr. Mehta.
Okay. Usually patients ask, sir, क्या दवाई लेनी है? दवाई लिख दो. No one usually asks for lifestyle changes requirement. There is a most important thing in hypertension and all other lifestyle disease. So today's our speaker is Dr. Minu Spandan. He is consultant cardiologist and lifestyle medicine advocate from Nizamabad. He is a healthcare leader at Prudent Hospital and international board certified courses also, and diploma in lifestyle medicines. Hope this session will highlight the role of lifestyle medication, lifestyle changes. Over to ma'am.
Good morning, sir. Good morning, everyone. Am I audible?
Yeah, you are audible, doctor.
Yeah.
Okay. Is my screen visible, sir? Slides? Hello, is my slides visible, sir?
Yes, visible, but
Lights are not now visible. They are not visible right now. Dr. Minu. Dr. Minu. Lights are right now not visible.
Yeah, please share it again. That's the way we will see it again.
Seems that she has lost the connection. Yeah, she's back.
Sure.
Sir, are you able to see my screen, my slides?
Yes, we can see your.
Okay, sir. I'll start. So
Yes.
the topic for today is lifestyle medicine can make your heart fit again. Okay. So first, let us see what is lifestyle medicine and how is it important for us in today's life. Lifestyle medicine is a evidence-based uh, lifestyle interventions to treat and often reverse the chronic diseases. It empowers the individuals with the knowledge and the skills to make significant changes in their daily lives. So the core advantage of this is generally when we are seeing patients in our clinic, we generally try to treat their symptoms or the direct cause like the blood clotting or the inflammation or the atherosclerosis problems. We the direct cause we are dealing with, but we always forget about the root cause which is in turn causing these problems. So this lifestyle medicine targets the root cause and not just the symptoms. Uh, it is a complementary medicine. It is not replacing the conventional medicine. We are giving the drugs. Along with that, we are trying to change their lifestyle. And this not only reverses the not only halts the atherosclerosis, but it also reverses the processes leading to atherosclerosis, and it reduces the pill burden in the patients, and in turn, which leads to reduction in the costs of medicine for the patients. And why is this important today is there are, when we come to the statistics, about 18 million deaths annually. This is the global information according to WHO 2024, and 85% of that is because of heart attack and stroke, and there is increasing number in premature CADs, like less than 50 years of age. Nowadays we see more number of patients, and in this group, it is given in a paper that 80% of the CVDs is because of bad lifestyle. And when we come to India specific statistics, CVD is the leading cause of death in India, and it is responsible for about 28% of the mortality. And there is a lot of economic burden projected by 2030. It is 2.17 trillion GDP loss because of these cardiovascular diseases. And what is lifestyle medicine? On what pillars we actually have to stress upon. Generally, when a patient comes to the clinic, we write the medicines, and then we tell them about a few points. If we are generous enough, we will take 2 minutes extra. We'll tell them about diet and physical activity, and we are stopping there. But not only diet and physical activity, we also have to see the other pillars of lifestyle medicine. First, the diet is very important. We have to advise them whole food, plant based, predominant nutrition, and regular physical activity should be there. Sleep is also very important. In the coming slides, I'll tell briefly about each pillar. Restorative sleep is very important. The stress management part is important. Avoidance of risky substances like tobacco, alcohol, and drugs, and positive social connections is also very important. We have to stress on all these 6 pillars of lifestyle medicine to change the lifestyle of a patient on the whole. And coming to the nutrition part, we should stress upon whole food and plant-based predominant diet, which can improve the LDL levels. It will improve the endothelial function, reduces the inflammatory markers, and promotes weight loss and insulin sensitivities. Few studies which are supporting this. I have for each pillar I have given one or two studies so that we can understand how important that pillar is. Ornish et al. Study has shown that the LDL levels will decrease by 37% in 1 year if the patient sticks to whole food plant-based diet. And there is also regression of stenosis, coronary artery stenosis by 2.2%. Even in the Lion Diet Heart study, there is 70% reduction in the recurrent MI with Mediterranean diets. So the key core takeaway here is food is not just for our strength, but it is atheroprotective medicine. And a plant-based predominant diet can halt the disease and also reverse the CAD progression. Next pillar is the physical activity. What is its role in reversal? It improves the vascular compliance, the cardiac output, coronary perfusion, increases the HDL levels, reduces the triglycerides, and enhances insulin sensitivity. The key studies supporting this are Harvard alumni study, which has shown that active men post MI, they have 53% lower mortality than their control groups. And another study has shown that exercise training to create power to our muscles, but also it is a and coming to the sleep, which is a very big problem nowadays. And sleep is this increases the CVD risk by 48% according to Sleep Heart Health study. So, having good sleep more than 6 hours is very important because poor sleep it causes increase in the cortisol levels, the sympathetic drive, inflammation, and also BP is also increased. And sleep apnea is directly related to endothelial dysfunction and arrhythmias. So, the core takeaway here is sleep is cardiovascular repair time, and deprivation of sleep is a silent arrhythmogen. So we have to stress upon this sleep part. We should encourage the patients to sleep more than 6 hours. That is 7 to 8 hours is the ideal time, and this will create a lot of impact on the health status of the patient. Next pillar is the stress management. In 2025, the most notorious role is played by this stress in all the CADs because it increases the catecholamine surge, inflammatory cytokines like CRP levels, interleukin 6 are increased. There is hypertension, and arrhythmia is also triggered by this by this stress. And key studies like Ornish lifestyle trial, Benson relaxation response, Blumenthal, all these have shown that the stress management plays an important role in ischemic episodes. If the stress could be managed well, then there are less anginal episodes, and even the disease can be reversed by modification of the inflammatory cytokines. So, I like this takeaway part very well because it is very well explained in this sentence. Chronic stress is like waves hitting a rock, the ocean waves hitting a rock. There, the rock doesn't break, but our heart breaks. So, the stress kills silently, and if we are able to de-stress ourselves or relaxation, this will heal the heart structurally, and it is very important to make our heart fit again. And even this has a role in reversal of CADs also. And the next most neglected pillar is we never stress upon the social connections of the patient, but this is very important because it lowers the stress hormones, improves the adherence to the medication or to the lifestyle changes. It reduces the depression in people, social isolation has been found as an independent predictor of cardiovascular mortality. And do you know that strong social ties decreases the mortality post MI by 50%. So first time when I read this, I was also surprised. But there are quite a few studies which are emphasizing on this social connections, like halt Lundstad meta-analysis, Adventist heart study, where the CVD incidence is decreased. The core takeaway here is heart health is contagious, and keep the right company to make your heart fit again. And the next pillar is avoidance of risky substances. We know about this, how tobacco and alcohol creates endothelial injury and oxidative stress in the patient. We should try to encourage the patients to stop these addictions as early as possible, because there are studies which clearly they are indicating that tobacco causes 36% of the MI risk globally, and alcohol moderation reduces the risk of arrhythmias. So the core takeaway here is every cigarette, every excessive drop of the drink undone is a plaque stabilizing agent. And the impact you can create promoting healthy lifestyles to your patients. It can cause anatomic regression, and the event rate is decreased. Primary prevention, secondary prevention, and tertiary prevention can also be done. Event reduction is clearly seen with Mediterranean and Ornish diets, and there is also mortality reduction. And we all know this. There is 50% reduction of CAD risk after cessation of smoking in 1 year, and there is survival benefits related to social connections. So, what I want to emphasize on today is not just writing the drugs to the patient, but we also should give lifestyle prescriptions to the patient, which will work as rigorously as medications. Um, and this is very important. And the greatest revolution in cardiology, I feel, is not coming from pharmacy or the labs, but it will come from our clinics, where we counsel the patients. We try to inspire them to change their lifestyle, so that the root cause of the disease is modified. And we already have good science, we already have good tools, good medicines, good techniques. But what we should give to the patient is a healthy lifestyle, which will support all these technologies, and the patient can live happily, as the root cause is mainly addressed here. So I come to the end of my presentation. Any doubts or anything, any suggestions, any discussions we can do? Am I audible?
Yeah, thank you, Dr. Minu, for highlighting that 6 pillars. Actually, we should think always about in everything before eating, before sleeping, for doing any exercise, and always think about heart. You presented very nicely. Thank you once again.
Thank you, sir.
Thank you so much, Dr. Minu. And thank you, Dr. Hiren and Dr. Santosh, for being here as chairpersons. Before we proceed, I request Dr. Minu, Dr. Santosh, and Dr. Hiren to kindly accept the certificate of faculty. With this, we move to our next session. Of course, we are running a little short of time. For the next session, we have Dr. Nishant with us, who will be talking as an FPA oration, Family Physician Association oration. To chair the session, I request Dr. Amin and Dr. Rakesh to kindly join in. Dr. Amin. Looks like I am missing him. So I request Dr. Nishant, who is a clinical cardiologist and assistant professor at Department of Preventive Oncology at Homi Bhabha Cancer Research Institute and SKM Medical College, Muzaffarpur, to talk on the topic of role of statin in breast cancer. With this, I request Dr. Nishant to kindly take over from here. And before we proceed, I request him to accept this medallion of FP oration. So over to Dr. Nishant.
So am I audible, sir? Thank you very much, sir.
Yeah.
Am I audible?
Yes, yes, Nishant.
Is my screen visible, sir?
Yeah.
Yes. Thank you very much, sir, for the opportunity. And I'm also very grateful to you for providing me the medallion. Uh, the topic of my presentation is the role of statin in breast cancer. And there's an emerging evidence here. And I was hearing both my presenter before me, the Dr. Minu, on a lifestyle management and to follow on her talk on EECP, and they are quite relevant in this topic itself. So what I am presenting is a systematic review. Now this systematic review was presented recently in a journal of internal medicine. It has been published in it's a very highly impactful journal, which has an impact factor of 9. And these were the authors from Sweden, and they have done a meta-analysis and a systematic review on topic of metabolic syndrome associated with breast cancer. And the reason I thought this presentation is important for our choosing, because in cardiovascular diseases, we often talk about metabolic syndrome. So when we talk about cancers, we generally associate with tobacco associated cancer. But it is very important for all of us to know, perhaps today in India and across the world, breast cancer is perhaps the most common cancer present. It is highly incident among women, and the incident rate is around 32 per 100,000 women. It is also, even men also get breast cancer, so there is no surprise to that. And we find there is an overarching mechanism, because we really cannot prevent breast cancer, because the mechanism of breast cancer is not tobacco related, though tobacco and alcohol have an indirect role association to it. But apart from genetics, the metabolic syndrome, obesity, central obesity, lipid metabolism has a very important role in development of breast cancer. And there is an emerging evidence that probably statins and lifestyle modification may be very helpful in patients, those who are being diagnosed with breast cancer, in fact, in prevention, and once they are diagnosed, and once they are referred for treatment. Now, most of our colleagues who do echocardiography and who see many patients in their OPD, they will get a large number of cardiology consults from oncologists, and their purpose will be mostly for evaluation of a 2D echo to just check their heart function before they start this new adjuvant chemotherapy, which has doxorubicin, which causes heart failure, which causes increased evidence of heart failure, or for pre-surgery consultation for cardiac clearance in an elderly lady, whether she is fit for surgery or not. So they should keep this in mind. Perhaps if the patient is obese, there is a room for at least lifestyle modification now. Statins, we are working on the mechanism, but we still don't know whether it is beneficial or not. Perhaps this article is providing some glimpse in the future. So, what is metabolic syndrome? Just to revise for ourselves, metabolic syndrome is a risk factors that escalates the probability of developing cardiovascular diseases and chronic diseases like myocardial infarction, stroke, type 2 diabetes, and it has been also seen to have a poor prognosis among patients who have breast cancer. Now, these risk factors encompass high blood pressure, high fasting blood sugar, and excess body fat around the waist, and abnormal lipids level. So how do we classify this into different categories? Now, when we talk about elevated waist circumference, it is population specific. In Indian population, if your waist circumference is more than 90, if you're a male, and if you're a female, and if your waist circumference is more than 85 centimeter, you are probably at risk. An elevated triglyceride level more than 150 milligram per deciliter, a reduced HDL-C level less than 40 milligram per deciliter in males and less than 50 milligram per deciliter in females, an elevated systolic blood pressure more than 130 and diastolic more than 85, an elevated glucose level more than 100, and if the HDL-C gets high density liver proteins. So now all these factors need to be present for classification of metabolic syndrome. So studies have shown women with metabolic syndromes have higher risk of developing breast cancer. Now, this is very important. As I mentioned earlier, they are also not risk of they are not only risk of developing diabetes, hypertension, but they are also the risk for development of breast cancer is also high, and they often tend to have poor prognosis. Now, why does this happen? We really do not know. But there is some evidence to this madness, and this evidence comes from the underlying mechanism. Because you see, breast cancer, even though it is preventable from the point of metabolic syndrome, but if you see the mechanism that is involved, it is the same that is involved in the development of cardiovascular diseases and diabetes and hypertension. What happens is increased obesity around the waist. It leads to insulin resistance and it leads to hyperglycemia because there is secretion of insulin-like markers. There is increased insulin in the blood. There is increased insulin-like glucose, increased growth factors because our tissues become resistant to the insulin. So because the tissues have become resistant to the insulin, the body has to secrete a large amount of insulin. And central obesity also produces a large amount of uh, markers. Now, these markers are very inflammatory in nature and they tend to increase cholesterol level, they tend to increase triglyceride level, LDL level, VLDL level, and the HDL level is reduced. And they also promote atherogenesis and they also promote invasiveness of the breast cancer. They promote angiogenesis and they promote those tumor markers which causes breast cancer. So, and once the breast cancer is when the breast cancer starts developing, they promote increased proliferation of the disease, increased invasiveness, and also increased metastasis. So the spread of cancer also becomes faster. So this is perhaps the probable mechanism what the authors have stipulated. I'm sorry, let's get my back. Yeah. Yeah. Other possible expression is because when you do breast cancer study, we generally talk for hormone receptors. Generally, we look for three hormones. We look for estrogen receptors, we look for progesterone receptors, and we look for HER2 receptors. We find because there is increased body fat, there is an increased responsibility to estrogen receptors because our estrogen in our body increases. Our fats and estradiol, it secretes a large amount of estrogen. So the estrogen receptors are increased and they also promote development of breast cancer. The excessive body fat may also create a tumor microenvironment and it potentially promotes development of breast cancer metastasis. Now, the underlying mechanism is in chronic inflammation. Basically, you must understand the whole mechanism is inflammation mediated. The role of statins or any other method is not to prevent the cholesterol level per se, but to address the inflammation. We are addressing the inflammation because there is an underlying inflammation, and that is what we see when we do the HSCRP level. We are seeing the underlying inflammation and it prevents the body from effectively combating the cancer because there is increased inflammation, our system get compromised, and there is an increase when you talk about cancer therapy. There is the role of immunotherapy or the role of T cell study or the CAR cell therapy where we strengthen our immune cells to combat cancer cells. So there our immune system gets compromised and that leads to uh, increased lipid lifestyle changes like Dr. presentation, it is very important. Regular healthy diet, physical activity. In fact, they can induce weight loss and they are also much more better in comparison. They work better for the PICO approach. PICO is a population of more than 18 years of women. All those women, those who have risk of metabolic syndrome, the comparison was the absence of metabolic syndrome, and the outcome was development of breast cancer survival, recurrence, metastasis, and death. In the secondary endpoint, they chose breast cancer mortality, and overall survival was chosen as the secondary endpoints. And there was no adequate statistical criteria because they chose all the searching literature who are present in PubMed, Scopus, Ovid literature, and also Gray literature were chosen for the study. And only English literature study articles were chosen because the systematic review it is an analysis of all the existing present data. So there were two authors who independently screened all the articles, and once the articles were screened, they segregated where the article was to be fit for the study, and there was one reviewer who, if was contacted, if there was two difference between these two reviewer, and then the data were extracted and a meta-analysis was carried out. And this is the statistical method where try to find out the just remember if the hazard ratio is more than one, that means the overall effect is positive. That means it is going to lead like this particular event, metabolic syndrome is associated with overall poor survival. So this they started with 1,019 articles and ultimately came down to 17 articles who were overall suggested who have studied on breast cancer and its effect and breast cancer and metabolic syndrome and its effects. So these 17 independent studies had a total population of around 42,135 breast cancer survivors. So you had a quite a large cohort, and this cohort had an age of 53.2 years, and they were medianly followed up for 23 months to 278 months. That is from around 2 3 years to around 10 years, which an average follow of around 94 months. That's around near about 6.5 7 years they have followed up all these patients. So what this overall study said, all this overall study said poor survival was noted among breast cancer survivors who had metabolic syndrome. Or if you see the pool data analysis, the graph is towards the right hand side of the screen. That means its overall effect is 1.5 times. That means people, those who have metabolic syndrome, have 57% more likely to die because of other complication. Either their breast cancer will reoccur or they will have a cardiovascular event, but the mortality among breast cancer patients is 57% higher those who are with metabolic syndrome. Similarly, women with metabolic syndrome, they have higher risk of reoccurrence of the disease. That means if 69% of women with breast cancer will higher chance of recurrence of the disease if they are having metabolic syndrome. So they have poor survival. They also have increased risk of recurrence. Okay. The overall mortality is higher 83 times. That means 83% of women, those who have metabolic syndrome, will have 83% higher probability of dying because of breast cancer than compared to their counterparts who do not have metabolic syndrome. So that idea is if there are for every one woman who die for every child, suppose there are two women, and if there's a cohort of there are 100 cohort of women, and there's one woman who are dying in who do not have metabolic syndrome, 83 women will die in a cohort of women those who have metabolic syndrome. The chances are 83 times higher, 83% higher actually. Uh, the overall survival is poorer in patient in 79% poorer in those with metabolic syndrome. So the underlying discussion was women living with metabolic syndrome and concurrently diagnosed with breast cancer have higher risk of recurrence from death and other breast cancer diseases. Metabolic syndrome women are 57 more likely to experience breast cancer related events during follow-up. 69% are more susceptible to recurrence and 83% are more likely to die. The increasing worldwide incidence of prevalence of obesity, diabetes, cardiovascular disease, and growing number of cancer survivors. Now, remember, if the woman doesn't die because of breast cancer, these women, the second most commonest cause is the cardiovascular mortality, and that happens to be the coronary artery disease. So, if they survive the breast cancer, their risk of delivering cardiovascular mortality is again very high. So, if you have any patient who has metabolic syndrome, who has diabetes, who has hypertension, and if she has survived breast cancer, then the thing you must be looking after is cardiovascular mortality. A less favorable prognosis of breast cancer, struggling concurrent disease, dyslipidemia, and diabetes. Now, currently, there are no guidelines. What should we do for this group of patients? For this group of patients, should we give them statin? Should we give them aspirin or clopidogrel or any kind of medication which is aimed at primary prevention, especially statin? There is currently no guideline. None of the clinical trials or randomized control trials have mentioned about the role of statins in patients with breast cancer. Though they advocate for lifestyle management and an enriched diet of fruits, vegetable, whole grain, lean meat, regular exercise. But till now, we do not have any guidelines or which talks about the use of statin. Now we know statins have been effective, have an anti-thrombogenic effect, and it is important for us to investigate this area. So we want long-term longitudinal studies to evaluate the long-term effect of metabolic syndrome and breast cancer patient overall survival. Now we need to conduct randomized control trial to conduct the specific intervention of the dosing of the statin we need, and what is it beneficial or not. We also need to see whether already the patient who are already stretched because of their cost of cancer therapy with addition cost of statin with metabolic syndrome may probably increase their budget too. Now, this is the study that has been proposed. The similar authors have proposed a study which is called the MASTER trial, and this is a very important phase 3 clinical trial, and which they are using the standard neoadjuvant chemotherapy with rosuvastatin. That means in one group of women, they are giving the neoadjuvant chemotherapy before the breast cancer surgery starts. The woman is supposed to receive a dose of chemotherapy. So in one group, they are giving only the standard neoadjuvant chemotherapy, and in one group, they are giving neoadjuvant chemotherapy plus atorvastatin of 80 milligrams per day, and they are following up the woman for 2 years. And the other group, once they have completed the therapy, they are giving adjuvant chemotherapy with there are two types of chemotherapy. One chemotherapy is given before the surgery, and one chemotherapy is given after the surgery. So in one group, they are giving it to women, those who are given neoadjuvant chemotherapy, and we are giving them with the atorvastatin 80 milligram. In the other group, they are given after the surgery has been gone, and they are supposed they are planned for chemotherapy. They are giving them 80 milligram adjuvant chemotherapy with 80 mg of atorvastatin to check whether the overall survival improves in any of the groups with the standard treatment. And that is they are comparing with the placebo treatment in other arm. So in conclusion, overall breast cancer survivors, metabolic syndrome is associated with poorer outcomes with breast cancer. The findings of this study emphasize the importance of metabolic screening in all the breast cancer survivors. And in fact, all the patients, those who are referred, for just for echocardiography of a clearance for being provided the chemotherapy drugs is important. As a primary physician and clinical physicians, we should screen them for metabolic syndrome and ensure our oncologist persons are advised if these patients probably would require a lifestyle modification as of now. But if the trial is positive, we may prescribe them also statin for increasing their overall survival and also preventing cardiovascular mortality in them. These are my references. I thank you very much for your patient hearing. Yeah.
Thank you so much, Nishant, for the wonderful presentation. Very rightly said that if there is a cancer survivor, the next big risk factor will be cardiovascular risk factor, and statins will definitely play an important role in that situation. Any questions for Dr. Nishant? So I guess your presentation was so lucid that people agree with your presentation. So kindly accept the medallion and the certificate. Also thanking my chairpersons. With that, we move to our next session, for which we have Dr. Prakash Bhushan Karn from USA for the presentation. And to chair the session, we have Dr. A.G. Pillai and Dr. Anirban Bhaumik from Bangalore and Faridabad, respectively. Over to Dr. A.G. Pillai and Anirban. Dr. A.G. Pillai, Dr. Anirban.
Hello.
Yeah.
Yeah, am I audible?
Yeah, you are audible, Dr.
Yeah. Good morning, friends. And first of all, it's a very, yeah. So good morning, friends. First of all, today is Independence Day, so wish you all a very happy Independence Day. And now we move to our next session, which is given by Dr. Prakash Bhushan. He practiced in Virginia. And the topic is mental severe health and comorbidity condition as behavior cardiology. As we all know, in the present situation, youth and everyone is in a stressed life, and mental health is very, very important. The moment we are not having a good mental health, we have an anxiety problem, and there is an increase in cortisol level, increase in heart rate, increase in inflammation, which leads to the cardiovascular disease. So mental health is very important. So let's listen, Dr. Prakash Bhushan, what do you want to say in this lecture? Please, Dr. Prakash.
Thank you, Dr. Pillai, and thank you, Dr. Bhaumik. Also, happy Independence Day, everyone. I'm hoping that I'm sharing the right one. And can you hear me all?
Yeah.
Okay, so my name is Dr. Prakash Karn. I'm one of the psychiatrists practicing in Virginia. I would like to say Happy Independence Day to everyone, as well as I would like to take this opportunity to thank Dr. V K Jagnany for giving me this opportunity to talk to my esteemed colleagues, cardiologists. As Dr. Pillai also said, and that it's very important, both mental health and cardiovascular health go side by side. So I have a lot of slides, but I'm not going to bore you with all those slides, but I would want, as a cardiologist, to get some of the finer details so that that will help you in your practice and in dealing with people with mental illness or people who develop signs of mental illness after a cardiovascular events. So as we all know, there is a heart-mind connection, dil or dimag. We all talk about this, not in the poetic sense, but in more like in our jargon, because cardiovascular health and psychiatric illness, I consider them as bidirectional. Mental health, people with mental health are at increased risk of cardiovascular disease due to behavioral, physiological, genetic factors. And also, people with cardiovascular disease, they also are at increased risk of having mental health issues like anxiety, depression, post traumatic stress disorder. So, if we can approach, as a cardiologist, if we can approach and have a little bit of more tools to help, that is going to help you in your practice as well. I said there's a risk factor for cardiovascular and mental health. I think I think my colleagues have already talked about it, but I'll just quickly go. As I said, smoking, poor diet, physical inactivities, and medication non-adherence is common reasons for that. Um, and that can increase your cardiovascular risk. Genetic as well as physiological, like chronic stress and mental health, can lead to inflammation, just like Dr. Pillai just talked about it. So, as a cardiologist, what you want from us. But before that, I just wanted to take a little bit more time about like what are the things you're looking for as from mental health perspective. People with cardiovascular events are at increased risk of having depression, anxiety, post-traumatic stress disorder, and also you will be dealing with a lot of people with like delirium. You'll be dealing with people with substance abuse who either have problems, cardiovascular problems. And so, how you can approach those people is what I wanted to just stress upon. So that's why, like, if you have some tools like screening tools, which you can use in your general day to day, and I know that you all are very, very busy, but if you can spend even like 5 minutes out of that, then I think that is going to help uh, your patient as well as you in dealing with and reducing the amount of work you have to do. So screening can be done in different ways. One is called as proactive screening, where like you can do a regular mental health assessment. And I'll stress upon the screening tools for depression and anxiety a little bit more later. And obviously, collaborative care is like more about like how do you collaborate between cardiology and psychiatry or mental health practitioners in your area. So before, I mean, if you, as a cardiologist, obviously we all have a, like a general loose term for depression, anxiety, post-traumatic stress disorder. But if you can use some of these screening questionnaires, then it's going to do a lot of help for you as well as for your patients. So one of them is called as PHQ-9, which is a patient health questionnaire. This consists of 9 items, and this is for basically for depression screening. And as you can see that they rate the frequency of each symptoms over the past 2 weeks. So this is just a snapshot of that one, like little interest or pleasure in doing things, feeling down, depressed, or hopeless, things like that. You can see there is a score underneath it. I would suggest, like, if you can give it to the patient also to kind of like score themselves, or if you have people in the intake or in the hospital, they can also do these ones. So it's like very simple, easy way of kind of getting an idea of people with depression in general. And if they do score more than 10 or more, then it needs a little bit more screening. But if they are 15 or more, then I would suggest that that's the time when you may need to talk to a psychiatrist for a consult. Obviously, severe depression will be another one. So the second one is the generalized anxiety disorder scale, and that is also very small. I think both the screening tools are like will take you less than 5 minutes to render them to your patients, and that's why I'm using these two in my topic of discussion. And you can see the questions are very simple, like feeling nervous, anxious, or on an edge, not being able to stop or control worrying, being so restless that it is hard to sit still, trouble relaxing, and they have rated it. So similar in this condition also, you can see the if it's more than 10, that's causes like moderate anxiety. Severe anxiety is like more than 15. Um, and this is just like a example of this. We can see that in this case, the person scored like a score of 9. So what you can do is, like, since this does not go beyond, like it's a mild anxiety, best to practice breathing exercise when feeling anxious. So just an idea of that. So that's what I was just talking about, how to interpret the results. Like if you have a PHQ score of more than 12, it's like you can start medications, or you can look into like referring the patients. And same with the generalized anxiety disorder, you can refer them for either for relaxation exercises or like stress management techniques or counseling and medication management also sometimes. So cardiologist-led mental health screening protocol is going to help because you are the first point of contact, and you will be able to look the first time how they are like. So the symptoms presentation will be with you. We as psychiatrists see them when they are like more severe. So many patients do get kind of like um, don't get those kinds of treatment, and then that can affect the outcomes for cardiologists or cardiovascular treatments. So when to screen? You can screen for the initial consultations, at follow-up visits, during routine checkups, and as I said, PHQ-9 and GAD-7, which is a generalized anxiety disorder, are like good small, like short tools to help you. Um, and then you can do it after a cardiovascular event screening. As I said, sometimes they may have like a heightened triggers because soon after a cardiovascular event like a MI or other events like a hypertensive emergencies, patients may have increased anxiety. So you have to be a little bit careful about when to start the screening. I would suggest to do the screening after a month when they are like post-op or post follow-up, like in a month, rather than just doing it immediately after that. It's not a bad idea to keep it in mind. And one thing after the cardiovascular event is what we call as like post-traumatic stress disorder or trauma, because it is like a trauma for them. It's kind of like the whole life has been upside down for them. So there will be a lot of like flashbacks, events from the past, which keeps reoccurring, and it can change from acute stress reaction to what we call as a post-traumatic stress disorder in a month's time or more, because they will start having, and that can really affect the way you will treat the patient. As I said, sometimes you're giving medications and they're not getting better. Yes, they're still having those increase like chest pains or anxiety attacks, which may mimic as cardiovascular symptoms. So that can also help cardiologists deal with or like take care of these symptoms in a well-mannered way. And as I said, you can do it as part of the rehabilitation because you can work with psychologists or counselor to provide on-site mental health support or offer group therapy sessions. And obviously, who are you screening for the high-risk populations with so who are these high-risk populations? The populations I'm thinking of is the history of psychiatric illness, patient with poor adherence to treatment plans, patient reporting high levels of stress, sleep disturbance, or significant life changes. As I said, there is a strong connection between people with depression, anxiety, mental health, schizophrenia, all of them having increased risk of cardiovascular uh, uh, conditions, and vice versa. People with cardiovascular condition have increased risk of having depression and anxiety as well. So as I said, I'm keep stressing on the same thing of using the screening tools and and taking that as one of the main point of this topic of discussion. I said I'm just scrolling through some of the things, but I just wanted to prove my point about screening is important. Early detection can help you improve outcomes. And also, you're providing a holistic care. I think Dr. Spandan gave a talk just before, which kind of helps me a lot because that also emphasizes on the lifestyle changes, and I'll go on that quickly later on. There are some of the medications which, as a cardiologist or a primary care doctor, can also use as an initial treatment. I will go very quickly on that because sometimes some of the doctors are comfortable using them, some of them are not. But the common ones are the antidepressants like SSRIs, some of them are SNRIs. As long as you understand some of the interactions with the cardiovascular medications and which causes QT prolongations and stuff like that, then I think um, most of people here, when I see them, either a primary care doctor or a cardiologist, have started them on a low dose of antidepressants, and they came to us when they are like when they're severely depressed. So it's not inappropriate for cardiologists also to look at some of these medications. As I said, common ones are the antidepressants, like on this slide. Then there are some anxiolytics. Obviously, you have to be cautious with the benzodiazepines like alprazolam and lorazepam because sometimes they can increase the risk of sedation, respiratory depression, and dependency also. But buspirone is another one. And then mood stabilizer. There's a tons of mood stabilizers. So I'm not going into the details. I'm just giving a snippet of it. Like these are the medications sometimes as a general as cardiologist you can look into. Obviously, for complex cases, it's always better to get consults from a psychiatrist so that both psychiatrists and cardiologists can together work to get a better outcome for their patients. And obviously, this is going just through the side effects of the psychiatric medications. As I said, there's a lot of slides. I don't want to bore you with all of them, but yes, it just gives an idea of like where to look for things which can help you in your practice. I'm practicing here not only in outpatient clinic but also in normal big specialties hospitals where we get consulted all the time. So usually I see patients on the cardiac units and so this is what I was coming to when to consult a psychiatrist in cardiac patients. The first one is definitely very simple, straightforward, is a severe depression. So what are the things you're looking for? Like persistent sadness, hopelessness, loss of interest in activities for more than 2 weeks. Also, difficulty concentrating, fatigue, or changes in appetite and sleep patterns. If you see these red flags, including suicidal thoughts or behavior, then it's time that you should talk to a cardiologist, the psychiatrist for a consult. And why is it important? Because depression is common in cardiac patients, especially after events like heart attack or surgeries. This can also worsen the cardiovascular outcomes. And then other is anxiety disorder, which can affect your cardiac conditions. Signs to look out for is excessive worries, restlessness, or panic attacks that interfere with daily life. Physical symptoms like chest tightness, rapid heartbeats, or shortness of breath unrelated to cardiac pathology. There's a lot of studies which suggest that anxiety and cardiovascular, there's a 21% increased risk. So anxiety is always going to be very, very common in both the conditions, and also can confuse cardiologists as well as psychiatrists also, as because when it is chest pain and when it is anxiety, we get these consults all the time. So if we can look a little bit more with some of those screening tools, that can also help you kind of like filter out some of those cases. And as I said, it's like a psychiatrist can provide targeted treatment like cognitive behavioral therapy or prescribe the medications. But for cardiologists, it will also exacerbate their cardiac symptoms. And just like Dr. Pillai also said before. The third one I want to talk about was the post-traumatic stress disorder. As I said, not only like abuse or some kind of war zones can cause you a post-traumatic stress disorder. Any kind of significant trauma in your life and having a big cardiovascular event is a big trauma for patients. So that should also be taken into account by people who are treating these patients, because that can affect their outcomes. Signs to look out for is like flashbacks, nightmares, intrusive thoughts about the event, avoidance of medical care or reminders of the event, then hypervigilance or exaggerated startle response. These are all kind of some of the signs you should be looking for. Sometimes we are very dismissive when they are avoiding medical care, but if we can ask few more questions, they may be able to give you a little bit more insight into their mental health, and that can help you, the outcome of the case. As I said, PTSD can lead to poor adherence to treatment and avoidance of necessary follow-ups. And delirium, I'm sure you guys are seeing all these people in the ICU after a cardiac surgery. We are also called sometimes for that because of the delirium with psychosis, hallucinations. Take home message for these patients will be like using antipsychotics. Usually they use, or anxiolytic they use, which have least amount of QTC prolongations. Haldol, if you're using IM, that's fine. If you're using haloperidol as an IV, be careful because that can prolong QTC. There are some other which has least propensity to cause QTC prolongations, so that can be used in the ICU setting. Same with the anxiolytics. It's kind of like a double-edged sword. It can help calm down patients, but at the same time can cause more confusion or like so that's another things about that. So obviously, we also get consulted for people who are non-adherents, like they are taking medications or not taking medications, not attending follow-ups, or making the changes which you would expect them to make. And that's where spending a little bit more time will help you understand the psych behind. And as I said, if we can treat those underlying mental health, then there is a high chance that their quality of life will improve. And I think when Dr. Spandan talked about those pillars of lifestyle changes, and 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 she has already explained, so I don't want to go into the details again, but that's also going to improve performance as well as quality of life. Another one is, as I said, substance use disorder, alcohol, drug use. I see a lot of patients who are using cocaine, methamphetamines, coming with like cardiac issues and withdrawing from the symptoms during hospitalizations. If the cardiologists are aware of, I'm sure I don't have to go into details about it. You guys manage these patients day in and day out. Obviously, psychiatrist comes into the picture for detoxification, support, therapy groups, long-term management plans. And yes, most important one is the suicidal ideations or self-harm. That's the most important thing because people have this feeling of hopelessness, worthlessness, helplessness, and they want to die. That's needs to be taken care of immediately. They require immediate psychiatric interventions to ensure safety and provide crisis management. Um, I will just skip through these ones. These are the same things which we talked about. What we do as psychiatrists, and I'm sure that psychiatrists in the areas also manage the same way: a comprehensive assessment, medication management, psychotherapy, and collaborative care, where like they can talk to the cardiologist and the primary care providers and come up with a whole holistic plan, and that can help the patients. I will also skip through this one because we have already talked about and emphasized on the screening tools like the PHQ-9 and the GAD-7 during the routine cardiac visits. Sometimes it's not feasible because you guys are seeing a lot of people, a lot of patients, but if they can be given these questionnaires, which they can fill, and they can bring it to you and you can just have like a quick look at it and see, okay, this 10 or more, then it needs a little bit more. Even that can also help you in your practice a lot. And then you can also be able to identify these high risk patients with recent cardiac events, chronic heart failures, things like that. And then again, the red flags are again severe depression or anxiety, suicidal ideation, self harm behaviors, significant symptoms of PTSD after a cardiac event, delirium, and the substance abuse. I have already touched on these ones. And I think I have already talked about these, about when to refer them to a psychiatry and develop a shared care plan and coordinate medication management. And it's important because some of the cardiac medications and the psychiatric medications can interact. And so, for example, common ones is SSRIs with anticoagulants like warfarins and stuff, and making sure that there are some psychiatric medication which can cause QTC prolongations and increases the risk of cardiac complications. Same things I'm repeating, collaborating on lifestyle intervention, provide patient educations. These are all which we just talked about. Monitoring and follow up. So you can use these screening tools like every few months just to gauge whether they're getting better. And you can also see that there may be a cardiac outcomes improves or not. And then you can modify the treatment accordingly. Obviously, we have already touched on these ones: delirium, suicidal ideation, substance abuse. Um, this is, I think, 1, 2, 3, 4, 5. I think I have few less than Dr. Spandan's 6 pillars of lifestyle changes, but stressing the fact that these things also improves mental health as well as heart health. Regular exercise, healthy diet, stress management, quality sleep, quit smoking, and limit alcohol. And I'm sure that this will get repeated throughout the day. Um, I have added some of the mental health support helpline on this slide. And anyone who is interested in having these slides, I will I will send it to Dr. V Jagnany for that. And these are only few of them where like they can get mental health support. But in your areas, there can be hospitals where you can do consultations. There are outpatient referrals you can do. There are some district mental health programs and services which also you can refer the patients to. Here, what they do is like in US, where I'm working, is like we are already providing support and we go as a consult. So I'm sure that there will be outpatient private practice as well as hospital-based psychiatrists as well who can be pooled into for to help you with the consultations. Um, I also found this PHQ-9 in Hindi, so I thought I'll just put it in just for the sake, like it should not be for people only who can understand English, but and I'm sure that this also comes into like different languages and can be modified, and this is similar. So the take-home message is maybe spend a little bit time 5 to 10 minutes, because these two can take less than 10 minutes for sure, because we do it day in, day out. And that can help. And that can definitely help, with your outcome for the patients. And thank you, everyone, for listening. I know there were a lot of things and I was breezing through them, but the take home message was like, if you get the connection between the heart and the mind and the importance of mental health for your cardiac patients, and do a little bit of screening and seek help when you need it, I'm sure that initial, like mild, moderate cases, you also can manage with some of the medications. And I think that will be the take home message for today. Thank you very much.
Thank you. Thank you, Dr. Prakash. It was a wonderful talk, and you touched almost everything which is needed. And in nowadays practice, we see a lot of patients. They come with a atypical chest pain, palpitation, anxiety disorder. So definitely we need, and it will really help that PHQ-9 and CAD-7. So we will try to use this in our day-to-day practice, and definitely it will help. And once again, thank you. And if anyone have any queries, please, you can ask. It seems no one has any query because you has elaborated the thing very nicely. So thank you, Dr. Prakash. We can move to another lecture. Thank you.
Yeah. Thank you. Thank you so much, Dr. Prakash. Thank you, Dr. AG and Dr. Anirban for being here. With this, we move to our next session. And before that, we request chairpersons and speaker to kindly accept the certificate. For the next session, we have a renowned cardiologist and electrophysiologist with us, Dr. Shomu Bohora. And to chair the session, we have Dr. Tanvi Patel and Dr. Alka Goel. So he will be the star speaker for the session. So over to Dr. Tanvi Patel.
Good morning, everyone. I'm Dr. Tanvi Patel. I'm working as a non-intervention cardiologist in Vadodara, Gujarat. Talking about Dr. Shomu Bohora. Shomu Bohora is a senior consultant interventional cardiologist and electrophysiologist, UN Mehta Institute of Cardiology and Research Center, Ahmedabad. He is also associated editor IPEJ. He's an author in ECG EP study. There are many publications also. He's a star speaker. He will talk with us about ECG of ventricular tachycardia. Over to you, sir, Dr. Shomu Bohora.
Medallion for Dr. Shomu, sir. Over to you, Dr. Shomu.
Thank you so much. Thank you for the invite. I'm honored to be here speaking on Independence Day and wishing everyone the same. Before I go to my topic, I would also thank the organizers to have me here. I'll start my presentation. Is the presentation seen? Hello?
Yeah, it's visible.
Yeah. Okay. So my topic is ECG diagnosis of ventricular tachycardia, and what is in store as of now is to diagnose it appropriately so as to treat them. So the outline of the talk would be why VT is important, what are the types, the basics of ventricular tachycardia on ECG, the algorithms that are used in clinical practice, and some case examples, and what you should do if you find that broad complex tachycardia, and we'll summarize it. So in the next 20 minutes we'll start with diagnosing ventricular tachycardia. The definition is a heart rate being more than 100 beats per minute, which originates from the ventricles. And ECG generally shows it to be a broad complex rhythm. The importance of ventricular tachycardia is generally it is associated with structural heart disease and can lead to hemodynamic instability, but it is not necessary though. And there is a potential risk of sudden cardiac arrest as compared to patients who have SVT. So going on to the types, you have monomorphic ventricular tachycardia, which can be a right bundle branch block or left bundle branch block morphology. And the QRS morphology are the same. Generally, they are very regular of a monomorphic VT as compared to a polymorphic VT with two or more different ventricular morphologies, and it generally presents with a chaotic electrical activity with multiple simultaneous wavefronts. And if it is associated with normal QT, it's a polymorphic VT, idiopathic. If it is a long QT related, it becomes a torsades. The other types would be bundle branch reentry VT, which occurs from the bundle branch, and accelerated idioventricular rate rhythm, which generally occurs post MI with a heart rate of 50 to 120. So what is a non-sustained VT? Generally, if you have 3 ventricular beats or more at a rate of more than 100 but last less than 30 seconds without any hemodynamic compromise, it is non-sustained VT. For a sustained VT, the duration should be more than 30 seconds, and hemodynamic compromise, if it is there, less than 30 seconds, you have to cardiovert, then it is a sustained VT. Bundle branch reentry VT, as described.
Sorry to interrupt, sir.
Yeah.
Sir,
Yeah.
your slide is not moving, sir.
Okay. So I'll be going this way. Is it seen now?
Yeah, yes.
Yeah.
By
I'll
the
be
way, it's
putting
not...
on this one.
Okay.
Kindly put it on the full
Yeah, I
screen.
had put it on the full screen, but it's not
But
coming.
it is not
So
showing.
let it be this way only. If it is
Yes.
showing this way, it's fine.
Okay.
So broad complex QRS rhythm is generally monomorphic or polymorphic, as we discussed, and the ventricular rate, if it is more than atrial rate, this is the basic that we have to see. The AV dissociation may not be there. So this is the diagnostic feature of a ventricular tachycardia. A non-typical left bundle branch block or a right bundle branch block, or a patient who has a QRS, which is initial part fractionated more as compared to the later half, or the QRS is very wide, more than 160 millisecond. If you have a concordant pattern with all QRS being either positive or negative, and the axis is either northwest or with left bundle branch block or with right axis deviation, or right bundle branch block with left axis deviation, that is when you get to diagnose a VT. So using this as a basic, I'll describe further. So let us see this. AV dissociation, if it is there, it's always a VT unless proved otherwise, where the ventricular rate is more than atrial rate. If you have a bundle branch block, you decide that it is a non-RBBB LBBB type typical. So how do you decide that? Is if you have in a RBBB morphology, a monophasic R or a QR pattern or a left side taller than the right side, that is called a rabbit ear, is considered in V1 as a ventricular tachycardia. In V6, if you have a deep S wave or a QS pattern or a monophasic R, again it is considered to be VT as compared to the SVT criteria. In a LBBB pattern, if the initial R is more than 30 milliseconds or the onset to the nadir is more than 60 milliseconds with a notching in the downslope of the QRS, is suggestive of a ventricular tachycardia. In V6, if you have a QR pattern or a QS pattern, it's generally a ventricular tachycardia based on ECG, and we'll see with examples. If you have a QRS duration of more than 160, either RBBB, LBBB, it's suggestive of a VT. But if in RBBB, it is more than 140 milliseconds, again suggests to be a ventricular tachycardia. If you have a northwest axis, generally SVT with aberrancy will not have a northwest axis. It's generally a VT. RBBB left axis or LBBB right axis, again a ventricular tachycardia. So if this is a typical example of a broad complex rhythm, and you should see the lead V1 wherein the P wave is the best. If you see that the P waves are there, and that can be seen as bumps which are not there in all QRS complexes as marked by arrows here. If the P wave is lesser than the QRS, so here there are 2 P waves, 3 P waves seen as compared to 8 QRS complexes. The QRS complexes are more than the P waves, it's a ventricular tachycardia. Even if you have 1-to-1 P wave, that is a broad complex rhythm, and a 1-to-1 P wave that is seen, sometimes taking a ECG again or giving medication like adenosine can cause a VA dissociation, and this area where the arrow is there, the P wave is not seen, and therefore now the QRS is more than the P waves. And this occurs because of VA conduction. And if you find this, it's again an indication of a ventricular tachycardia. The typical AV dissociation, second part would be a capture beat and a fusion beat. So what is a capture beat? It is also called a Dressler's beat, wherein the QRS complex during a wide complex tachycardia is identical to the sinus QRS complex. And as seen here, it is narrow. There is a preceding P wave before it, and the capture denotes that it's the normal conduction system that has momentarily captured the ongoing ventricular activation or the VT focus. You also have a fusion beat. It's a combination of the sinus beat or a fusion beat. So what you see here is a fusion beat wherein it is somewhat broad in between the capture and the ventricular tachycardia beat, and it is basically comes earlier than the preceding QRS. So these AV dissociation features would be P waves less than QRS, a fusion beat, and a capture beat. As in this rhythm strip, you can see all of them. So ideally for these, you should take a long rhythm strip and see the features there. We have described this QRS morphology with a non-typical bundle branch block. Typical bundle branch block, you should know that it is in a LBBB, it's an RS complex in V1 and no Q in V6, while in a RBBB, it is RSR dash, the typical R dash being more taller than the initial one, with S less than R in V6. So here is an example where you have an RBBB, you have a first beat which is marked by an arrow, which shows a RSR dash, R taller initial later on, while in a VT, you have an initial R which is taller than the later R. So initial spread of impulse is lower than the later because it's a myocardial origin. The circuit occurs from the ventricular area, and therefore it is muscle to muscle conduction, and therefore the initial part of the QRS will be slurred as compared to the terminal half. While in bundle branch, what will happen is bundle branch block, one bundle is blocked, but the other bundle is still conducting. So the initial part will be more sharper as compared to the terminal half, because the terminal half is conducted slower in the ventricle. So if you have an initial slur as seen by an initial R of more than 30 or R2S more than 60, Brugada sign being more than 100, then it is considered to be as a ventricular tachycardia, and the Joseph sign mentioned is a notch in the downslope of V1, V2. So if you have a QRS duration which is more, that again shows that this is a slow conduction in the ventricular myocardium, a LBBB more than 160 or a RBBB more than 140 milliseconds, with the other typical features of bundle branch block, as you can see in V1 also, initial more taller than the later half. What is concordance? So concordance is seen in V1 to V6. If you have a negative V1 to V6 totally, that is called negative concordance. It is more specific. Or if you have a positive V1 to V6 without any QR complex or an RS complex, then it is called a concordant pattern. So V1 to V6 positive or negative suggests concordance is a VT. About the QRS axis, if only AVR is positive and the rest limb leads are negative, it's a northwest axis, suggests to be a ventricular tachycardia. So if you have to see only one lead, then AVR is the lead to see, and there are criteria for that to diagnose a ventricular tachycardia. Additional diagnostic features would mean that if you have multiple morphologies of a broad complex rhythm, it can only occur because of a ventricular tachycardia, not because of aberrancy. If the ventricular tachycardia starts with the QRS complex, if you have the initiation of a broad complex rhythm and it's a QRS complex that starts, it has to be a VT. If this is called an incessant NSVT, short runs of ventricular tachycardia occurring less than 30 seconds, it's a non-sustained VT. Additional diagnostic features, especially if you have a prior ECG. So if you have a prior ECG of a bundle branch block, structural heart disease, pre-excitation, or a prior MI, or even a normal ECG, it helps to bring out the diagnosis. And a rhythm strip is very important. So here is a patient who has broad complex tachycardia considered as a VT, but if you see a sinus rhythm ECG, it's the same as compared to the broad complex rhythm ECG, and you can subtle see a P wave likely to be a sinus tachycardia only. Whereas this patient has a RBBB left axis broad complex rhythm, again diagnosed to be a VT. But if you see this rhythm strip here, it is irregularly irregular, and a baseline also has a RBBB left axis. Again, thinking that this is likely to be an AF with aberrancy. So if you have a broad complex rhythm with 1:1 conduction, you might think this is an aberrancy. But if you have a baseline ECG which shows abnormal QRS complexes like this in patient with epsilon waves ARVC, and this V becomes likely a VT. So baseline ECG is very important. Again, a positive concordant, so I would have diagnosed it to be a VT, broad complex in V1 to V6. But if you see the baseline sinus rhythm, there is presence of pre-excitation, short PR interval, delta wave, and this becomes likely to be a antidromic tachycardia rather than a VT. If you have a rhythm strip, a broad complex initially and a narrow complex occurring at the same time, then this is likely to be aberrant conduction rather than a VT. So regular tachycardia is generally seen in a monomorphic. The variation is less than 10% most of the time. So if you have an irregular monomorphic tachycardia, it becomes more likely to be atrial fibrillation rather than a VT. So here, generally these VTs, broad complex rhythms, are very regular, except some beats which are irregular. But if you have an irregular rhythm as seen in this patient, it's more likely to be atrial fibrillation because this is monomorphic in nature. And if it is very broad, very fast, that is called FBI, fast, broad, irregular, it becomes AFWPW. So why do you need to diagnose well? Because ECG for a broad complex can represent a wide complex QRS bundle branch aberrancy, wide complex QRS pre-excitation, a ventricular tachycardia, or a bundle branch re-entry. So all SVTs and VTs can be broad complex, and therefore the treatment is different. So this is a synopsis that what I have said: broad complex rhythm SVT versus VT on ECG. And the most important point is AV dissociation. Then you see typical or atypical bundle branch block. You see the QRS axis, and if it is northwest, likely to be a VT. If the QRS duration is more than 160, likely to be a VT. Concordant pattern suggests a VT. Irregularity in a monomorphic suggests it's an AF WPW. And if it is irregularly irregular but polymorphic, then it is likely to be a polymorphic VT. Onset with the QRS is a VT, and compare it with the sinus rhythm. So this is a synopsis of the thing. So what are the algorithms to use to diagnose? The first algorithm is the Verikes algorithm. AV dissociation, if it is present, then it is a VT. Initial R in AVR, that is a northwest axis, again a VT. Non-typical bundle branch block, VT, and initial slur is lesser as compared to the later slur, then it is likely to be SVT versus a VT. Brugada has the same algorithm. Absence of RS means concordance. Initial slur versus later slur, that is the RS more than 100 millisecond initially. AV dissociation and morphological criteria of a bundle branch considers. So there are many criteria, but I would highlight this lead AVR algorithm, where if you have a dominant R in AVR, this is only one lead criteria. So if you see AVR positive, it's a VT. Initial R wave is more than 40 millisecond, or even if you have a Q, if it is more than 40 millisecond, or a deep negative notched initial QRS complex in a AVR, then it's likely to be a ventricular tachycardia. So this AVR algorithm can give you a clue based on only a single lead. So if you use this criteria, even if you have a 1:1 in AVR, you can see initial R wave only in AVR, and therefore it's a ventricular tachycardia. So there is a VT scoring system also. I'll not go into that detail. So let us see some case examples, ECG typical and atypical. And if you see here, C in V1, C in inferior leads, and if you see P waves which are less than QRS, it is likely to be a VT. Again, here AVR is positive. You have a RBBB left axis deviation, and therefore a non-typical bundle branch block QR pattern in left, right. So all these criteria suggest it to be a ventricular tachycardia. Some atypical ECGs, like a somewhat narrow RBBB left axis, a fascicular VT, a patient who has LV dysfunction, LBBB or RBBB baseline, and you have a morphology of tachycardia similar as QRS complex, you might be tempted to think it is to be SVT with aberrancy. But if you see this, there is AV dissociation and it can be a bundle branch reentry VT. RVOT VT considers LBBB with inferior axis, while LBBB with inferior axis is a LVOT VT. AIVR occurs generally in acute MI settings, heart rates of 50 to 120, and these patients are generally because of revascularization. Rarely you will have a narrow complex rhythm with AV dissociation. And remember, if you have a baseline broad complex in this, so baseline there was left bundle branch block and the tachycardia is narrow complex, it has to be a VT because SVT with aberrancy will present with the same aberrancy of the baseline ECG. Ventricular fibrillation at 12 lead ECG should never be taken. The patient is hemodynamically unstable and therefore have to be cardioverted. If you have a long QT syndrome with this torsades, a polymorphic turning around the axis pattern, it is torsades. While if you have a normal QT and you have a polymorphic VT, this is a typical idiopathic ventricular tachycardia. A bidirectional ventricular tachycardia occurs in CPVT and is diagnostic of either digoxin toxicity or CPVT. In a Holter recording or sometimes on ECG, you will have these artifacts and you will be tempted to think it is to be a ventricular tachycardia. But if you have this ECG, a single lead which shows a normal QRS morphology, this is likely to be an artifact. So be aware, especially in ICU settings, that you may be dealing with artifacts also. Lastly, in era of pacemakers, you have a pacemaker mediated rhythm which can present as a tachycardia itself. So remember, VT accounts for 80% of broad complex in unselected population and 95% of patients having prior myocardial infarction. So making a presumptive diagnosis of VT is always better than SVT with aberrancy. Treatment of SVT as if it was a VT is also safe, but the opposite is not true. And remember that presence of hemodynamic stability is not the diagnostic criteria for SVT. Even VTs can be hemodynamically stable. So summarizing, approach in broad complex, you should have a clinical history of a prior cardiac history, physical examination, stability or unstable, a baseline ECG and get a 12-lead ECG. Try to compare, do some maneuvers, put the ECG in the algorithm and see for special features, if any. Broad complex rhythm, SVT versus VT, I've summarized this prior also, but very important, AV dissociation, C for typical QRS morphology, access, duration, concordance, irregularity, onset, and compare with the sinus rhythm ECG. So summarizing, broad complex tachycardia is VT unless proved otherwise, and therefore any patient with broad complex with structural heart disease should be considered and treated as a VT. 12-lead ECG definitely should be taken if stable. Apply the algorithms. If still doubt, treat it as VT. Remember the special situations and refer or discuss if it is not clear. Thank you so much. And again, a very happy Independence Day.
Thank you so much, Shomu Bohora, sir. As we all know, the wide complex tachycardia is the most complex thing in our cardiology component, and Dr. Shomu Bohora, sir, has explained it so nicely, especially as that Varic's algorithm. Thank you so much, sir. Any question from audience?
Thank you, Tanvina.
Yeah, I think, sir, you have explained so nicely that nobody have any questions. Thank you
It's
so
my
much,
pleasure.
and happy Independence Day, everyone, sir.
Any questions,
Thank you.
any comments for Dr. Shomu Bohora? Dr. Purohit sir is here to compliment him.
It was a very quick session and very nice presentation, Dr. Shomu.
Thank
So
you, sir.
the next session, before we move to the next session, kindly accept the medallion and
Really
the
nice
certificate.
information, Dr. Somu. Thank you very much.
Thank you.
Thank
Thank
you,
you
sir.
so much.
Thank you,
So
Dr.
then,
Vinit, sir.
thank you. For the next session, uh, we have two talks from Dr. Bharat Purohit. To chair the session, we have Dr. Prabhu and Dr. Sanjay Shah, sir, who is clinical cardiologist at Dharampur and senior family physician with ex-president at Maninagar Medical Association and Ahmedabad Family Physician Association with special academic interests. So to introduce the speaker, I request Dr. Prabhu to kindly take over, and then Dr. Sanjay can also take over. Over to Dr. Prabhu.
Quick talk by Dr. Bharat. He's coming from Hyderabad, Telangana. He finished his MDD and his cardiology at Yeshua Hospital. He's the director of cath lab at Hyderabad. Sir, we welcome you, sir, for the beautiful twin talk, innovation, and atrial appendage occluder. Happy Independence Day to all of you.
Yeah, good morning to all of you, and special thank to Dr. Jagnany to have invited me. And I'll be talking on some interesting. I'll just first let me share my screen so that we are aware what's going on. So, two interesting topics which are coming up in a big way for all our patients right now. One is renal denervation, for especially for resistant hypertension, and another is left atrial appendage occluder, especially for people who have high risk of stroke and as well as high risk of bleeding in non-valvular AF patient. First, I will talk about renal denervation. The concept is basically because in all over world, what we have seen that almost 50% of people, they are not diagnosed with hypertension, and those 50 to 60% who are diagnosed, again only 50% are treated, and out of these 50% treated, only half of them are actually controlled. So there is a huge population which is either not controlled or which is not even diagnosed. So in especially in those people where we think of giving drug therapy, we have seen that when we prescribe medication, we know most of the patient will require more than two drugs, and that is where the non-adherence comes. And the data says that almost 40% of people, they are either partially adherent or they are non-adherent to the drugs. So that is the major reason why these people are not getting controlled. So even though we are giving them medication, there are a lot of people who are not at all controlled despite multiple medications, especially in older age people. We try to give them 4 drug, 5 drug, and still the BP is 180, 190. So that is where the whole problem comes. What should we do? Because we all know that if you have uncontrolled hypertension, you are at a very high risk of stroke, heart failure, and coronary artery disease. The concept of renal denervation came because we know that there are afferents around the renal artery which give feedback signal to the brain, and from there the efferent signals come, and that leads to persistent of hypertension despite multiple drugs in them. And this is how these these nerves are surrounding the renal artery. You can see the tube is the renal artery and the other part is the nerves, and you can see here the nerves are coming from the main aorta, and they are more around the arborized around the mid or distal part of the renal artery, and that is where this concept came. This concept was used way back in 1953 as a surgical treatment for hypertension patient, but because of its high mortality and morbidity, it was withdrawn. And now again, this same concept has been tried with non-invasive, non-surgical method by using a catheter inside the renal artery. Multiple companies have come up with their own catheters. The Medtronic company, the other Abbott company, others, they have tried their own ways, but the only one which is still available in India right now is the Medtronic Simplicity catheter. And the people have tried with alcohol injection around that, and they have also tried to denerve the nerves by using ultrasound system. The initial hype was very, it had a big hype initially, but then there was a big trial called Simplicity Hypertension 3 trial with the sham control, and it said that probably this therapy is sham, it is not working. And subsequently, the trial people, they went again to see what exactly was the reason why the trial failed, and they came up this multiple trials were done from 2009 to 2019, and you can see with different mechanism, different trials have been done. But the most important one is the spiral HTN off and on medicine trial and the global simplicity registry, which actually tilted the balance once again and started developing the interest among the cardiologists, and the results were dramatic. The whole concept was changed. Initially, we were giving the therapy in the proximal part of the renal artery, and we found that as per the histology, that is not where the nerves are concentrated. They are more concentrated at the bifurcation of the renal artery, and that's where we started giving the therapy at the bifurcation, and then the results started coming up. And you can see here the catheter is almost at the bifurcation, and that is where the nerves are mostly concentrated, and you get a good result. And same thing here, you can see the nerve plexus. They're not at all in the proximal part. They are more at the branching points. So this is angio picture. You can see the catheter has got 4 dots, which actually gives the pulses, and they are in a spiral manner. So all around the artery, you can give the pulses. The reason why it works in the renal nerves is because they are unmyelinated. So we are able to destroy them properly, and because there is no myelin sheath, there is no chance of regrowth, or the nerves cannot come back again. So even if they try to, they just make it look like this, but rather than joining each other and reforming it. So the denervation is actually complete and it is permanent. So this therapy is given only once in lifetime, and you need not worry that the patient is going to come back again. It's not going to happen. So this was the system, and you can see here it's a system which maintains the blood flow to the renal artery. It is spiral, so the points are actually touching the wall all across, and the central lumen is it's patent, so that there is no chance of renal ischemia here. And these are the trials you can see here. Spiral hypertension off, that means these patients never had any medication, who had very, very high BP. Spiral hypertension on, that means those patients who were on medication, but still the BP was not controlled. And then you had a whole global registry. So what was the result? Within 24 hours, you can see the blood pressure result was around 4 millimeter mercury systolic, 3 millimeter diastolic, and office blood pressure also was showing to be 9 to 5 millimeter systolic and diastolic reduction was seen. Was it only immediate? Over 3 months, you can see there is almost 9 millimeter mercury reduction, and across all the 3 subgroups, you can see 9 to 20 millimeter mercury reduction. This is the 3 months. The light blue is basically 6 months. This is showing 3-year result, and you can see here over a period of 3 years, there is a sustained and progressive reduction in the blood pressure from 4 millimeter to 9 millimeter to 10 millimeter to 20 millimeter mercury reduction in the BP. And this BP is maintained throughout the day. That means it is not showing that it is only working in the daytime or night time. All across 24 hours, it is working. Coming to the side effects, hardly any side effect. You can see the side effects are 0, 0, 0, 0 in all the trials which have been done. This was a trial with 250 patients. Hardly any. Very rarely, when we are doing the femoral puncture, you may have some groin-related issues. Otherwise, there is hardly any damage to the kidneys or to the renal artery because of this procedure. This is a data of 3 years. You can see here over a period of 3 years, all across the subset of patient, whether it's registered hypertension, diabetic, AF, CKD, systolic hypertension, elderly, all set of patient you see over a period of 3 years, you have a sustained reduction of almost 10 to 20 millimeter mercury reduction. So this suggests that it's a pretty durable, and these are the long-term data. You can see here over a period of 1 year, 2 year, 3 year, 4 year, 4.5 year. You can see there is a sustained and gradual progressive reduction in blood pressure in these subsets. This is the data of almost 10 years, and you can see over 10 years also the BP reduction is still maintained. Now, it is beneficial for both males and females. You can see here, male and female, light blue and green color is the female. You can see the BP reduction equal. What is most important is we must talk to the patient, explain all the things to the patient, because there will be a lot of apprehension. And only when there is a combined patient-physician understanding, they are in the same place, then only we should go ahead with this. Who are the people who will benefit with this? Patient who have got uncontrolled hypertension. That means those who have been taking more than 3 drugs in adequate dose, including a diuretic. That is where we call it as a resistant. And in this subset of patients, we can probably give them. Patient should be excluded of secondary causes. treatment priority must on those who have got elevated cardiovascular risk, and if they are uncontrolled with multiple drugs, we must give them. Most important, shared decision making. And this is one example, 36-year-old male, hypertensive for 4 years, and you can see here the drugs which he has been taking, metoprolol 50 mg, cilnidipine with telmisartan combination, the chlorthalidone, as well as the alpha blocker is also there twice a day. That too, it was prazosin, and BP was still uncontrolled. So we decided to go ahead with the renal denervation, and we did a pigtail injection to see both the renal arteries and where we are going to do it. This is the catheter, and this is how the impulse is given. And we take a angio here. You can see the right renal artery, the left renal artery. Then we push the wire inside, and then subsequently the catheter goes in, and we check where exactly is the branching point, and we start giving the pulses. You can see we are just at the branching. There's no need to go deep inside, because then you have chance of injuring the tissue there. So we just keep our catheter near the, and of all the 4 points, we can select which point we can give the therapy also. And after this, you can see renal artery is pretty well flowing without. So we try to go in all the branches, because the nerves are there everywhere. We just cannot do only in the one branch. All the major branches we try to go in and give the therapy, and then subsequently we go to the left side also. You can see here the therapy is being given all across, and then you can see here we have gone to the left side, and we are again trying to give the therapy. Of all the 4 ducts, we can choose whether we want, because this distal most is quite deep inside, so we can switch off this therapy and we can give only in the proximal 2. So that way we can select. It's not that the moment you want all 4 points, you will be giving therapy, and try to be away from the tissue and then give the therapy. And subsequently post, you can see the angio, the renal artery is absolutely fine. And so in conclusion, for this renal denervation, it's a promising therapy. Shared decision making is very important. Randomized data, more randomized, because right now we have a 3 major trial only, but more data is needed to accept the therapy widely. And the procedure is pretty simple. It doesn't take much time, maybe half an hour, 45 minutes. It's just given and done under local anesthesia. Patient can go home next day without any issue. And it takes generally you to get a good response. You can wait for at least 10 to 12 weeks, and then you can start seeing. And this is how the renal denervation therapy works. Now let us go to the second part of my talk, which is about the left atrial appendage occluder, which is again a very promising therapy, especially in people. We know that non-valvular AF is very important, and left atrial appendage, just like appendix, it was supposed to be a vestigial organ, but later on it was realized that it has a potential to cause stroke. And this was an editorial which said that is the most lethal human attachment, because it has a potential to cause arterial thromboembolism, especially ischemic stroke. So that is how this appendage has been described. And we have come a long way, because this was the editorial which came in 2016, where it says that left atrial appendage closure should stop now, because there were a lot of criticism when we were doing this therapy in the initial stage. And mind it, 2015 only the FDA had approved this therapy, but in 2016 this is the heading which came. From then, this therapy actually was conceptualized in 2001 by electrophysiologists, who found that when they were doing ablation, they were easily going into the appendage. And subsequently 2002, the Amplas device was used. In 2001, the Plateau device came, but Plateau device is now off the market. We now have the Watchman device. And subsequently, 2015, the Watchman got FDA approval, and 2021, the Amulet also got the US FDA. So these are the 2 devices which have got US FDA approval. And plus, there is an epicardial device called the Lariat that also has got a US FDA approval, but that device is not available in India right now. A little bit about AF. Why we are so worried about AF? Because it's a very common arrhythmia, and it is growing. There is almost a 5-time lifetime risk of stroke in this one. Above the age of 55 years, almost 1/3 of patient will have AF. And then once you have AF, it puts you under a more than 5-time risk of developing a brain stroke compared to the non-AF patient. The treatment of the baseline treatment, the fundamental treatment or the gold standard of treatment is giving oral anticoagulants, especially the direct oral anticoagulant like the Apixaban, the Rivaroxaban, and the Dabigatran. The patient who have got a very high bleeding risk, we can consider percutaneous left atrial appendage closure, or in those patients where we are worried, then we cannot stop anticoagulant. Then in those subset, we cannot even think of giving any anticoagulant. That means once you put a device inside, you have to put the patient on dual antiplatelet or an anticoagulant at least. But in those patients where you cannot even think of giving any antiplatelet, then you can think of either a surgical closure or you can think of a percutaneous epicardial closure in this subset. The whole concept earlier was that it is just a mechanical stasis which causes thrombus, but we have realized that it is not that. The cause of thrombus formation is atrial fibrillation, is not just only stasis, but along with stasis, there is a atrial remodeling, the anatomy of the left atrial appendage. There are certain anatomy which are very prone, like cactus and the cauliflower trike, and the endothelial dysfunction, inflammation, all this lead to formation of the thrombus. Where exactly this thrombus forms? This is the landmark picture which was published in '96. It showed that 94% of this thrombus forms inside the left atrial appendage. And that is the reason why this concept of closing this left atrial appendage to prevent development of stroke in non-valvular AF came into the reality. The treatment, if the patient is having very high risk of stroke, we think of giving oral anticoagulant. But if still patient has recurrent AF, we continue to add more and more drugs, like from say anticoagulant to dual anticoagulant plus aspirin, anticoagulant plus clopidogrel, or we can even think of going triple therapy. But the downside is the more you add medication, the higher is the bleeding risk. So that is where, when the risk of bleeding is high and the risk of stroke is high, then we can consider this. These are some of the trials which helped us establish the therapy. The PROTECT came way back in 2013-14, and that was the reason. Then subsequently Prevail, which helped establish the therapy and got the US FDA approval. Then Amulet also has got its own trial, Amulet ID, based on which they also got the approval. Coming to the most important question, who are the patient whom we should consider left atrial appendage closure? As per the SKY guidelines, these are the subsets which have been described there. Patient with who have a contraindication for oral anticoagulant. Definitely, you cannot give them. So instead of doing nothing, you must think of LA closure. Patient who has got a very high bleeding risk when they are taking a oral anticoagulant. Those patients who are non-compliant to drugs, that means they are not taking the drugs properly, or they are not at all willing to take them. Then there are certain specific subsets, like those who are undergoing cardiac surgery, those who are undergoing AF ablation, those who have renal failure. So these are some of the important subsets where we can consider left atrial appendage. Let us see what is the class of recommendation in them. The patient of non-valvular AF who are eligible for long-term oral anticoagulant, in these subset of patients, we are not supposed to do LA occlusion. We must convince the patient that the best treatment for them right now is oral anticoagulant. By all means, if he is still not convinced, then he comes into the category where he is not willing for oral anticoagulant, and then we can consider it. But otherwise, those who are eligible, we must convince them to go ahead with the oral anticoagulant, because the volume of data in supporting DOACs is so robust that we still do not have a superiority trial of LAC over oral anticoagulant. So this was the trial which took the same subset of patients who are eligible for oral anticoagulant, and these subset of patients were given a new generation of Watchman device, the Watchman FLX. And you can see here, even in this subset of patients, the performance goals was more than what it was expected. They had expected 97%, but here the primary effectiveness point was beyond the expected result. And the safety point was much lower than what it was expected, 4.2%. Here they had the safety event rates was only 0.5, suggesting that therapy was pretty safe as well as pretty effective. And this, even in patients who are eligible, we can still consider, but provided the patient is not at all willing. Patient who has got a contraindication for oral, now it has got a class 2A indication, because these are the subset of patient where instead of doing nothing, because their contraindication bleeding is contraindication for oral anticoagulant, you can consider this therapy. The patient who have got a very high bleeding risk, we should discuss with the patient regarding the benefit and risk of the procedure, as well as the bleeding risk. And after that, if the patient wants, then we can go ahead with the therapy. This is a trial data from Italy, basically. Here you can say that in these patients who have got very high bleeding risk, when they used LA appendage closure compared to the oral anticoagulant, you can see the annualized stroke risk, suggesting that this is the effectiveness was dramatically reduced with LA therapy, and the bleeding risk also, which suggests that the safety point. That means the therapy, because there is no oral anticoagulant, the bleeding risk was pretty low, suggesting that in subset of patient also you get good result. In non-compliant patient, those who are unwilling or unable, then if we have not convinced the patient about the benefit of oral anticoagulant, we are not supposed to. We just cannot give a very loose statement that, oh, you are not willing, okay, go ahead with LA appendage. No, that should not be our approach. We should convince the patient, those who are unwilling or unable, that oral anticoagulant is the treatment of choice. If despite all our effort, if still they are not convinced, then only we should consider it. Those who are not efficient, that means those who are developing recurrent stroke on oral anticoagulant, in these subset of patient, we can again consider using LA appendage closure as an additional measure to reduce the risk of stroke. So this is a very important subset which is coming up recently, that those who are on oral anticoagulant and they still continue to have recurrent states. So instead of making it triple therapy or quadruple therapy, you can give them an option of LA appendage occluder. Now, there are certain niche subset like patients who are undergoing catheter ablation. We know that catheter ablation, despite successful ablation, still a lot of people recur, or there may be paroxysmal episodes of AF which we might be missing it. So now the therapy has been combined, that patient undergoes a catheter ablation and they do a left atrial appendage closure in this subset of patient. The big trial which came recently in January only in New England Journal of Medicine is the option trial, which established the safety and efficacy of this therapy, suggesting that LA appendage occlusion combined with catheter ablation was able to reduce the risk of bleeding in this subset of patient and was equally effective in terms of reducing the stroke risk. There was a doubt whether this occluding the appendage will have any implication on successful catheter ablation, but it was found that it is unfounded. It is not doing any such thing. Another subset is when we do for routine cardiac surgery. The LAC trial looked at it, that anybody who goes for any routine cardiac surgery who doesn't even have a atrial fibrillation, should we occlude it? Yes, this trial clearly showed that even if you occlude this appendage, even for any cardiac surgery, you are still going to give them reduction in stroke risk in the future. The two trials which are going to come up in future are the Laos 3 and Atlas. These are the trials basically which are done on patients who have AF and those who are undergoing surgery. The previous one was patient who did not have AF, but they were going for surgery. So in both the subset of patient, this AF undergoing cardiac surgery, it is clearly established that these subset of patient clearly benefit when they are going to when they are doing a surgical closure, when they are going for other cardiac surgery in those who have got a atrial fibrillation. In ESRD, we know that data with oral anticoagulant is not very clear. Those who have got very low GFR, we cannot give them DOACs, or those who are on CKD, those who are on dialysis, also we don't have much data. So in this subset of patient, when they have done oral anticoagulant, you can see the bold line actually is the LA appendage. The thromboembolic event rate was low. The cardiovascular event rate was low. Overall mortality was very less, suggesting that these subset of patient also benefited. So in conclusion, the recommendation for LA as per the ESC 2024, it is to be given in patient who have got a contraindication, but ACC has made it class 2A. Those who have contraindication and those who cannot take, or those who are very high risk, we can consider class 2B. The available devices in India are only Watchman FLX, the Amulet, and the Lambre devices. There is no difference between the two. Where these are the data which are compared the Amulet with Watchman, and they found that there is hardly any difference between the two. And this is the suture-based device which is not available. The clips are basically done by the surgeons, and these are the two future devices, the laminar flow and the class dividers, which will actually make the procedure much more simpler, because the class is like a foam. The moment you go inside and release the device, the foam automatically expands and it will be able to occlude any type of appendage which is there. These are the future trials which are going to make this device more, give us more confidence in using the device. And this is how the procedure is done. Just one example I'll give you before I close. You go into the superior vena cava with the needle, and then you try to come down, and under the transesophageal echo guidance, you can see here the septal is being punctured on the extreme right. And once you have punctured the septum, we go into the left atrial appendage, take a angio picture, and then subsequently this is a device which is coming out. This is the amulet device, ACP device, sorry. And we deploy the device and check an angio whether the contrast is coming out. Basically, you can see the TE probe also, which tells us whether leak is there or not. And once we confirm there's no leak, the device is released and we can come back. So in conclusion, LAC is a promising therapy for stroke reduction in patient with non-valvular AF. It is, if done by experienced person, procedure complications are very low. Most of the LA can be closed by any of the device which is available, that is Watchman or the amulet or the lambre. Careful patient selection is the key, and with each passing year, new data is emerging, which is strengthening the recommendation levels. Thank you very much. If you have any questions, I'll be more than happy to answer.
Thank you, Dr. Bharat Purohit. You have taken your topic very nicely. As we all know, both the procedures are newer and they are very much helpful. Particularly, renal denervation is useful in resistant hypertension, and similarly, this left appendicular appendage surgery required for to prevent atrial fibrillation. Both the techniques are very good new techniques, and newer cardiologists are doing this procedure very nicely. We are thankful to them. And it was really good presentation by you. We all know very new things from you. Thank you, sir.
Thank you, Dr. Bharat. Thank you, Dr. Sanjay. It was a very good presentation and a sharing session also. What about cryoablation, sir?
See, basically cryoablation and pulse field ablation are basically done to convert the atrial fibrillation into sinus rhythm. So what we do is we take a catheter, go into the pulmonary veins, and this catheter, it has got a balloon kind of a thing. When it expands, there is a very cold energy is given, and that cold energy will make a circular ablation around the pulmonary vein to isolate it, because we know that atrial fibrillation, the major origin or the maintenance is around the pulmonary vein. Earlier, we were using catheter radio frequency ablation, and the technique was not very great. But cryoablation has come up, and it has made the procedure pretty simpler. But even much more simpler and more effective is the pulse field ablation, which is the latest technique which is available to convert an atrial fibrillation into a sinus rhythm.
What was the technique, sir? I didn't get you.
Pulse field ablation.
Thank you so much.
Sir, for renal denervation also, which are the criteria you decide for renal denervation?
See, honestly, I'll give you one or two scenarios. I gave you an example of a very young man who was 36 years and who are on 5 medications. Now, these patients are very high risk to develop future cardiovascular events. So we must make sure that the blood pressure is pretty controlled in them, because no matter what we did, they will not be maintaining the blood pressure. There is another subset of patient is isolated systolic hypertension in old age patient, where despite all the drugs, because of arterial stiffness and all this thing, the blood pressure still remain very, very high. So the criteria is basically the patient should be on more than 3 drugs, including a diuretic at a good dose. If the patient is not controlled with these drugs, we can consider renal denervation.
Thank you, sir.
Thank you.
Thank you, Jagnany. Thank you, Bharat. Thank you, Sanjay, for a wonderful Independence Day session. We are all happy.
Thank you. Thank you for being here. Thank you, Dr. Bharat, for being here, and 2 wonderful sessions from your good self. Thank you, Dr. Sanjay sir and Dr. Prabhu sir, for chairing the sessions. So kindly accept the medallion and the certificate. And with this, we move to our next session, which is from the senior most person of our association, Dr. Senthamarai Samuel. To chair the session, we have Dr. Rakesh Chaudhary, clinical cardiologist from Jaipur. So over to Dr. Rakesh.
I would like to invite the speaker, sir, Mr. J P Senthamarai Samuel, sir, who will highlight today's topic as hormones and hearts. Sir, please.
Good morning, everyone, and a very happy and blessed
Sir.
Independence Day.
Yeah, I guess इसके बाद आपका होना चाहिए. Also.
Thank you. The video is not coming, so I'll go ahead with that.
Yes,
And,
please, madam. Yes.
We have hormones and heart and a lot of things to share, but I will go ahead with the minimum things. And the hormones and heart, we have thyroid and heart, parathyroid and heart, adrenaline and heart. Then next slide, David, how to go to the next slide? Next slide. Next slide.
Madam, make it full screen.
Yeah, no, I'm not able to move it. How to move it? Okay. And we have acromegaly, growth hormone deficiency, carcinoid, diabetes, estrogen, and oxytocin. And I'm straight away starting with thyroid. We have both hypo and hyper and hypo. And I'm just going to talk about the serious effects only, because other things we all know. Because it's a cardiology session, I'm going on. In hypothyroidism, the effect on CVS is increased cardiac output, stroke volume, LV contraction, heart rate, myocardial oxygen
The
consumption.
slides are not moving.
No, I'm just going on with that only. Even that only I'm explaining, okay? Myocardial oxygen consumption, coronary flow, and augmented systolic and diastolic, systolic contraction and diastolic relaxation. And systemic vascular resistance is reduced. And catecholamine being low or normal in both conditions, systemic vascular resistance will be reduced. But the effect of catecholamine is seen because of increased responsiveness of beta catecholamine receptors in various conditions. It need not be catecholamine level going up, but without that also, the beta receptors are reacting to it. In case of hypothyroidism, just the opposite of hyper, we have decreased cardiac output. We have decreased cardiac output, heart rate, and stroke volume, and LV contraction, myocardial oxygen consumption, blood volume, and the flow to the periphery all are reduced. There is hypothermia, hypoventilation, and hypotension.
Dr. Sanjay, will you please mute? Dr. Sanjay, will you please mute?
Supported movements पापा के 1 महीने तक. हाँ, घर पे ही रहना 1 महीना तो.
Hypothermia, these are all the signs that are seen in myxedema. Increased circulation time and increased peripheral resistance because of the low flow thyroid hormone, chronotropism and inotropism both are lost. Then we are going in for, this is the cardiac findings, and then we are going in for diagnosis. We have lab diagnosis, increased free T4 and thyroid index, free thyroid index, but TSH will be suppressed, as we all know. And antithyroid hormones, antithyroid antibodies we have to study, and TSH receptors we have to see, and all these are thyroglobulin, all these are there. In case of hypothyroidism, TSH is elevated and all the other things, T4, free T4 and FTI will be reduced. and anti-thyroid antibody elevated only in Hashimoto's thyroiditis. Creatinine kinase is elevated in hypothyroidism. We have to also note for anemia, hyponatremia, and dyslipidemia, which are the normal findings of hypothyroidism. Diagnosis, now we will concentrate on ECG because cardiac related.
Madam,
ECG,
slides are not moving.
oh, it's not moving, is it? Slides are not moving, is it? Okay. Some regular. What we did know,
We are still with the first slide only.
oh God, 1 minute, 1 minute. So they usually is it moving now? Has it changed?
Yes, sir.
Now it's changed, right? I'm in diagnosis.
Yes, madam, it's moving now.
Okay, thank
Ma'am,
you.
if you can just make it into a slide presentation, the slides will start moving. You're not in a presenter's mode, you're still in that open mode. On the right down corner, you will have a small TV like figure, just click on it.
Where? Right corner, there's something there which should move.
There's
Right
a slider,
down
ma'am,
corner.
122% is showing. Next to that 122%, there's a small monitor like thing. Next
Is
to it,
it?
left, on your left. Little
This
bit.
one.
There are 3 dots like next to 140. No, not that one. The other one, other side, next to 122.
Next
On your
120.
left.
Come this side.
More left. More left.
More left.
No, don't slide it. You just go to the next one. Yeah, this one. Press it. Just press this.
Okay. Okay, thank you. And diagnosis ECG, because of its there is sinus tachycardia, SVT, atrial fibrillation, APCs. So echo shows hypercontractile state because it's hyperdynamic. There is rapid filling of highly compliant ventricle, increased LV mass and cardiac hypertrophy. In case of hypothyroidism, there is sinus just the opposite of hyper, sinus brady, prolonged PR and QT intervals, low voltage complexes with inverted T waves. Atrial and ventricular and intraventricular conduction delays will be noted. Echo asymmetrical septal hypertrophy, obstruction to the LV OT, and there will be pericardial effusion in 30% of the cases. Next. Treatment. You have to prevent thyroid hormone synthesis and release, and these are all the drugs. And from our side, cardiac side, we have beta blockers to control the heart rate, and we have lithium iodide and corticosteroids reserved for life-threatening conditions.
Ma'am, please, slide is not moving. Please click on marker.
Marker, Thambi, marker.
Swastika, can you help, please?
Ma'am, yes, ma'am, you can like try stop sharing your screen and reshare the screen once again, ma'am.
No, 1 minute, 1 minute. Yes, please. Hello. Is it okay?
And now, ma'am, please try moving to the other slides once.
I try. 1 minute. It's not moving. Is it okay now? Is it okay now?
Yes, ma'am, it is moving, but can you please make it in slideshow mode?
I put it on. Add remove buttons. Slideshow mode. Resume slideshow mode. Is it okay?
Press F5.
F5. F5 one. F5 press. Let's come. Yeah. Oh, so now press F5.
I already did that.
Is it okay now?
There must be some compatibility issue. You can just click on the slide which you want to show. It will change,
Okay.
keep changing.
Now I am with hypothesize. I go to the next one.
समस्या एक ही है कि आप पिछला हफ्ता हम लोग आपको बुलाते हैं लेना नहीं चाह रहे
treatment, as I told you, medication, and then I was going ahead, radioactive I-131 for gland destruction and a hormone replacement following that. Painful thyroiditis, we give aspirin and NICADs, and surgery or retreatment in multinodal. Suppose iodine 133 doesn't destroy the gland, we have to repeat the treatment, but surgery is ideal. Case of hypothyroidism, can you hear me? Can you hear me?
Yes, ma'am.
Okay. Hypothyroidism, thyroxine therapy reverses all serious manifestations associated with hypothyroidism. So we have to start the patient on treatment earlier. The underlying CAD requires slow and judicious use of thyroid hormones. Otherwise, it will cause exacerbation of angina or MI. In case where the patient has unstable angina, as you said, if there is unstable angina and where we cannot start on hormone therapy, we can even go ahead with angioplasty or CABG and then start the usual dose with hormone therapy. And what's this? Now we go to parathyroid, hyperparathyroidism and hypo we have. Primary parathyroid because of adenoma is the commonest thing. There is hypoplasia also, which is rare. Usually found also with multiple endocrine neoplasia, overproduction, where overproduction of parathyroid hormone is noted. Secondary is due to hypocalcemia, vitamin D deficiency, and renal failure. There is also tertiary cause, chronic stimulation of the thyroid gland, mostly because of renal pathology. In case of hypoparathyroidism, primary is idiopathic. Also occurs in post-op settings where the surgery is done for neck and thyroid because the patient goes in for magnesium deficiency. Symptoms, mostly asymptomatic thyroid, detected only in the routine lab test. Others complain of non-specific symptoms, vague aches and pains. Serious, we notice arrhythmias. I press something else. Serious arrhythmias uncommon, but acute hypercalcemia can cause sinus brady and first-degree AV block. Renal damage from nephrocalcinosis and elevated PVR because of the direct effect of parathyroid thing on the smooth muscles. There is LVH, 80%. There is also valvular sclerosis. Mortality rate is not increased in hyperparathyroidism. In case of hypoparathyroidism, symptoms include tingling around the mouth, hands, and feet. Cardiovascular manifestations are rare. Treatment. Treatment. ECG, as we notice, there is hypercalcemia, decreases the plateau phase of the action potential. There is short ST and QT, XT segment and QT interval corrected for HR. Is probably the most reliable. When the QT interval is shortened and corrected QT interval is shortened, that will be the most reliable ECG index for hyperparathyroidism. Calcium level is more than, if calcium level is more than 16 milligrams, widening of T wave and increase in the QT interval is noted. Echo, high insistence of LVH, calcification of aortic valve, mitral valve, coronary trees, and myocardium. Lab test serum serum and ionized calcium level will be increased with or without parathyroid hormone elevation. The 24-hour urine calcium level more than 200 points out the diagnosis. Phosphate levels can be either low or normal, low normal. Hypercaloremic metabolic acidosis noted. Serum alkaline phosphatase is elevated if the bone is involved. Treatment for parathyroid treatment is parathyroidectomy. If not feasible, then we are going for medical administration of biphosphonates, pamidronate, and estrogen in case of postmenopausal women. Hypoparathyroidism, ECG segment, ST segment is lengthened, QR prolonged, T wave usually normal. Echo, impaired LV function, restoration of eucalcemia may improve the cardiac function. In hypothyroidism and hypoparathyroidism, once a hormone level is established, I think the cardiac manifestations will be less. It will be improved. We are going in for adrenaline and heart. We have pheochromocytoma and adrenaline insufficiency. In case of pheochromocytomas, the medulla secretes catecholamine. Medulla, we have catecholamine secreting neoplasm. Epinephrine, excess catecholamines are produced by these neoplasms. 90% of these pheochromocytoma are in the adrenals. Extra adrenal are present in sympathetic chain of cardiac, where the visceral autonomic paraganglia are present in the atrium and IAS, intra-atrial septum. In case of bronchomeric, there is bronchial that is present, very rare, but it is present in the bronchial arch. This pheochromocytoma can be part of ME and multiple endocrine neoplasm, type A, 2A and 2B. Now, in case of adrenaline insufficiency, autoimmune destruction of adrenal cortex, here medulla and here cortex, deficient production of glucose and mineralocorticoids. Primary usually is adescence, cortex is destroyed. Secondary, ACTH hyposecretion could be because of hemorrhage in the cortex, and then metastasis, AIDS, and granulomatous conditions, lesion like COX, and withdrawal of corticosteroid, patient will go in for adrenaline insufficiency. Present also in critically ill and aged patient over 55 years with hypotension. They are nearly 30 to 40% of the people in the critically ill category are having adrenal insufficiency. Symptoms and signs: unpredictable release of catecholamine and also dopamine, vasodilatation, paroxysmal attack of headache, palpitation, sweating with hypertension. That is, there will be labile hypertension, both hypo and hyper. If there is sweating with hypertension, we can label it as adrenaline, pheochromocytoma. There will be sudden elevation of blood pressure during anesthesia. There is orthostatic hypotension because of dopamine presenting there. Increased nervousness, irritability, sense of doom, mild abdominal pain, constipation, then increased heart rate, contractility, and augmented conduction velocity. Both dilated and hypertrophic cardiomyopathies are noted in echo. High level of catecholamine, this is because of the high level of catecholamine. Contraction bands cause necrosis and fibrosis, which are reversible. In case of adrenal insufficiency, deficient production of glucocorticoids, patient will have fatigue, anorexia, nausea, vomiting, weight loss, hypotension, hypoglycemia. That is in patient of glucocorticoids. In case of reduction in mineralocorticoids or aldosterone deficiency, both deficiency of renal sodium and bicarbonate wasting will be there. And there is because of that, there will be hyponatremia. Hypokalemia also will be noted. Acidosis and profound dehydration will be noted because bicarbonates are less. Occurs also in when people are exposed to stress such as infection, trauma, and surgery. Chronic cases decreased vascular resistance, myocardial contractility, hypotension. There could be even orthostatic, and there will be syncopal attack. In case of acute, low, normal, or high SVR and cardiac output, and low cardiac output, low or normal cardiac output, and then capillary pressure is low, high. Acute on chronic, there will be hypovolemic shock, fever, volume depletion, depressed mentation, nausea, vomiting, abdominal pain, etc. Hypoglycemia, if untreated, will lead to coma and death. And ECG findings, sinus tachy, brady also, because it is hormones are at least different timings. Non-specific STT change will be noted. Prominent U wave and atrial and ventricular tachyarrhythmia will be noted. Conduction disturbances such as RBB and LVB and noted. LVH also seen. In echo, increased LV mass and cardiomyopathy. CT and MRI radionuclide imaging localized as a tumor. In case of adrenal insufficiency, there is sinus brady, tachy, non-specific T wave. Peaked T will be noted in case of hyperkalemia. Low voltage and shortened QT will be seen in hypercalcemia. Echo, small cardiac chambers with normal function. Lab elevation of catecholamines and their metabolites we have to see, and then 24-hour urine collection which shows metnephrines and free catecholamines will be noted. Plasma collection after placing the IV catheter for 30 minutes, make the patient rest in supine posture and then look for plasma, catecholamine and metnephrines. Clonidine suppression test, if unchanged, pheochromocytoma is diagnosed. In case of adrenaline insufficiency, there is hyponatremia, hypokalemia, hypocalcemia, hypoglycemia, and acidosis. That is in primary adrenaline insufficiency, addisons. In secondary in adrenaline insufficiency, there is hypokalemia, will not be there as the renal angiotensin will stimulate aldosterone production, production. Hypokalemia will not be there, whereas in case of addisons it will be there, because here in case of secondary, the aldosterone production is stimulated. There is normocytic, normochromic anemia, and with lymphocytosis, eosinophilia in the blood smear. Synthetic ACTH, that is rapid ACTH test, cause elevation of cortisol to 20 milligrams per DL within 30 to 60 minutes. If that causes that, if it fails to increase, then that clinches the diagnosis of primary adrenaline insufficiency. Treatment, prevention of serious complications, MI, heart failure, hypertensive crisis, stroke. Arrhythmia, sudden death will be seen, and in pheochromocytoma, so the management is prevention by that. Surgically, we can do lap adrenalectomy. Now, at present, they are doing even lap adrenalectomy to remove the tumor. Pre-op Instead of giving the regular antihypertensives, alpha beta blockers will be ideal, and then switch over to alpha blockers to prevent hypertension and coronary spasm and pulmonary edema. Then propranolol to control the heart rate, and labetalol, heart rate and arrhythmia. Metirosin, 250 milligrams to 500 milligrams, maximum up to 4 grams you can go, inhibits the synthesis by 40 to 80%. Inoperable cases, we have to go for medical management. In case of in adrenal insufficiency, treatment should be immediate, and because it is life-threatening. Stress dose of corticosteroid hydrocortisone, 100 milligrams once in 6 to 8 hours, along with saline for volume resuscitation, along with glucose infusion to correct volume and electrolyte. Underlying cause, infection should be searched and treated. Once patient comes back out of crisis, corticosteroid slowly can be withdrawn. Alternate treatment, dexamethasone, 2 to 4 milligrams IV rapid ACA test can be done, as this does not interfere with cortisol assay. Addison disease, both cortico and mineralocorticoid replacement to be done. We are going in for Cushing. ACTH producing pituitary adenoma causes Cushing syndrome. Excess cortisol in the circulation. Other area, there are other ectopic areas also, which produce other ACTH is produced by other areas of ectopic tumors. They are small cell carcinoma of the bronchus and exogenous use of corticosteroid. Pseudo-Cushing syndrome, seen in alcoholics, obese, and have some psychiatric problem. There, the physical signs may be there, but confirmatory tests will be normal. Diagnosis, we have screening, confirmation, and determination of the cause. Screening, we do 24 hours urine collection for free cortisol, which is elevated both in Cushing and pseudo-Cushing. So we have to do confirmatory test. 1 milligram of overnight dexamethasone suppression test will be done. If it normally doesn't respond, so we have to give 2 milligrams with or without corticotropic. Releasing factor confirms the diagnosis. With this 2 milligrams, it will be elevated. Determination, the cause of ACTH level performed. If elevated, primary tumor or ectopic production of ACTH will be noted. If low ACTH means adrenal disease. 8 milligrams of dexamethasone suppression test and cortical releasing hormone stimulation test, pituitary from ectopic. When we give 8 milligrams, it just decides from pituitary from other sources of ACTH. Imaging done to localize a tumor and is done after completing biochemical workup. Treatment, surgical removal of pituitary tumor with or without radiation. Removal of ectopic sources of ACTH production. If surgery is not feasible, medical management using adrenolytic therapy. Adrenocortical blocking drugs. And these are the drugs. Then comes hyperaldosteronism, increased and autonomous production of aldosterone, the adrenal gland, that is primary cause. Consequences of excess aldosterone, sodium retention. Despite sodium retention, there is no edema, as kidneys can compensate excess sodium. Plasma volume expansion is noted, renal loss of potassium and bicarbonates, leading to hypokalemia and alkalosis. Hypoaldosteronism, common secondary cause for hypertension. In 12 to 20%, there is noted. Diagnosis, if any hypertensive, spontaneous hypokalemia, resistant hypertension, adrenal insuloma, or in whom secondary hypertension is suspected, we have to do basal cell, spontaneously they have hypertension. Basal plasma renin activity should be suppressed with elevated plasma aldosterone and aldosterone renin ratio. Patient must discontinue any antihypertensives that affect the renin-angiotensin system. So for 3 to 4 weeks before, and there is 3 to 4 weeks salt before salt suppression test. They have to be given alpha-adrenergic blocking blockers preferred. Patient is put on more than 120 milli-equivalent of salt with NaCl supplements for 3 to 4 days to suppress the aldosterone last day. Patient should be put on regularly on 120 milli-equivalents of salt per day. And later, for the last 3 to 4 days, NaCl supplements can be given to do the suppression aldosterone test. High salt intake, 24-hour urine collected. If NaCl is more than 200 milli-equivalent and aldosterone more than 12 microgram, unsuppressibility of aldosterone confirms the diagnosis. If both are given and if there is not able to suppress it, aldosterone confirms diagnosis. Imaging of adrenaline to look for hyperplasia versus adenoma. Treatment, surgical resection, and then this cures hypertension in 70% of the patients. And patients who are not candidates for surgery and hyperplasia, medical management. Aldosterone antagonist, spironolactone, 100 to 20 milligrams a day. Epinephrine is 25 to 100 milligrams a day. Diuretic, amyloid, 10 to 40 milligrams a day. And calcium channel blockers. Then comes acromegaly and growth deficiency. Acromegaly is pituitary adenoma with excess secretion of growth hormone. And in case of, in adults, it is called acromegaly. In children, it produces gigantism. Bony growth and organomegaly and premature death will be caused by this. There are ectopic sites also, like carcinoid, small cell, pancreatic islet cell, and other tumors which secrete growth-releasing hormones. Serious manifestation, cardiac dysfunction, heart failure, chronic cases, in chronic cases. Acromegaly cardiomyopathy is noted. Concentric biventricular hypertrophy, inadequate filling, both systolic and diastolic dysfunction noted. Histologically, interstitial fibrosis, collagen deposition, myofibrillar derangement, myocyte apoptosis are noted. Glucose intolerance and frank diabetes causes premature cardiovascular death. If untreated, elevated TGL and apolipoprotein A1 and fibrinogen, plasma fibrinogen, activator inhibitor are all elevated. Karn syndrome, growth hormone secreting pituitary tumor, which is noted in more than one chamber. Anterior pituitary gland causes the problem in anterior pituitary gland growth deficiency. Abnormal body causes, these patients will have abnormal body composition, increased fat masses, abnormal lipid metabolism, impaired capacity to exercise, increased bone mineral density, increased quality of life, increased serious mortality twice as normal, MI, hypokinetic, decreased LV size, LV thinning and septal wall thinning noted. This is called hypokinetic syndrome. Low heart rate and BP and low ejection fraction and cardiovascular CVS. Treatment acromegaly, you have to do the treatment is surgical removal of the pituitary adenoma, post-op radiation. Medical octreotide given per day subcutaneously. Once the control is achieved, progression of CVD is arrested and mortality is reduced. Heart failure and arrhythmia treated conventionally. Growth in hormone insufficiency treatment, we have to give the medical management and you have to do the provocative test, which actually helps in increasing cardiac mass because there is thinning of cardiac muscle and nitrous oxide production, decreased carcinoid, decreased carotid and intimal medial thickness, reverses early atherosclerosis in major arteries, improves vasodilatory function of the endothelium, hypertrophic effect subsides over time, and side effects, fluid retention and carpal tunnel syndrome. Carcinoid is again a neuroendocrine tumor containing vasoactive secretagogues like ACTH, growth hormone, releasing hormone and releasing hormones, also serotonin. Found also in GI, urinary tract, pulmonary bronchial. Symptoms and signs: flushing head and neck with liver metastasis and bronchospasm in pulmonary carcinoid. Unique effect of the tumor is serotonin causes fibrotic plaque-like thickening on the endocardium of tricuspid valve, which causes severe TR and right heart failure, cardiomegaly, and congestive heart failure. Half of them die of congestive heart failure. There is also deposition in pulmonary valve, which causes pulmonary stenosis. Atria, ventricle, SVC, IVC, pulmonary arteries, and coronary arteries also get these deposits. Diagnosis and CT and echo, we have cardiac involvement, which we have to see, and treatment is surgical removal of tumor if not metastasized. Otherwise, medical management, the synthetic somatostatin decreases the tumor and decreases serotonin level. Diabetes and heart, as we all know, I think this is known, macro and microvascular disease, and diabetes with or without cardiovascular death is higher. And type 1, I don't think I'll go. Metabolic syndrome, we all know it is obesity, insulin resistance. And symptoms, angina, MI, atypical symptoms. Here in diabetes, the symptom will be atypical, painless, unusual pain patterns with delayed presentation, so diagnosis delayed. High mortality rate from MI. Recurrence frequent, long-term prognosis poor, high incidence of congestive heart failure, men 2 to 4 folds, women 5.1 fold. Increase also, and there is also ventricular rupture happens. Fixed tachycardia when the sympathetic denervation is there, and when there is parasympathetic damage, low heart rate. In complete denervation, heart rate will not respond to any physiological stimuli. Test abnormal systolic and diastolic function with impaired diastolic filling. Early sign, that is the early sign for cardiomyopathy. Delayed opening of MV, longer pre-ejection period, and shortened LV ejection time resulting in decreased filling and contractility. Except in recent onset diabetes, there will be increased contractility. Cause of dysfunction is multifactorial. That includes hypertension and diabetes, hypertension and heart disease. Treatment, lifestyle, oral hypoglycemic and insulin sensitizers, antihypertensives, ACI and ARBs are the first line. Beta blockers, CCB and low dose diuretics are second line. Aggressive lipid lowering drugs and antiplatelets. And PTCA and CABG, and in CABG, Lima gets preferred because restenosis can be avoided. HRT, hormone replaces, and they have done panel 2, panel 3, and restriction replacement progression coronary artery atherosclerosis, but no, there was not much found out. And in fact, in the World Health Initiative stopped the early study because there was increased risk of CA breast, rates of CAD, stroke, DVT, and pulmonary embolism. Hence, HRT for postmenopausal women not recommended anymore for prevention of CAD. Oral contraceptives causes estrogen causes DAV, high dose, DVT, MI, and stroke. So currently they use low dose with 50 milligrams with some progestin, safer for women who are on not diabetic, not hypertensive, and who do not smoke. The oxytocin is a new thing that has come, a lot of benefits, beneficial effects on infarct size, functional recovery of the ischemic reperfused heart, improves cardiac work, decreases apoptosis and inflammation, pro-inflammatory cytokines and immune cell infiltration. promotes angiogenesis by stimulating differentiation stem cells into cardiomyocytes and smooth muscle cells, decreases myocyte hypertrophy, oxidative stress in cardiac and cellular. In cardiac,
with due respect, we are running.
I'll just
yeah.
Cardiac and cellular modules of ischemia and reperfusion, acute administration of oxytocin, along with the onset of reperfusion, cardiomyocytes viability and function by improving CV metabolic function, improving the CV coronary vascular function and metabolic function. And I think I've finished with this. And thank you. And thank you for giving me the opportunity. The topic was a little big.
It's our privilege that you are here. Thank you so much.
And I'm getting old and I'm not able to do it fast also.
No issues, ma'am. No issues. Your presence is more important.
Thank you so much, all of you.
Due to paucity of time, I guess we will move to the next session. We are running a little bit late. So kindly accept the certificate, madam, and also our chairperson, Dr. Rakesh and Dr. Nandi. Somehow Dr. Manoj is unable to present, so really sorry. I request the chairpersons to be kindly be here, Dr. Elivel Pusa and Dr. Manish Kedia for the next session. And for next session, we have Dr. Ashwin S, who is clinical cardiologist. And to chair the session, we have Dr. Chitrali Singh and Dr. Shanti Mala Tirki. So Dr. Ashwin will be presenting on hypertension in pregnancy. Dr. Chitrali and Dr. Shanti are as chairpersons. With this, we request Dr. Ashwin to kindly take over the session. I have done the needful on your behalf, Dr. Chitrali. You can conclude the session once he finishes. Thank you so much.
No problem, sir.
Dr. Jagnany, very good morning. Am I audible?
Yeah, you are audible and slides are also visible. Kindly
screen is visible as well. Screen is visible, I hope.
Yeah, kindly make it full screen.
Yeah. Good morning, everybody. I'm Dr. Ashwin from Bangalore. The onset, wish you all a happy Independence Day. And I would take this opportunity to thank the organizers for giving me an opportunity. Today's topic is hypertension in pregnancy or hypertensive disorders in pregnancy. It's a vast topic. I had to have I made the topic as much crisp as possible due to lack of time. We all know that hypertension is one of the commonest medical disorder occurring during pregnancy, which complicates around 5 to 10% of all the pregnancies. When it is severe, it can lead to stroke and death, and prompt recognition, early treatment can reduce the risk of these complications. If you look at the prevalence, the overall prevalence is around 8 to 10% of all the pregnancies. Preeclampsia occurs in about 2 to 8 globally. Eclampsia prevalence is lower in high-income regions, whereas it is, it's lower in the high-income regions, whereas it is 30 times higher in the low socioeconomical groups. Again, the HELP syndrome, which affects around 10 to 20% of preeclampsia patients, translates about 15 to 0.5 to 9% of all the pregnancies. There are 4 major hypertensive disorders which we are going to discuss today. In this, the important point is whether it is less than 20 weeks of gestation or more than 20 weeks of gestation. If it is less than 120 weeks, it's 20 weeks of gestation, then it's directly called as chronic hypertension. And if it is more than 20, then it is gestational, then leading to preeclampsia and chronic hypertension. I'll go it one by one. Let's look at the definition or the diagnostic criteria as per the latest. The gestational hypertension is a new onset of systolic hypertension, which is greater than 140 systolic, 90 diastolic on at least 2 occasions, 4 hours apart, after 20 weeks of gestation in a previously normotensive individual. There should not be any proteinuria and there should not be any symptoms and signs of preeclampsia related end organ dysfunction. So this is called as gestational hypertension. The next is preeclampsia. Patients or the pregnant ladies who are presenting with gestational hypertension in the presence of either, it could be proteinuria, which is around 300 milligrams greater than 300 milligrams in the last 24 hours sample, or a protein creatinine ratio greater than 0.3 or a dipstick method greater than 2. If there is any organ dysfunction, like it can be thrombocytopenia, elevated liver enzymes, renal impairment, pulmonary edema, or neurological symptoms, including IUGR. Again, preeclampsia is a generalized seizure in a patient with, eclampsia is a seizure in a patient with preeclampsia that cannot be attributed to any other causes. HELLP syndrome, which is seen in pregnancy, is hemolysis, elevated liver enzymes, and low platelets. Here, hypertension is not a must. Sometimes, if hypertension present, then it is also considered as a variant of preeclampsia. Next is the chronic hypertension, or what we call as pre-existing hypertension. Here, the blood pressure is greater than 140/90, diagnosed either before pregnancy or before 20 weeks of gestation. And according to the latest 2023 criteria, they have included hypertension, that is chronic, they have included hypertension first diagnosed during pregnancy, and if it persists 12 weeks postpartum, then also it is considered as chronic hypertension. They have taken it to the next, they have added one more called as chronic hypertension with superimposed preeclampsia. Here, it's again any patient with chronic hypertension. If there is a sudden increase in the blood pressure that was previously well controlled, or an escalation of an antihypertensive therapy to control blood pressure. It also includes new onset of proteinuria or a sudden increase in proteinuria in a patient who was a known case of proteinuria before or early in pregnancy. And again, a significant new end organ dysfunction consistent with preeclampsia after 20 weeks of gestation or postpartum. This was recently added again, wherein they have added chronic hypertension with superimposed preeclampsia with severe features. These severe features include a systolic blood pressure greater than 160, a diastolic greater or equal to 110, despite of escalation of antihypertensive therapy. Again, thrombocytopenia can be present, wherein less than 1 lakh is considered here. Pulmonary edema, new onset or worsening of renal insufficiency, impaired liver function, or they can also have a sign or symptom wherein severe persistent right upper quadrant or epigastric pain unresponsive to medication and not accounted for alternative diagnosis like appendicitis, gallstones, whatever it is. The other one would be, the last one would be persistent cerebral and visual disturbances. If you look at the pathophysiology of hypertensive disorders in pregnancy, it's not completely understood. Most of the experts agree that the underlying reason is multifactorial, and there are many theories forward, and few of them are like placental bed, immunological factor, genetic factors, age, renin-angiotensin system, and atrionatric peptide, prostaglandin, and neutrophils. They also mentioned that due to abnormal placentation that leads to oxidative stress, endothelial dysfunction, which again triggers the systemic inflammation, vasospasm, multi-organ involvement. Also, they mentioned there is something called impaired spiral artery remodeling. N number of theories have been put forward, but there is not a single one which has still been, been suggested that this is the primary cause. It is multifactorial. So let's going forward. What are the other things that we look into? Laboratory and screening consideration. The first is the blood pressure measurement, very important, we all know, but then cell sphygmometer remains, the oscillatory method remains the standard, gold standard. Nowadays, oscillometric devices are also validated for pregnancies. Whenever we have a suspected case of white coat hypertension, we suggest to use 24 hours ambulatory blood pressure monitoring, or blood pressure monitoring is also equivalent to it. Here, the point you need to emphasize is omit the first reading and take the second reading. And as far as proteinuria assessment is concerned, 24-hour protein, which is greater than 300 milligram, is considered as the gold standard. Again, dipstick method is common and it's been used in all the parts of India, including rural India, but it has a very limited sensitivity of only 61%, high specificity of 97%. Nowadays, there are new prediction markers or biomarkers available for screening. They are called as maternal risk scoring, which helps us in identifying the high-risk pregnancies, whereas the detection rate could be varying from one to other. These are the few pitfalls which I thought I should put. Very important. Again, in case when measuring the blood pressure, if there is an improper cuff size, there could be a variation wherein if it is too large, the blood pressure monitor could be 2 to 10 millimeters less. If it is the smaller one, then we can have a higher one. Similarly, if the placement is been not proper, we can have variation. Talking while measurement can increase. Improper positioning, patient not sitting properly with a back support, not feet resting on the floor, arm not supported, even as simple as full bladder can increase the blood pressure by 10 millimeters. These are very simple, but we tend to miss. Let's look at the risk factors which can modify the hypertension in pregnancy. These can be divided into three. One are the modifiable risk, non-modifiable risk, and the obstructive factors. Under modifiable risk factors, we have obesity, diabetes, lifestyle factors such as smoking, less excessive alcohol consumption, poor dietary habits. Anemia also can predispose to hypertension in pregnancy. Lower education, again, this especially in case of hypertension not being monitored can lead to preeclampsia and eclampsia. Psychological stress like pregnancy-related anxiety and prenatal depression, very important again. The obstructive factors include the period of gestation. Again, it is said that a prior history of stillbirth, and if it is multigravida or multiparity. Twins or triplets, they are more prone for hypertension in pregnancies. What are the non-modifiable risk factors? If there is already a existing hypertension, if is a patient who is known case of kidney disease, if it's a multiple gestation, if the maternal age is less than 20 or greater than 40, certain race, especially Black people, Africans, are considered to be high risk for pregnancy-induced hypertension. If there is a strong family history of hypertension, yes, and if there is a history of hypertension in previous pregnancies, also in nulliparity, and few autoimmune diseases like lupus and genetic factors. Before we go to the topic hypertension in pregnancy further, let's look at the differential diagnosis which we need to rule out before labeling anybody as pregnancy-induced hypertension. They are basically antiphospholipid syndrome. There could be a coarctation of aorta, can be Cushing's, need to roll out eclampsia per se, glomerulonephritis, can be identiform mole, Karn syndrome, hyperthyroidism, malignant hypertension. These are few which I have mentioned. There are still much. Then we can also have few diseases which can mimic preeclampsia. Again, preeclampsia is next to the gestational hypertension, wherein pleiochromoscytoma stands first, and we have some other secondary causes like endocrine causes like Cushing syndrome, primary aldosteronism. It can be substance related like use of cocaine, amphetamines. Then we can have vascular diseases like Takayasu arthritis, which can cause renal artery stenosis, can lead to hypertension in pregnancies. Other pregnancy-related conditions can also go as or mimic as preeclampsia, like thrombotic microangiopathies, acute fatty infiltration of pregnancy. This is of late been well documented, and if is a case of SLE, there can be a flare in SLE also. So what are the complications that we are looking at? Here, complications can be divided into maternal and fetal. Let's look at maternal. Maternal complications include, they can go in for convulsions, coma, cerebral hemorrhage, can progress to renal failure, heart failure, liver failure. They can go in for DIC, abruptio placenta. Again, they can continue with the hypertension, like they are called as the chronic hypertension. They can have recurrent preeclampsia in their next pregnancies. Whereas if you consider fetal complication, it could be IUGR, intrauterine fetal death, and prematurity and its complications. So very important to know this. So how do we go forward? Pregnancy-induced hypertension or gestational hypertension, so-called, it's just focused on managing blood pressure by protecting both mother and child. It's not just medication, it is the lifestyle adjustments, regular monitoring, and if necessary, medication. So what are the lifestyle modification we are looking at? Rest, hydration probably would help us. Dietary adjustment, especially reduction in salt intake, sufficient calcium and vitamin D recommendations, vitamin D intake. Exercise low, regular or low impact exercise like just walking. Swimming sometimes may be beneficial, but after taking opinion from your healthcare provider. Very important is regular blood pressure monitoring. Again, frequent monitoring is very important at home and in clinic. It's not just at clinic, we have to emphasize them at home also. We need to monitor the fetal growth, very important, especially with patients with hypertension in pregnancies, because they are more prone for IUGR. Again, urine test, especially checking for proteinuria, very important to assess whether there is any progression to preeclampsia or potential complication which can lead to eclampsia on later stage. So coming on the medication part, we all know the first line of drug is labetalol, which is around 100 to 200 twice daily, can be increased thrice daily. The maximum dose is around 2,400 grams per day. Here, we should look for side effects, hypotension. There can be an increased liver enzymes. There can lead, it's a beta blocker. It has alpha and beta both. So it can lead to fetal bradycardia. Hence, FHS monitor is very important. You need to look at neonatal hypoglycemia, especially post-delivery within the first 15 days. And this drug to be avoided, especially in asthmatic due to a risk of bronchospasm. They can even induce congestive cardiac failure. The next drug which we use is nifedipine per oral. Usually we use extended release unless it's an emergency, we take short acting, otherwise it is long acting. 30 to 60 milligrams daily, probably we can increase in the next 7 to 14 days. Maximum is around 120 milligrams per day. Here the side effect would be severe headache and peripheral edema. Methyl dopa was the initial drug which was used early. Now it has been into the third level, or usually choice is later. 250 milligrams twice daily or thrice daily. We can increase up to 3,000 milligrams per day. Here the issue is it could be a little sedative. There can be a peripheral edema, anxiety, nightmares, and dry mouth, hypotension. And this drug is particularly contraindicated in patients with depression. Next two drugs are considered as second and third line. Here, hydrochlorothiazide, the diuretic, 12.5 milligrams can be taken once daily, can go up to 50 milligrams in a well-built lady. But in Indian scenario, I would restrict myself to 25 milligrams. Again, restriction is very important. Contraindicated during the first trimester, can be safely used, especially those patients who are salt sensitive hypertension, what we call. There is volume depletion, there can be fetal growth restriction, and then oligohydramnios. So observation is very important. That's why we consider this as second line. Hydrazolene, again, this is a very important, earlier used, but now it's used as a third line of drug, 10 milligrams QID, can increase up to 200 milligram, but this medicine cannot be used as a single medication. This is to be used along with labetalol to counter the tachycardia which induces. There can be side effects like severe tachycardia, headache, flushing, fetal distress, hypotension, and also very important is inhibition of labor, especially when it is combined with magnesium sulfate. So this should never be used in isolation. The next is severe range hypertension, like what I said, chronic hypertension with preeclampsia with severe, that is called as hypertensive emergencies in pregnancy. We are going to use IV medication here. Again, the first line is labetalol IV, 5 to 20 milligram. We can increase it every 10 to 15 minutes, maximum dose of around 220 milligram per day. And this can be started in infusion also. The side effects remains the same, but you should be very careful with this patient with asthma, as they can cause bronchospasm and congestive cardiac failure. And the next drug is hydrazine in case labetalol is not available. Labetalol is not available in Germany. Those patients who are on labetalol going to Germany, please be aware that it is contraindicated. It's not used, it's not available and not to be used in Germany. Hydrazine, again, 5 to 10 milligram can increase up to every 20 minutes to max of 30. Say the side effect remains the same as the previous one. The last one is the oral, not the IV, but it is the oral, which is immediate release nifedipine. This is around 5 to 10 milligram. We can increase it every 30 minutes to a maximum of 50 milligram per day. It is the first line alternative to labetalol only in the absence of IV access for the treatment of acute severe hypertension. Let's come to the other. There are certain calcium channel blockers we are very fond of, like amlodipine, which we use left and right in all our patients. If we come across any lady who is planning for a pregnancy, we need to shift it to the extended release of nifedipine before conception or during the early first trimester pregnancy, because of extended fetal safety data being recorded with nifedipine. Then use of thiazides, I said it is being used, but it is suggested to discontinue or reduce the dose before conception or early pregnancy, though there is no evidence of effect on the fetus. They say that thiazide diuretics can interfere with volume depletion. Again, there is a lot of changes which happens between the first trimester, second trimester, and the third trimester. So there will be a volume, there is a fluid shift. So use of thiazides on the higher dose could always alter this. As far as beta blockers, commonly used beta blockers, carvedal, metoprolol, we suggest shifting to labetalol before conception. Again, metoprolol is still being used and can be used during second and the third trimester, but need to keep a look on fetal bradycardia. Very important. Labetalol, again, has to be used cautiously whenever a heart rate is less than 60 in a patient with hypertension in pregnancy. If the heart rate is less than 60, avoid using labetalol because it has both alpha and beta 1 activity. Avoid atenolol because of its documentation with fetal growth restriction. Atenolol is one of the commonest beta blocker used in rural India, so would avoid atenolol. Avoid, as usual, we all know that we should avoid AC inhibitors, ARBs, MRS, and direct inhibitors because there is no safety as far as the fetal is concerned. They can always lead to growth retardation. Also, there are congenital anomalies which have been documented, hence is completely contraindicated. Low dose aspirin as prophylaxis has been recommended after 12 weeks of gestation for prevention of preeclampsia in patients with chronic hypertension or if patients are at high risk of developing the disease. High risk of developing disease means those patients including obesity, those who have a high or a strong family history of hypertension, those patients who have a previous history of hypertension during the early pregnancies, nulliparity, or if somebody is aged more than 40, age less than 20, we are using a very small dose, 75 milligrams of aspirin is been recommended. It is very important to monitor the fetal growth. Again, evaluation of fetal well-being is very important because all patients of hypertension in pregnancy are prone for FGR, for fetal growth retardation. So we need to look at it very carefully with doing more number of serial growth ultrasounds or to watch for the growth of the child. Then use of magnesium intrapartum sulfate. We can't use magnesium sulfate as a treatment for hypertension, but yes, we can use as a seizure prophylaxis in a patient with preeclampsia, especially during the third trimester. I'll not go into preeclampsia and eclampsia due to lack of time. I would be restricting myself to hypertensive disorders. I've tried to make it as short as possible. Again, those patients who've been started on antihypertensive medication, whether it could be prior to pregnancy, during pregnancy, or prior to labor, should be continued intrapartum, and we should be monitoring them post delivery for severe hypertension. They can go with higher blood pressure during the early 6 to 13 days. Very important. Again, timing of delivery, those patients who are well-controlled blood pressure, patients with hypertension, we suggest them to deliver at 39 weeks, not to prolong it, but in Indian scenario, the gynecologist usually deliver it by 38 weeks. And this can be reduced further if there is any presence or an indication for early delivery. Postpartum, as I told earlier, again, monitoring of the blood pressure is very, very important for within the first 3 to 10 days, because again, there is a lot of changes which occurs during the postpartum time. So we need to be very careful when we are using antihypertensives with the patients with pregnancy-induced hypertension. So the overall management, if you are looking at, we need to look at preconception, early pregnancy, and later on. Preconception include patients to be assessed properly prior to it. We need to address the issue. We need to educate them, tell them the importance of regular medication. And again, we need to monitor them early. And then during the early pregnancies, we need to do a baseline laboratory, very important. Cardiac evaluation is a must, renal, and then retina. Again, retina also very important. We need to get the retina checked in pregnancies with hypertension. Accurate gestational dating, very important. Usually, if somebody has an irregular periods, they always have an irregular dating. Here, it keeps varying. And these patients, especially patients with pregnancy-induced hypertension, they are all prone for fetal growth restriction. So you need to be very careful in documenting that, and then you should be ready for that if they are suspecting a preterm birth. So the take-home message is accurate classification, early detection, which are very crucial, recognition of severe pictures and help guidelines, urgency. We need to know the pathophysiology which undergoes the system, because we are other things other than pregnancy which can cause hypertension in a pregnant lady. We need to use aspirin as a prophylaxis, appropriate blood pressure control, seizure prevention, use of magnesium, and timely delivery, and we should optimize the outcome. Thank you.
Thank you. Thank you so much, Dr. Ashwin. Any questions for Dr. Ashwin? Any questions for Dr. Ashwin? Any comments?
I was fast, I believe.
Yeah. You have saved some time for us. Thank you so much.
It was very precise and to the point. Thank you, Dr. Ashwin, for the wonderful presentation.
Thank you, ma'am. Thank you.
So I guess we can move to our next session. And before that, I request Dr. Ashwin and our chairperson, Dr. Chitrali and Dr. Shanti, to kindly accept the certificate of faculty. Thank you so much, Dr. Chitrali, for being here, and Dr. Shanti and Dr. Ashwin. So for the next session, we have Dr. Mitesh, and to chair the session, we have Dr. Shashikant Mishra, clinical cardiologist from Gurgaon, and Dr. Nishant from Devghar. Over to Dr. Shashi. Dr. Mitesh is a clinical cardiologist from Surat with more than 15 years of clinical experience, and he is faculty both at state, zonal, and national level, and is also co-investigator at Hermes trial for heart failure. He will be talking on coronary angiography and how should a clinical cardiologist should approach them. So over to Dr. Shashi and Dr. Mitesh.
Hello.
Hello.
Yes.
Yeah, kindly share your slide, Dr. Mitesh.
Yes. On new share option, there is a screen sharing.
Green button.
Slides are visible or not?
Yeah, slides are visible.
Okay. Should I make it full screen now?
Yeah, please make it full screen.
Okay, is it
Yeah,
fine?
yeah, it's full screen. Yeah,
Just
please.
tell me whether it is moving.
Yeah, yeah, it's moving.
Okay. So
Thank you.
we will start with this case presentation. This patient is 64-year-old male with hypertension and hyperlipidemia is referred to us for evaluation of exertional stage pain. So is exercising treadmill is sufficient, or we should order a coronary CT angiography in such patient? So we will try to understand this question with presentation on CT coronary angiography and coronary artery calcium scoring. We will go through this steps one by one from indication till take home message. So I'm Mitesh Chauhan, based at Surat. So in our day-to-day OPD, definitely we get chest pain patients. More than 50% of our OPD patients are coming with chest pain. So we take history, we do risk factor analysis, and we do clinical examination. And based on our initial clinical assumption, we order certain tests like ECG, echo, treadmill, dovitamin, CT coronary, or in certain highest patients, we certainly send them for conventional coronary angiography. So how do we decide for a particular test? There is this thing called pre-test probability of having a coronary artery disease. So based on our history and clinical judgment, we come to know about likelihood of a patient having CAD before any specific diagnostic tests are performed. And what are the factors which influence our decision making? Age, sex, type of chest pain, tobacco consumption, dyslipidemia, diabetes, and family history of CAD. So based on this pre-test probability, there are categories low, less than 20%, intermediate 20 to 80%, high, more than 80%. So we all don't go for any investigations in patients less than 20%, and we advise them for prevention, therapy, lifestyle modification, diet, exercise, and in with high risk patients, definitely we don't do this and straight away send the patients for conventional coronary angiography. But those patients with intermediate risk probability, we have with in our armamentarium exercise stress and dopamine stress ecography and a CT coronary angiography. So we will first understand the indications of CT coronary angiography. So there are first line indications for evaluation patient with no past history of CAD, but patient with typical chest pain or atypical chest pain or angina equivalent like dyspnea or fatigue. In such patients, we can send them this patient for CT coronary angiography. Or we want to rule out some coronary anomaly or patient with past history of CABG. We want to rule out any graft patency or certain patients, like for patient is a known case of coronary artery disease and stable or typical chest pain or angina equivalent, we can definitely for the course or for the further planning, we can send them for CT coronary angiography. Or there are some reasonable indications like patients with stent past history of angioplasty and stent is more than 3 millimeter or proximal non-bifurcating thin strut with less than 3 meter also such patients also we can send them for CT coronary angiography. So this all guidelines come from this AHA-ACC and AAC, this SCCT society. They have come out with guidelines for patients with stable chest pain, class 1 level of evidence 1, that CCTV, CT coronary angiography is effective for diagnosis of CAD, for risk stratification, and for guiding treatment decisions. In certain patients with acute chest pain, CT coronary angiography is useful for exclusion of atherosclerotic plaque and obstructive CAD. So in certain patients, exercise stress test is useful, and in certain patients, CT coronary angiography is useful. So we will see in which subset of patients. So what are the advantages of CT coronary angiography? It is rapid, safe, and accurate with high negative predictive value. Negative CCTA rules out CAD. But it also can detect non-obstructive plaque, which we might be missed by other tests. So when we should order CT coronary angiography, when it is available and can be done with high quality, and probability of having disease is intermediate to high, and when identification of such patients will prompt us for more intense prevention, and this CT coronary angiography can rule out CAD but also identify plaque and high risk anatomy, and in which patient exercise tolerance test is sufficient. When CT coronary angiography is not available, good image quality is unlikely to be achieved. Patient is patient can exercise and has a normal baseline ECG, or there are lower probability of CAD. So even in patients with high risk patients with known coronary artery disease obstructive, but to guide further whether to stent it or whether to send this patient for revascularization bypass, so this exercise test can also help us. So advantages: simple, widely available, no radiation. We can evaluate exercise capacity, assess presence and severity of symptoms. We can also check hemodynamic response to exercise, and we can also see for exercise-induced arrhythmia. There are limitations. We all have faced this thing in our day-to-day practice because it lacks sensitivity and specificity, and includes inconclusive findings are more common. In certain patients there are baseline changes, and during the trace this baseline changes definitely affect our interpretation of the study, and in some patients we fail to achieve target heart rate. So this graph tells us this inconclusive exercise tolerance tests are more common. So this patient we can with this not available of this thing, we can send this patient for CT coronary angiography. We understood the indications. Let us now look for the contraindications. As such, there are no absolute contraindications, but with a history of severe anaphylactic reaction to iodine-related contrast, we should not do it. Okay, and there are relative contraindications like pregnancy, thyroid storm, renal insufficiency. Patient cannot hold breath for more than 5 seconds. Patient on radioactive iodine therapy. Patient is hemodynamically unstable with decompensated heart failure, and body habitus is not suitable for the CT scan. There are some criteria mentioned in the guidelines about the equipment. We can skip this one. Radiologists, technologists, nursing staff, training, advanced life support, and can insert IV line, should be experienced enough and readily available. Yes, now we can see this patient. We need to guide them before sending them for the CT coronary angiography. Patient should not have solid food for 4 hours before the exam. Liquid he can have. Patient should take all his or her regular medications, especially blood pressure medication. Should have no caffeine for 12 hours. IV access. We should tell them that they are going to take the IV line. And yes, most important thing is heart rate. Heart rate should be resting heart rate should be less than or equal to 60 beats per minute. And there are some protocols to control that, like some radiological institutes, they prefer giving metoprolol or ivabradine 1 or 2 days prior to this particular test. And we should also guide them, these patients, about avoiding use of NSAID, avoiding use of metformin, because metformin as such is not nephrotoxic, but if it is accumulated, can lead to the toxicity. So we should also tell them that sometimes they may have to use nitroglycerin during the test, so they should be prepared for this thing. So, and we can also guide them about the breath holding practice. This positioning and lid placement is being done at the radiological center. So we should also keep this contrast-induced nephropathy in our mind. In patients with high risk of contrast-induced nephropathy, we should look for the other tests like space test or dobutamine stage echo, where it doesn't require intravenous contrast. And we should always avoid dehydration. We should minimize the volume and frequency of contrast administration. We should avoid high osmolar agents. Nowadays, isoosmolar or low osmolar agents are commonly used. We discussed about nephrotoxic drugs on hold for 48 hours, and we should consider IV fluid in patient with high risk as per the patient's clinical situation. We can skip this one technique. It is more bit about technical aspect. Image acquisition is also about technical aspect. Yes. So we can now talk about coronary calcium scan. Coronary calcium scan, also known as CAC or calcium score test, is a non-invasive imaging test that measures the amount of calcium buildup in the walls of the coronary artery. It's a way to assess the risk of CAD and potential future IHD event. So how it works? That calcium which is deposited in the coronary arteries is a sign of atherosclerosis. So the scan generates a score based on the amount and density of calcium found. A score of 0 indicates no detectable calcium and low risk of future CAD, and higher score indicates more calcium buildup and higher risk of heart attack. So it's a quick CT scan over heart, low radiation dose, no contrast, and gated to ECG. So high risk of CV in case of high or calcium score. We should also see whether that calcium deposition, calcium is diffuse or it is focal, more diffuse, more high risk. Is it affecting the aorta, aortic valve, mitral valve? And based on the findings, we can always guide our patients about diet, exercise, activity, sleep. Okay. And so what if patient has got high calcium score? If patient can exercise or patient is walking regularly and is asymptomatic, no further testing is required. We should focus on preventive therapies as discussed. But if we are uncertain about patient's exercise capacity and we want to see for the evoked response to symptoms, we should order exercise tolerance test. And but in case of very high risk, in case of coronary calcium score is more than 1,000 possible symptoms, stress test or a CT coronary or a conventional angio we should order. And this coronary angiography is in patients with this high score, we should definitely order. We can also come to know about plaque characteristic on this quick scan over the heart. Likewise, dozens of positive remodeling, like yellow, this marked in this slide as yellow arrows, and low attenuation plaques are the most important determinants of plaque vulnerability. Whereas stable plaques lack both of these features, remodeling and low attenuation. So these are the CT images. Left antedescending artery circumflex, right coronary artery. So with the advantage of newer machines, photon counting, less calcium blooming, good quality image is now available in patient with past history of stenting. We can also see the patency of the stent. We can also now ability of fractional flow reserve with the CT coronary. We can also determine the severity of stenosis. And this is a typical CT coronary angiography report mentioned the name of the contrast, quantity of the contrast, scoring, calcium score is mentioned, left coronary system, the type of LED, and diagnose the branches, then the impression, and then the advice. So we should also guide our patient or consider the complications in our mind with anaphylatic possibility of anaphylatic response. This CT scan utilizes access to radiation and this thing contrast. So coronary CT angiography is a non-invasive, cost-effective, and accurate measure means of assessment of CAD. Timely method of anatomical evaluation of coronary arteries with tremendous prognostic utility. In a low-risk suspected ACS patient, the use of CT coronary angiography is also expanding. It offers alternative explanation of symptoms by providing information regarding non-coronary components or congenital anomalies. This newer CT technology will help reduce the risk of radiation exposure and greatly improve image quality, visibility, and accuracy of CT coronary angiography. So, with this presentation, we should, to summarize this intermediate risk category chest pain patients, definitely we should, by doing CT coronary angiography, we can rule out because it has got high negative predictive value in patient with inconclusive TMT. Definitely CT coronary angiography can guide us further whether to start patient on statin and or aspirin, or patient has a known case of coronary artery disease or established coronary artery disease, but patient cannot tolerate statin for one reason or the other. So whether the disease is progressive, stable, the kind of plaque characteristic we can come to know about this CT scan, CT coronary angiography. But when we order, we should also keep the risk and the cost to the benefit ratio in our mind. If that pre-requirement is heart rate, the heart rate should be less than 60 beats per minute. We should also guide our patient about contrast and radiation-related complications. And definitely it's a prerequisite that good quality images and experienced radiologist is there to make the report quality. And then when patient comes with the report in our cabin, we should also know about what we have to do with the result. Okay. So as we discuss about this patient in first slide, so patient we send this patient for exercise tolerance test and he the exercise for 8 minutes. He achieved 10.1, but no ischemic changes, no angina symptoms. Stop due to fatigue. This is his baseline ECG. This is immediate post exercise. So we couldn't achieve the target heart rate. So we ordered a CT coronary angiography and we could found out the mild stenosis but large amount of plaque. So what we recommended, aggressive risk factor modification and preventive pharmacotherapy. So with this slide, last slide, thank you organizing chairman, secretary, president of FFPI, secretary, Family Physician Association, Height Society, senior members and dear friends. Thank you for your valuable time and patient hearing, and have a happy Independence. Thank you.
Hello. Thank you so much. As we move to the next session, I request Speaker Dr. Mitesh and Chairperson Dr. Shashi and Nishant to kindly accept the certificate. And with this, we move to our next session with Dr. Suman O S. To chair the session, we have Dr. Ravi Bhushan Gupta and Dr. Amar, clinical cardiologist from Delhi and Ranchi. Dr. Suman O S is cardiologist at Badr Al Sama Hospital, Oman. He is also member of various societies, including ISCC, Fellow of European Society of Cardiology, American College of Cardiology, and Russian Society of Cardiology. He has also received various awards. He is involved into research and peer reviewer with various publications and presentations to his credit. He will be talking on management of heart failure. With these words, I hand over the session to Dr. Ravi and Dr. Soman.
So good morning, everyone. First, I just want to thank Dr. Vinay Jagnany and his entire team for this great opportunity. Today, my topic for discussion is management of heart failure. The screen. Can you share the screen? I don't know. It is not.
Swastika, you can help.
The screen it is not showing. No, that slides.
Sir, you can just go to the PowerPoint, like open the PowerPoint in the downwards. Yes, and now make it full screen, and there is an option which is coming as a hide. You can then hide that option also. Yes.
Is okay now?
Thanks, Swastika. Yes, it's visible.
It is visible, no? So shall I
Yeah.
start now?
No.
Okay.
Again, it stopped. Now, yeah, yes.
Yeah,
And
wait.
Full screen.
Yeah. Is it okay now?
Yeah.
Yes, sir.
Yeah. Shall I start?
Yeah.
Yeah. Thank you. So management of heart failure. Heart failure, also known as congestive heart failure, is a syndrome caused by an impairment in the heart's ability to fill with or pump blood. So this definition shows the systolic as well as the diastolic heart failure. There are four stages of congestive heart failure. Stage A, at risk. Stage B, pre-heart failure. Stage C, symptomatic heart failure. And stage D is advanced heart failure. I'm very focusing on the recent guidelines of that is a 2022 ACC-AHA guideline for the management of heart failure, which provides the recent updates on heart failure management, including primary prevention, treatment of heart failure with reduced ejection fraction, with mildly reduced ejection fraction and preserved ejection fraction, as well as advanced heart failure. So when we start with the therapy, the dietary modification is very important, especially dietary sodium restriction. The excessive sodium intake, it can cause fluid overload and it can precipitate heart failure. So dietary sodium restriction is very important. It's a two-way indication in treatment of heart failure. Coming to the activities, for patients with heart failure who are able to participate exercise training, it is recommended to improve functional status, exercise performance, and quality of life. It's a class 1A indication. And in patients with heart failure, a cardiac rehabilitation program can be useful to improve functional capacity, exercise tolerance, and health-related quality of life. And diuresis and decongestion strategies in patients with heart failure. Diuretics are recommended if there is any evidence of fluid retention. It's a class 1B indication. And in patients with heart failure and congestive symptoms, addition of the thiazide, that is metalazone, to treatment with a loop diuretic should be reserved for patients who do not respond to moderate to high dose loop diuretic to minimize electrolyte abnormalities. Coming to the renin-angiotensin system inhibition with ACE or ARB or ARNI. And in patients with heart failure with reduced ejection fraction, when class 2 to 3 symptoms, use of ARNI as well as ACE inhibitors are recommended to reduce morbidity and mortality as a class 1 indication. And in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction who are intolerant to ACE because of cough or angioedema, and when use of ARNI is not feasible, the use of ARB is recommended to reduce mortality and morbidity. So the first choice definitely it is AC, that is AC inhibitors or ARNI. If it is not possible, then we can go for ARB. That's the recommendation. That's a class 1A recommendation. And concomitant use of RNA or AS inhibitors are not recommended. It can do harm. There should be a gap of 36 hours of the last dose of ASE to start RNA. So there should be a gap of 36 hours. And RNA and AC inhibitors should not be administered for patients with any history of angioedema. Coming to the beta blockers, we have three beta blockers we have used in many trials. That's bisoprolol, carvedilol, and sustained release metoprolol. This is the class 1 year recommendation to reduce mortality and morbidity. And coming to the mineralocorticoid receptor antagonist, the MRS, These are used as a class 1 indication patient with class 2 to 4 heart failure patients, and provided the EGFR should be more than 30 milliliter per minute, and the potassium should be less than 5. If any hyperkalemia or other things, then it is contraindicated. And coming to the sodium glucose co-transport 2 inhibitors, this is a class 1 indication in patient with symptomatic chronic heart failure with reduced ejection fraction. It is recommended to reduce hospitalization and mortality, irrespective of presence of type 2 diabetes. Hydrolyzin and isolazine dinitrate. We have isolazine in the market. There are trials in the ethnic population like African Americans, and is proved there's a benefit in patients with class to class 4 with heart failure with reduced ejection fraction. And it is also recommended in patients those who we can't able to give AC or ARB due to other complications like hyperkalemia or renal dysfunction. So in this category of patients also we can use hydrolysin to reduce the mortality and morbidity. Coming to other drug treatments like omega-3 polyunsaturated fatty acid supplementation may be reasonable to use as adjuvant therapy to reduce mortality and morbidity and cardiovascular hospitalizations. And in patients who experience hyperkalemia, potassium binders can be used. And regarding anticoagulations, it is no longer recommended for heart failure patients unless there is a indication like LV thrombus, venous thromboembolism, atrial fibrillation, or something like that. Otherwise, it is not recommended. And these negative inotropic agents like dihydropiridine calcium channel blockers like diltiazem and verapamil is not indication for patients with heart failure. I think only calcium channel blockers we can use in patients with heart failure is amlodipine if depends upon the blood to control the blood pressure. And vitamin and nutrient supplements and hormonal therapy are not recommended other than to correct specific deficiencies. And patients, dihydropiridine already discussed, is not recommended. And antiarrhythmic like dronedarone may increase the risk of mortality, so it's not recommended. And thiazolidines like pioglitazone can cause edema and fluid return, so should be avoided in patients with heart failure. And dihydropiridine, DPP for inhibitors, saxagliptin and allogliptin can increase risk of heart failure, should be avoided. And NSAID, of course, don't use in patients with heart failure. And the guideline-directed medical therapy dosing, sequencing, and up titration. In patients, we always start with always start the drugs with the minimum dose, and we have to titrate to the maximum tolerable dose for the patients with heart failure. And you have to titrate for every 1 to 2 weeks, depends on the patient's symptoms, vital signs, and laboratory findings can be useful for optimized medical therapy. These are the common drugs used in heart failure. We have many trials on enalapril, pentopril, ramipril, and these are the most commonly used AC inhibitors. And we have to start with minimum dose and titrate to the maximum doses. And coming to the ARBs, there are candesartan, losartan, and valsartan. And I think the majority trials have been taken place with valsartan. And Arni, sacubitril valsartan, we have the paradigm heart failure trials. And the usual dosage is 50 BD to 100 BD. But many of the class 4 heart failure patients, majority of them have blood pressures on the borderline. So we will start with 25 BD or even 12.5 BD, and definitely we can titrate depends upon the tolerability of the patient. And beta blockers, bisoprolol, carbidiol, carbidiol sustained release, metoprolol. And coming to the mineralocortical receptor antagonists, we have spironolactone, eplerenone. And SGLT inhibitors, dapagliflozin and empagliflozin, and isosorbate dinitrate, and this combination. And we also have ivabradine, then vericiguat, and digoxin. And ivabradine, we can use 5 milligram BD to 7.5 milligram, depends upon the heart rate of the patient. It can reduce, it's simply affecting the sinus node and reduce the heartbeat. And for patients with symptomatic, that is class 2 to 3, stable chronic heart failure with reduced ejection fraction, that is EF of less than 35%, who are receiving guideline medical therapy, including a beta blocker at maximum tolerable dose, and who are in sinus rhythm with a heart rate of more than 70 beats per minute at rest. Evaporating can be beneficial to reduce heart failure, hospitalization, and cardiovascular death. This guideline tells first we have to start the beta blockers, then evaporating. But sometimes in our clinical practice, especially patients with class 3 to 4, most of them have blood pressure on the lower side. Sometimes we have to start evaporating as an initial choice, but and definitely it will get benefited. And soluble guanylyl cyclase stimulators is to be a recommendation in selected high-risk patients with heart failure with reduced ejection fraction and recent worsening of heart failure. Already on therapy, oral soluble guanylyl cyclase stimulator may be considered to reduce heart failure hospitalization and death. These are the summary of slide. And coming to the ICTs and CRTs, it's a class 1 recommendation for patients with non-ischemic DCM or ischemic heart disease at least 40 days post-MI with ejection fraction less than 35, class 2 to 3 symptoms on chronic therapy who have reasonable expectation of meaningful survival more than 1 year. Then only ICD is recommended. This is a class 1 recommendation. And class 1B, that is post-MI, 40 days at least, ejection fraction less than 35, class 1 symptom while receiving therapy, and reasonable survival more than 1 year. Which you can also consider. Then next category, patient who have EF less than 35 in sinus rhythm, LBBB with the QRS duration more than 150, and class 3 to 4 symptoms or 4 ambulatory symptoms, then definitely it is recommended. And for patients who have EF less than 35, sinus rhythm, non-LBBB, but QRS duration more than 35, and survival definitely more than 1 year, and class 2 to 3 and 4, it can be considered. And patient AF with EF less than 35, guideline director method on therapy, CRT can be useful to reduce total mortality, but the patient requires ventricular that AV nodal ablation or pharmacological rate control will allow near 100% ventricular. So this type of patient we have to do AV nodal ablation with pacing and control the rate with drugs, like beta blockers. And ICD is not recommended in patients those who have the ECG, QRS duration less than 120. CRT is not recommended. And coming to the heart failure with mild reduction of ejection fraction, this that is symptomatic heart failure with EF 41 to 49%. And this for this patient, diuretic class 1 recommendation definitely is there is any fluid overload. SGL2 comes as 2A indication, ARNI, ARB, all the other things 2B, MRI 2B recommendation, and evidence-based beta blockers 2B recommendation. And heart with mildly reduced ejection fraction, SGL2 can be beneficial in decreasing heart failure hospitalization, and definitely that's a 2A recommendation. ARNI, all the other things comes as 2B recommendation. And coming to the next category of heart failure with improved ejection fraction, this should be a patient who improves after the treatment of heart failure. The therapy should be that the guideline directed medical therapy should be continued to prevent further relapse. So don't stop this medication once this ejection fraction improves. And coming to the heart failure preserved ejection fraction, that is symptomatic heart failure with EF more than 50%. Diuretic, as we told the other classes, if needed only. And SGL2 inhibitors come with 2A indication, ARNI 2B, MRI 2B, and ARB 2B recommendation. And heart failure with preserved ejection fraction, hypertension should have medication titrated to attain blood pressure targets in accordance with published clinical. So this type of category, blood pressure may be the important, blood pressure control will be the major role. And SGL2 inhibitors are recommended. And management AF, atrial fibrillation, is very important in this category of patients. And in selected patients, heart failure preserved ejection fraction MR may be considered to decrease hospitalization, provided the GE, GFR, and potassium levels should be normal. And the phosphodiesterase inhibitors and nitrates have limited role in this category of patients. And specialty referral for advanced heart failure. In patients with advanced heart failure, when consistent with the patient's goal of care, timely referral for heart failure specialty care is recommended. Review heart failure management and assess suitability for advanced heart failure therapies like left ventricle assist device, cardiac transplantation, palliative care, and palliative inotropes is a class 1 indication. And coming to the mechanical circulatory support, in selected patients with advanced heart failure, NUSA class 4 symptoms who are deemed to depend on continuous intravenous inotropes or temporary mechanical support, durable left ventricle assist device implanted is effective to improve functional status, quality of life, and survival. And in selected patients with advanced heart failure who have class 4 symptoms, despite therapy, mechanical circulatory support can be beneficial to improve symptoms, functional class, and reduce mortality. Inotropes are recommended in patients with class stage D heart failure refractory to therapy, and they're planning for cardiac transplantation. Is normally it's used as a bridge to bridge therapy actually, and and this continues in patients with advanced heart failure and hemodynamic compromise and shock. Temporary mechanical circular support includes percutaneous or extracorporeal ventricular assist device are reasonable as a bridge to recovery or bridge to distance. These LV assistant devices are used as a bridge to cardiac transplantation. Coming to cardiac transplantation, for selected patients with advanced heart failure, despite therapy, cardiac transplantation is indicated to improve survival and quality of life. This is a class 1C indication. And 10 take home messages. So, the guideline directed medical therapy for heart failure with reduced ejection fraction now includes 4 medication classes, which include sodium glucose transport inhibitor, that is SGLT2 inhibitors, and these SGLT2 inhibitors have a 2-year recommendation in heart failure with mildly reduced ejection fraction, a weaker recommendation for 2B. So in this category, SGLT2 inhibitors are have a major role than RNA by the new recommendation. And the new recommendation for heart with preserved ejection fraction are made for SGLT2 inhibitors at 2A, MRA, RNA, or 2B recommendation. Several prior recommendations have been renewed, including treatment of hypertension, treatment of atrial fibrillation 2A, use of ARBs 2B, avoidance of routine use of nitrates or phosphodiesterase 5 inhibitors. That is, there is this category of drugs that like nitrates and phosphodiesterase inhibitors, there is no benefit. So improvement of EF is used to refer for those patients with a previous heart failure with reduced ejection fraction who now have an EF more than 40%. This patient should continue the treatment. Value strategies were created for selected recommendations where high quality cost effectiveness studies of the intervention have been published. And amyloid heart disease have new recommendations for treatment, including screening of serum and urine monoclonal light chains, bone scintigraphy, genetic sequencing, tetramers, stabilized therapy, and anticoagulation. Evidence supports increasing filling pressures is important for the diagnosed heart failure in the EF more than 40%. Evidence for increased filling pressures can be obtained from non-invasive or invasive testing. And patients with advanced heart failure who wish to prolong survival should be referred to a team specialized in heart failure. They can plan for LVAD or cardiac transplantation. And primary prevention is very important in this category of patients at stage A, that is pre-heart failure, stage B. Stages of heart failure were revised to emphasize the new terminologies for and risk of heart failure for stage A and pre-heart failure for stage B. So this is the category where we clinical cardiologists have a good major role to prevent this heart disease. And recommendations are provided for selected patients with heart failure and deficiency, anemia, hypertension, sleep disorders, type 2 diabetes, atrial fibrillation, coronary disease, and malignancy. Thank you. Any questions, please?
Thank you. Thank you so much. Any questions for Dr. Suman? If we do not have any questions, then we move to our next session. Before that, kindly accept the certificate of faculty. And for the next session, we have Dr. Rikul Shah as chairperson to introduce Dr. Jaiveer Singh Khatri. Over to Dr. Rikul.
Thank you, Dr. Jagnany, and happy Independence Day to all. Our next speaker is Dr. J.S. Khatri. He is consultant at Max Hospital, Dwarka. And over to you, Dr. Khatri.
He will be talking on hypertrophic obstructive cardiomyopathy. Over to Dr. Jaiveer Singh.
Thank you, Dr. Rikul and Dr. Vineet. It's my pleasure to give this brief overview over hypertrophic cardiomyopathy. And before that, I would like to congratulate everybody for our 79th Independence Day. Being an ex-army man, I feel proud to announce this on this Independence Day. So congratulations, everyone.
Thank you. Thank you so much.
So my slides are visible, sir?
Yes.
Changing.
So as we all know that hypertrophic cardiomyopathy is a... Oh, I think my slides are gone.
No, it's visible.
Hypertrophic cardiomyopathy, everybody is known to everybody. It's a genetic disease which is characterized by unexplained LV hypertrophy associated with non-dilated ventricular chamber in the absence of another cardiac or systemic disease. So basically, the septal hypertrophy is the main view which we see in hypertrophic cardiomyopathy. Talking about the prevalence, 1:500 is the prevalence, which is quite common. Total term of hypertrophic cardiomyopathies are hypertrophic obstructive cardiomyopathy and idiopathic hypertrophic subaortic stenosis. In earlier days, we usually call it subaortic stenosis also.
Dr. Suman.
Let's talk about the genetics. So hypertrophic cardiomyopathy most commonly is a genetic disease, which is basically due to the beta MSC mutation and the sarcomere protein gene mutation, which is responsible for 40 to 60% of the cases of the HCM. Still, the unknown cases are 25 to 30%, and 5 to 10% are the other causes like MYL gene, TPM, TNN, TNNT2, MYH7, MYPBC3. So what is the mechanism, what the pathophysiology of the HCM? I'm going very quick. So LVOT obstruction is the main mechanism of hypertrophic cardiomyopathy, which is usually produced by the systolic anterior motion of the mitral leaflet. And the physiology behind this is Venturi effect and the drag effect usually. Venturi effect is the mitral wall drawn towards the septum because of a lower pressure that occur as the blood is ejected at high velocity through a narrowed outflow tract. And usually the mitral wall is sucked towards the aortic wall and it causes the obstruction by pressing it over the septum and causing the gradients. So you can see here on the left side, there is a gradient of hypertrophic cardiomyopathy, and the right side is the aortic stenosis gradient. Usually the dagger-shaped gradient is of hypertrophic cardiomyopathy, and aortic stenosis gradient is usually this one. We will talk about the obstruction. Dynamic obstruction. It is usually in three state. Top, we are taking in respect to the septum. If you take it to the basal obstruction at rest is usually, if it is obstructing at rest, it should be more than 30 mm of Hg. So 30 millimeter of the mercury is the criteria for diagnosing hypertrophic cardiomyopathy. If it is a non-obstructive at rest, it should be less than 30. If physiologically provoked, even if it is less than 30, it is non-obstructive. So criteria is simple, more than 30, even at rest or on provocation, it is hypertrophic cardiomyopathy. And if it is less than 30, with or without provocation, it is non-obstructive. Diastolic dysfunction is the important sequelae of hypertrophic cardiomyopathy. And the physiology behind is the impaired relaxation, decreased compliance due to the replacement scarring, interstitial fibrosis, hypertrophic septum, and the symptoms belong to this is the exertion dyspnea due to the pulmonary pressures and increasing filling pressures. Myocardial ischemia, which is very common because of the systolic anterior motion of the mitral leaflet, which causes the obstruction and LVOT obstruction. Basically, the ischemia is less blood to the coronaries, to the sinuses, and the ischemia causes. Arrhythmias are very common with the hypertrophic cardiomyopathies, and most commonly are premature ventricular contractions, couplets, and SVTs, SVT, AF. Atrial fibrillation is also very common in hypertrophic cardiomyopathies, which is eventually needed to be evaluated in further treatment. So what is the clinical presentation? Majority of the patient of clinical hypertrophic cardiomyopathy are asymptomatic. They came to you in primary health checkup, or maybe just randomly they came for their checkup. So unfortunately, in our Indian setup, most of these patients came to us with the first incidence of VT or sudden cardiac death. It is very unfortunate. Otherwise, the symptoms behind that are dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, palpitations in various forms of arrhythmia, congestive symptoms. Sudden cardiac death, as I said, is sometimes the primary symptom of the patient. Angina because of the ischemia, syncope and presyncope. Presyncope is more common than syncope, and we should go for the Holter monitoring if the patient is having syncope or presyncope. The diagnosis, the simple diagnosis of the patient, we can detect right from the ECG, right from the beginning. ECG shows LV strain pattern with deep T wave inversion like a dagger-shaped T wave, and increased voltage with left ventricular hypertrophy. T wave inversion, as I told you, lateral precordial leads, deep and narrow Q waves, lateral precordial leads. Q waves will be there, and left atrial enlargements. This is the typical of HCM. So I would like to focus more on echocardiography, as I am the echocardiographer and I'm seeing non-invasive cardiology. So echocardiography is the very important, the primary tool to rule out the hypertrophic cardiomyopathy. And we all, being a cardiographer, should counsel the patient for the further management. It's our primary duty, because it's nowadays it's a scenario of sudden cardiac death is very common in young adults. And that's our duty to counsel the patients. So echocardiography, what we see is the presence of hypertrophy and its distribution, whether it is septal hypertrophy, whether it is apical hypertrophy, whether it is right ventricular hypertrophy, and the ejection fraction, left atrial volume is very important regarding the diastolic dysfunction, pulmonary artery pressures, and the obstruction at LVOT, at rest with or without Valsalva maneuver. MRCVT is also important. Material regurgitation is very common in HCM due to the anterior mitral leaflet systolic anterior motion. These are just to show you that you all must be aware of this picture. This is, you can see the septum is too much thick, and these are the AML which may cause obstruction. It's just to depict it. You can see this SAM in this M mode. Now we'll focus on eco findings. So I would like to thank my friend who gave me these slides. And first of all, the confirming of left ventricular hypertrophy is very important, whether it is symmetrical or apical. We have to see it. So hypertrophy preferentially involves interventricular septum in basal LV segments, but it may extend to other walls also and apex of pool. What are the eco criteria? As per European guidelines, thickness more than 15 mm in any segment is HCM. And the ratio of septal to posterior wall ratio of greater than 1.3 in normotensive subjects, and septal to posterior wall ratio more than 1.5 in hypertensive patients suggest hypertrophic cardiomyopathy. Alveoli obstruction, as I told you earlier, this is just one rule of 1/3. 1/3 patient have obstruction under resting condition. 1/3 have physiologically provoked gradients. 1/3 have non-obstructive forms. So the gradients more than 30 are significant. But if the gradient is more than 50, then it is undoubtedly a hypertrophic cardiomyopathy obstructive form. Assessment of mitral regurgitation. It is also important, as systolic anterior motion, which we call SAM, which result in failure of normal leaflet cooptation, causes mitral regurgitation. You can see this is the picture. The motion is attaching to the septum and it is causing anteriorly directed jet of mitral regurgitation. The next one is the left atrial enlargement, which is the very important. And for this, we usually follow the biplane method of left atrial volume, LAVI. And the values for this is left atrial volume index of more than 34 ml per meter square. More than 34 ml per meter square is predictive of greater degree of LVH and severe LV diastolic dysfunction. Latent obstruction. To assess it, Valsalva maneuver and exercise stress echo we usually recommend. But in our scenario, exercise stress echo usually, I haven't seen any clinician or cardiologist till date who has recommended exercise stress echo for me to assess LVOT obstruction. But yes, definitely Valsalva maneuver we do, and DSC is not recommended at all. So Valsalva maneuver is the good enough to assess the LVOT obstruction, to assess the latent obstruction. Another modality, 2D strain imaging, speckle tracking imaging is also important, which showed that the longitudinal strain with basal septum and apical septum are reduced significantly, while the circumferential strain is increased, and there is a normal twist or torsion reduction in untwisting in diastole. This is just because of the longitudinal strain is reduced. Now you can see, if you assess these are the septum, these are the septal strain, which is showing pinkish one, and the reddish one is having good strain. This is having good contractility, this is less contractility. And this is particularly in the mid septal segments. So strain imaging is also important for the assessment of HCM, and somewhere rule out with other infiltrative heart disease also, like amyloid or EMF. Assessment of systolic function. In patient with HCM, systolic function is typically normal or supernormal. Everybody knows that. But if the systolic function is reduced, then eventually it shows that the mortality of that particular subject is more, and it is 11% per year. And he's more prone to sudden cardiac death. So systolic function is also an independent predictor for the mortality. TDI imaging is obviously dropped, and it is reduced early diastolic mitral annular velocity in hypertrophic cardiomyopathy related to the magnitude of hypertrophy. Usually to the medial mitral annular systolic velocity of the medial one is less than 4 centimeter per second. You can see here also TDI velocities, and it is also an independent predictor death hospitalization for worsening heart failure. Diastolic dysfunction, important to assess, and HCM often have diastolic dysfunction, everybody knows that, but mostly indicating impaired myocardial relaxation regardless of symptoms or presence of LVOT obstruction. Patient with restrictive LV filling pattern at higher risk of adverse outcome even with preserved ejection fraction. So if the diastolic dysfunction goes up, it goes to grade 3, then the mortality is more, definitely. And this is a dagger-shaped obstructive pattern. Now, few predictors of unfavorable outcome. If the maximal wall thickness is greater than 30 mm, sudden death is more. HCM-related death, LVOT gradient at rest greater than 30 mm of Hg, or ejection fraction less than 50%. All-cause mortality, left atrial diameter more than 48 mm. Heart failure development, LA volume is 27 ml per meter square at baseline, but usually if it is more than 34, it is significant. The dysynchrony interventricular is more than 45 millisecond. Now, we are done with the echocardiography, and usually nowadays the gold standard modality to rule out whether the HCM is genetic or it is some deposition abnormality like infiltrative variety. CMR is the very important role. Magnetic resonance imaging is important, and when echocardiography is questionable, particularly in apical hypertrophic cardiomyopathy, we have to go for the MR. Systolic anterior motion is also good, widely visible in MRI. And especially if we are suspecting the patient with the amyloid or athlete heart or the Fabry's disease, gadolinium enhancement is the important modality. If the gadolinium enhancement is late in MRI, it represents myocardial fibrosis. Some histological pattern, like this is what we can see is the HCM fibrosis. This is the normal one. We can see the myocardial myofiber disarray and the interstitial fibrosis in the histology. See the thickened septum and the anterolateral part. Some varieties of hypertrophic cardiomyopathy and the subaortic variety, especially causing SAM, mid-ventricular variety, apical, this one, and diffuse all over. We'll go with the management of heart failure, and the medical management nowadays, the mavacamten is the first-class drug approved by FDA that is specific for HCM, but it is still not approved by Indian Drug Controller, Director General of India. It is still yet to approved in Indian pharmacopoeia. So it is a basically selective allosteric reversible small molecule ATP inhibitor of cardiac myosin that function by blocking the interaction between actin within cardiac muscle cells, which exerts a negative inotropic effect. It's a very costly drug, quite a costly treatment. And what we give usually in India and all over the world is the beta block, which is the first line of the management. Beta blocker is the standard treatment. Another who are contraindicated like calcium channel blockers and diuretic in later phase also. Patient having diastolic dysfunction, systolic failure, diuretic helps. Surgical modalities, septal reduction therapy includes septal myomectomy, reduces LVOT obstruction, alcohol septal ablation, and radio frequency ablation technique being studied for the left ventricle septal reduction, heart transplant in end-stage heart failure. And last but not the least, ICD is playing a very important role for the heart hypertrophic cardiomyopathy patients for the last 20 years and improving the mortalities. Some patterns mimicking HCMs are chronic hypertension, RV, right ventricular hypertrophy, cardiac amyloid, athletic heart, and valvular aortic stenosis. Thank you so much. Thank you for your patience.
Thank you, Dr. Khatri. It's very good insights on how to diagnose and how to treat the hypertrophic cardiomyopathy, specifically obstructive cardiomyopathy. Thank you very much.
Thank you, sir. Thank you, sir.
Dr. Jagnany, over to you.
I have a question for him. If beta blocker is contraindicated, which type of calcium channel blocker you want to give for this kind of patient?
We can give him verapamil also. We can give him diltiazem also.
Okay. Okay, so verapamil or diltiazem is the next option in case of beta blocker is contraindicated.
Undoubtedly.
Yes.
Uh,
Thank you so much.
So next we have Dr. Kumar Gaurav Sharma. I'm jumping one of the sessions we will take after that. Dr. Mrunal, kindly bear with me. I'm really sorry. He has some emergency to take up. So without your permission, I have just done this. I'm really sorry for that. So Dr. Kumar Gaurav Sharma is here to talk on ESC guidelines on hypertension. Dr. Nitin Shah is the chairperson. Over to Dr. Nitin Shah. Dr. Kumar Gaurav Sharma is clinical cardiologist at Dehradun and is member of various societies, including Heart Failure Association and American Heart Association. He is also organizing secretary for various conferences. So over to Dr. Kumar for this particular session. Dr. Kumar Gaurav. Dr. Kumar. Looks like there is some issues with him. In that case, I request Dr. Mrunal we go by the sequence, and I request Dr. Mrunal to kindly take up her session on fit or not to be fit.
Hello. Yeah, very good afternoon. Thank you, Dr. Vineet. Am I audible?
Yeah, you are audible.
Okay. So do I just open the PowerPoint straight away?
Yeah, sure.
Yeah.
I'll just.
Do I need to share screen or something?
Yeah, of course.
Okay. Okay. Is it visible?
Yeah, it's visible.
Yeah. Just. Okay. Yeah. So very good afternoon and a happy Independence Day to everyone. My regards to all the respected dignitaries, and a very thanks to all the organizing committee, especially Dr. Vineet, my dear colleague. So I thank you for this opportunity to present this very small, but nonetheless a very important topic from anesthesia point of view about preoperative fitness or checkup in anesthesia. So I would like to bring your attention to this first slide of mine. As is shown, this is a junior telling the consultant that the patient is not fit for thyroid surgery. So as usual, the surgeon would want to post it as an emergency. So this is the kind of scenario we are facing day in, day out regarding a patient being fit for surgery. So I would like to, in fact, so the topic, to be fit or not fit for anesthesia in Shakespearean language, that is the question. And I would say that it is a trick question, because I would say that there is no patient who is not fit for anesthesia. It is the anesthetist who needs to be fit or competent or confident enough to provide anesthesia, to provide the right kind of anesthesia to the patient that is presented to us. Because patient can be having several comorbidities. They may be geriatric, pediatric patients, and so on. So a quick introduction is the why is there a need for this pre-anesthesia checkup? So the need is that we can establish a rapport with the patient. Usually the patient comes in, we knock them out, render them under anesthesia, patient is woken up in the recovery, and then we are behind the scenes. So this allows us a chance to establish a rapport with the patient, to become comfortable with the patient. We can, tell them, we can make them aware about the type of surgery, the type of anesthesia they are going to receive. Because it's quite rude. Patient is coming in, we are poking needles in their backs, shoving tubes down their throats. And at least we can tell them what kind of anesthesia they are going to receive, reassure them that they are going to be pain-free throughout the procedure. They will not have any certain memory about, any painful memory about the procedure. And of course, it gives us a time to plan the course of anesthesia, knowing the patient's baseline criteria, parameters. It gives us an opportunity to identify any risks for the same. And most importantly, preventing cancellations for surgeries, which the surgeons are very, crucial about. So the basic outlines for my talk would be just about the definition, aims and objectives. I will cruise through. I know we are pressed for time. So pre-anesthesia physical evaluation, lab tests, planning, which goes through after these evaluations, and optimization. So the definition per se is, it is nothing but a systematic assessment. It is not a systematic assessment of the patient. Why systematic? I will come further. The aims are for patient optimization prior to surgery, because it improves the surgical outcome. And most importantly, it is also optimizing the anesthetist, because after assessing the patient, of course, in emergency, we barely get 5 minutes of time with the patient. But in case of elective surgeries, we do get time to assess the patient thoroughly. And it will introduce us to the various, we can anticipate potential problems, difficult airways, spines, the kind of major surgery, supra-major surgeries we are having to face. And it will optimize us, it will prepare us mentally, physically, to know what kind of patient is coming to us on table. So these objectives are, we understand the goals of all these preoperative testings. We can evaluate them, each component, we can evaluate, we can work on it. Patient sugars are not controlled, BP is not controlled, so we can optimize that. And certain evidence-based protocols we can formulate as to how we are going to go about giving anesthesia to this kind of patient with comorbidities and whatnot. And most importantly, a risk stratification. We need to know what risks we are going to face. Since you as physicians, you might be giving certain fitness to so many patients, and you are writing fit for anesthesia with due risk. So the due risk part is what we are going to face on the operating table with the patient. And it is our duty to keep the patient with his baseline parameters throughout the surgery, maintain his physiological parameters as far as possible throughout the surgery. So the pre-anesthesia evaluation, I can broadly classify it into a detailed history and physical examination and the labs, of course. So history specifics, I will not get into too many details. Obviously, the demographics, age, sex of the patient, where is the patient hailing from, the type of surgery that he's going to undergo, a detailed medical history obviously with the comorbidities, any allergies, whatever drug intakes, any addictions. And most importantly, any previous surgeries that the patient has undergone and any complications of anesthesia they have faced. So we had a patient, I can remember that she was coming for tubal ligation, pretty normal surgery. She gave us a history of having previous two LACs. And both the times she received spinal anesthesia, is what she claimed. And she says that the spinal anesthesia failed and I had to be given GA, which was very strange. We were contemplating, okay, we were like, we will give it our best shot, reduce manual errors, try to give a senior anesthetist to give the spinal and everything. But in spite of that, it still failed. And we did have to give GA to the patient. So these kind of, complications of any previous surgeries that the patient has faced, they do give us a history. It does help us in making certain plans. And a functional status of the patient, that is how much stress can the patient's cardiovascular system, respiratory system handle? Because undergoing surgery and anesthesia is extremely stressful. The patient is anxious, tachycardic, they can have panic attacks, their BP rises, they're tachycardic, they have palpitations, whatnot. So all these parameters go haywire once they are on table. And so for that, we need to know whether the stress can be handled by the patient. So what are their metabolic equivalents? As you know, one metabolic equivalent is nothing but the oxygen consumption that the patient, a person of say 40 years, healthy, 70 kg adult has at rest. So one metabolic equivalent, as you can see, is just by sitting and watching television. But you can achieve, if the person can achieve up to 10, 14, 15 metabolic equivalents, say they are tennis players, squash players, football players. So we know the amount of stress their cardiovascular system is going to handle, because even intubation can lead to severe hemodynamic changes in the patient. We need to know whether they can handle that. So this by bedside history, we can ascertain whether this kind of activity patient can do and sustain, so we can know how much stress the patient will handle. And after that, a physical systemic evaluation, obviously all the vitals, the nutritional status, the cardiorespiratory, all the systemic examinations that we can do on the bedside of the patient are important. Most importantly, anesthesia point of view, the airway of the patient and the spine. If we have to give GA, we need to know how the airway is, whether we are going to face any potential risks of any airway problems, whether we are able to ventilate, can we ventilate, can we intubate. Any anesthetist, it is a nightmare landing up in a situation where cannot intubate and cannot ventilate the patient. So God forbid any anesthetist should face this. So for that, there are certain bedside assessments that we can do. There is a Malampatti classification, wherein the size of the tongue as compared to the oral cavity is assessed, whether we can, wide mouth opening allows us to introduce the laryngoscope, whether we can see the posterior pharyngeal wall, the tonsillar pillars, the soft palate, everything. There is a gradation for that, and that gives us a rough idea about whether it will be a difficult ventilation or an intubation. And the atlantoaxial joint extension, that helps us in aligning the axial axis while intubating. So we need to know whether the patient can have a fairly good neck extension. Patients with ankylosing spondylitis, any cervical spine surgeries done, they will obviously have a restricted neck mobility. So that we need to know. And there is a 2-finger rule. Just basic bedside, 3 fingers mouth opening, 3 fingers thyromental distance, and 2 fingers a thyrohyoid distance. That gives us a fair view whether the larynx is anterior. We'll have to use certain other gadgets or to visualize the larynx or no. It gives us a rough idea. So these are all bedside, you can say maneuvers or tests we can do, assessments. We can do a quick assessment preoperatively. And after this, we have an American Society of Anesthesiology classification, where we grade after this basic examination as to whether he is in grade 1, ASA grade 1, 2, 3, and 4. As you can see, ASA grade 1 will be a completely healthy patient, no comorbidities whatsoever. Grade 2 will be having a mild disease but controlled. Grade 3, a severe uncontrolled disease probably. Grade 4, life-threatening, and a moribund patient. So in all these, whenever ASA grade 1 to 5, if they are coming for an emergency, we add on E as the grade, because even an ASA grade 1 patient in emergency can prove to be a complication for us. Then we come to the labs, the basic lab tests as given, dictated for any surgery, any age type and the type of surgeries are basic CBC, RFTs, LFTs, the sugars, the urines. BT-CT, PT, I would say for certain surgeries wherein certain blood loss is expected, we withhold for those kind of surgeries, or maybe ENT dental surgeries kind. So these guidelines help us, like CBC, we can detect any anemia, infections risk, bleeding risk, electrolytes for a renal disease, coagulation profile will tell us any bleeding diathesis, sugars obviously for their diabetes control, and the renal function, especially in elderly, because we are using nephrotoxic drugs at times, our inhalational anesthetics can be nephrotoxic, we need to know their baseline renal profiles as well. Certain special tests are reserved for patients undergoing supramajor surgeries, or it depends on the type of surgery the patient undergoing and the comorbidities that the patient has. So obviously for the cardiovascular system, as you know, EKG, stress test, a stress echo, 2D echo, these are all reserved for, I mean, if you are finding any difficulty problems with the ECG, we will go for a stress test. Obviously, they will come to cardiologists like yourselves to go further for their workup. But from our point of view, we can at least advise them, probably get a stress test done or an echo done to let us know what their cardiovascular system functions are. And obviously respiratory, we are dealing with, we are giving GA to the patient. We need to know whether the patient will be able to breathe on his own adequately. Under anesthesia, we are controlling, but as they come out of anesthesia, whether their respiratory system is equipped enough to withhold and to come out of the anesthesia comfortably. So in case of major thoracic surgeries, we do advise pulmonary function tests to be done for COPD patients, asthmatics, and so on. Then comes the anesthesia planning and the risk stratification after all these lab tests and evaluations are done. So as I told you before, ASA grading is done. A stop bang for obstructive sleep apnea. It is a mnemonic that we assess because obstructive sleep apnea can tell us a lot about their respiratory system, whether they will decompensate under anesthesia, whether they will be able to come out of anesthesia, whether they'll be able to breathe post anesthesia, post reversal or not. It tells us a lot about the this kind of obstructive sleep apnea patients. This is a simple mnemonic. It is stop, bang, stop for whether they are snoring, S for snoring, T for whether they have tiredness during the day, whether there is an observed, O for whether there is an observed apnea, whether the partner will be telling that they stop breathing at night all of a sudden. So if there is kind of observed apnea in the patient, whether they have high blood pressures, P for high blood pressures, whether they have a high BMI, usually obese, hyper obese, morbidly obese patients, or their age more than 50 years, a huge neck circumference, and the gender, usually males, will be having OSA. So if there is a scoring for that, and if they are scoring high for all these criteria, then we know that this patient will be either a difficult airway, difficult intubation, difficult ventilation, so on. Whether they will require ventilatory support post-operatively also. Then there is a least criteria, a revised cardiac index. Initially, there was a Goldman's index which was used. Now, recently, Lee et al. Have been, they have revised and they have introduced certain more criteria, 6 more criteria, as you can see, whether there is history of ischemic heart disease recently, congestive heart failure, cerebrovascular disease, diabetes requiring insulin, a chronic kidney disease, creat more than 2, and undergoing supramajor surgeries. So these 6 criteria added on, they have given a scoring index, predictors, whether they can have any myocardial events. in the perioperative period. So these are predictors. As you can see, the scoring shows 0 predictors. They will have still 3.9% chance of having any untoward event. As the predictors increase, the chances of having a perioperative cardiac event goes on increasing. So in such cases, we need to get the patients further evaluated, or maybe if it is an elective surgery, get the cardiac workup and cardiac fitness, and say maybe an angiography, angioplasty, or CABG or whatnot. Treat the cardiac problems first before they are on table. The next slide, sorry for being having a microscopic slide, I could not get. This is basically a roadmap which shows that a patient coming to us for a non-cardiac surgery. If it's a cardiac patient but coming for a non-cardiac surgery, and how to go about evaluating such kind of patients. This is a basic roadmap that we can follow. I'm sorry, it's not in a visible slide mostly, but I could not get a better slide for this. So it basically just tells us whether it is an elective, emergency surgery. If it's emergency, no questions asked. We just have to take the patient on table and accept whatever risk we have to face. But if it is an elective surgery, we can definitely work up the patient, assess the risk, do a risk stratification, whatever risk factors the patient has, such as if they may be having a severe valvular heart disease, pulmonary hypertension, and or they have had a bypass done recently, they have suffered an MI or stroke. All these things, whether we can get them under control and then get the patient on table, is what basically the steps that we have to follow. And lastly, optimization and pre-medication of these patients, obviously controlling the comorbidities. We say, please control get your blood pressures controlled, get your sugars controlled, and we advise them to continue their antihypertensives right till the day of surgery. Nil by mouth criteria, 6 hours at least for solid foods. To stop smoking, and optimization of the chest for especially thoracic surgeries or upper abdominal surgeries, wherein their chest can also get compromised post-operatively. We do advise on chest optimization and chest physiotherapy, which helps a great deal in the post-operative period. And good nutritional support, preoperative anxiolytics or sedatives as per need. Just the other day, we had a patient who was extremely anxious. She was an ASA grade 1 fit patient, healthy patient otherwise, but extremely anxious, extremely panicking at the thought of surgery. And unfortunately, we did not get time to give her any pre-medication, as we usually give some anxiolytics, but the patient arrived late. We did not have time. We had to take her on table immediately. And her BP was shooting high. The surgeon was uncomfortable. I had to get her blood pressures low. Her block did not act. Hyper anxious patients, their blocks also do not, unfortunately, they don't act well. And I had to give everything short of a general anesthetic for a local surgery. So these kind of problems we can face. So a basic preoperative examination will help us establishing a certain rapport, calming the patient down, reassuring them, and or pre-medicating them on a timely basis. And preemptive analgesia, I cannot stress more. Preemptive analgesia definitely helps us giving us, it reduces our drug requirements on table, and post-operatively also patient is more comfortable pain-wise. So the take-home message from my side would be a pre-anesthetic checkup. This is a most effective tool for us anesthetists. It helps us optimize the patient. It helps us optimize the anesthetist to know what we are facing on table. And it will definitely improve the surgical outcome, because since we are optimizing both patient and anesthetist, obviously the surgical outcome will improve with less complications. And most importantly, it will prevent any cancellations from happening. So I hope I managed to sum up this small topic. And thank you very much. Thank you, Vineet.
Thank you. Thank you so much, Mrunal, for being here. This is definitely a topic of importance, because invariably we physicians tend to face this situation of having an fitness, and we generally write, as you rightly said, fit with so much of risk, mild risk, moderate risk, and we do not probably understand which you have to face. So definitely thank you so much. And just to introduce her, of course, after the session, which has to be done before the session, she's anesthesiologist from Bombay, uh, and also trained at Canada with various workshops and award-winning sessions, both academic, non-academic, and she's also Limca and Asia book record holder for as a whistler, and she has also won a prize for that. So thank you so much. Thanking our chairpersons, Dr.
Thank you,
Vishal
Vinny.
and Dr. Sargam. Kindly accept the certificate. And
Thank
with
you. Thank you for this opportunity, Vinny. Thank you so much.
Thank you so much.
Yeah.
And with that, we move to our
I hope
next.
I was clear enough. Thank
Yeah,
you.
yeah. This was wonderful session. Uh,
Thank you.
For the next session, we have Dr. Kumar. Dr. Nitin sir is here to introduce him. He will be talking on hypertension, the ESC guidelines. Over to Dr. Nitin Shah. Dr. Nitin. Dr. Kumar is clinical cardiologist from Dehradun and is member of American Heart Association and European Heart Failure Association. He has also organized the conferences. He has been panelist and advisor for various conferences. So Dr. NAP from Mangalore, clinical cardiologist, and Dr. Nitin Shah from Vadodara are the chairpersons. Over to Dr. NAP, Dr. Nitin, and Dr. Kumar for the next session.
Thank you so much, Dr. Vineet. I hope you can see my slide.
139 slides.
No, I'm not going to show all of them. Don't worry.
Okay, okay. Thank you so much.
Right. Okay. Can you see my slides?
Yeah, yeah.
Okay.
Visible.
So, first of all, thank you so much, Dr. Vineet, for inviting me always. And I wish you all a very happy Independence Day. And not to delay anything more, basically, most of while this talk was going on, I had to actually hide a lot of slides because a lot of speakers have covered what I was going to say. So to minimize things, I have only now kept what is the most important part for the 2024 ESC guidelines. Another month and we'll have the 2025 guidelines. Not to delay any further. So the class of recommendation has remained the same. Nothing has been changed in this. Sorry, one second. So the new recommendations, right? So it is recommended to measure BP using validated and calibrated devices to enforce and correct measurement techniques. So this has become a class 1B now. And out of office measurement is recommended for diagnostic purpose, particularly because the white collar hypertension and mass hypertension, where out of office are not logically or economically feasible, then now it is recommended to diagnose we confirm with repeated office BP blood pressure measurement using standardized measurement techniques. Now, what apparatuses are being sold in India, I am not sure about their quality, but I normally recommend people to buy the Omron machines because they are, I think, decent and most calibrated in India. I have skipped a middle lot of slides which the previous speakers have already spoken about. So opportunistic screening with the office blood pressure measurements to monitor development of blood pressure during late childhood and adolescence, especially if one or both parents have hypertension, should be considered to be better predictive development of adult hypertension and associated CVD risk. And one more thing with people who are having children, it is recommended to restrict free sugar consumption, in particular sugar sweetened beverages, to a maximum of 10% of energy intake. It is also recommended to discourage consumption of sugar sweetened beverages such as soft drinks, fruit juices, starting at young age. And in patients with hypertension without moderate or advanced CKD and with high daily sodium intake, the increase of sodium potassium intake by 0.5 to 1 gram daily through sodium substitution with potassium enriched salt comprising 70% sodium chloride and 25% sodium chloride, or through diet such as fruits and vegetables should be considered. Hypertension in pregnancy, which already has been spoken about. Then older and frail patients. Also, it is recommended that the treatment of elevated blood pressure who are not moderate to severely frail follows the same guidelines as for young patients, provided the BP lowering treatment is well tolerated. And while initiating blood pressure treatment for patients who are 85 and above, uh, that is the patients who are severely flail, and long-acting dihydropyridine CCBs and RAS inhibitors should be considered. Then we are comparing the 2018 and 2024 guidelines. I am now going to be only concentrating on the ones which have some recommendations which have changed. Others I have already omitted because there was no point in having the same 2018 and 24 guidelines being spoken about. Okay. Previously, the recommendation that blood pressure classified as optimal, normal, high, normal, and grade 1 to 3 is now changed. The BP is now categorized as non-elevated elevated blood pressure, and hypertension to aid in the treatment decisions. There was a previously CV risk assessment score. Now the score 2 has come in, and it is recommended for assessing a 10-year risk of fatal and non-fatal CVDs among individuals aged 40 to 69 years with elevated BP who are likely already considered as an increased risk due to moderate to severe CKD. Okay, so now this is what the new dictum is. Comparison of the office, home, and ambulatory blood pressure measurement threshold for elevated blood pressure and hypertension. So non-elevated in office blood pressure measurement would be less than 120/70. Elevated would be from 120/70 to and less than 140/90, and hypertension would be more than 140/90. Then the whole blood pressure assessment is also similar, except that the higher values is 135 and 135 for elevated and hypertension also. Daytime ambulatory blood pressure monitoring, which is now recommended for all patients by ESC. Non-elevated BP would be blood pressure less than 120/70. Elevated blood pressure would be 120/70 to less than 135/80. And hypertension would be more than 135/85. And night time, which is also very important, is 110/60 and less than 120/70 is elevated BP. Hypertension is more than 120/70 at night. So this is the score 2, which was estimating incident cardiovascular event risk in older persons in 4 geographical regions. The green ones are the low risk, moderate is yellow, orange is high, and red is very high risk. So the model was computing the risk with sex specific coefficients such as derived in 28,000 individuals. Okay. And then we have the revised recommendations. This is the same what I was talking about, the score 2. Score 2 is recommended for assessing a 10-year risk of fatal and non-fatal CVDs among individuals aged above 70 years with elevated blood pressure who are not already considered as increased risk due to moderate or severe CKD, established CVD, and diabetes mellitus or familial hypercholesterolemia. And then we have class 1B indication, which was class 1C, where screening of his blood pressure is 140 to 160/90/99. Is recommended that diagnosis of hypertension should be based on out of office blood pressure measurement with ambulatory or home blood pressure. If these measurements are not logically feasible, repeated office blood pressure measurements, more than one, should be done. And where screening of his blood pressure is more than 160/100, it is recommended that blood pressure of 160 to 170/100 and diastolic of 100/109 be confirmed as soon as possible, and preferably by home or ambulatory blood pressure measurement. And it is recommended where blood pressure of more than 180/110 should be treated as hypertensive emergency and should be excluded in these patients. Uh, there has not been much change in investigating criteria. Echo is recommended again. And then pulse wave velocity. This is something which is new. Measurement in a non-invasive technique should be used to assess the arterial stiffness, which is a key indicator for cardiovascular health. It measures the speed at which pressure waves travel through the arteries. The higher velocities often indicating the stiffer arteries. So pulse wave velocity is calculated by dividing the distance between two measurement points by time, and it takes for the pulse wave to travel between them. So the moderate intensity, okay. Now treating elevated blood pressure, moderate intensity aerobic exercise, which for more than 150 minutes, that is at least more than 30 minutes, 5 to 7 days a week, or 75 minutes of vigorous intensive aerobic exercise per week over 3 days are recommended, and should be complemented with low or moderate intensity dynamic or isometric resistance training to reduce blood pressure and CVD risk. Uh, then it is also now this recommendation of body weight has changed. Previously BMI of more than 30, now it is 20 to 25, and the waist circumference values of less than 94 in men and less than 80 centimeters in women. So all the speakers, please take out the clothes you were wearing in college and start seeing if you can fit into them. Okay. Adopting a healthy and balanced diet, that is NASH dash, is now recommended. Then men and okay, now the most important topic which we do mostly post the conference is the alcohol. Okay, men and women are recommended to drink less alcohol than the upper limit, which is about 100 grams per week of pure alcohol. Well, how do you translate this in number of drinks? Depend on portion size, the standard of which differs in country to country. The most drinks contain 88 to 14 grams of alcohol per drink, so you have to calculate it accordingly. My maths is very bad, so I would recommend I request someone to please translate this 8 to 14 grams and tell me how much I can drink today after the conference. Okay, on the lighter note, among all blood pressure lowering drugs, ACE inhibitors, ARBs, dihydropyridines, calcium channel blockers have demonstrated to have most effective reduction of blood pressure, and therefore recommended as first line management. Uh, Okay. Now something what has changed is that if blood pressure is not controlled with three drug combination, in whom spironolactone is not effective, eplerenone instead of spironolactone should be used. Then right, because of right, this is not important. Right. This class 1A indication, older patients for more than 65 years, which was class 1A, has now become class 2C. That is that the CVD benefits of an on treated systolic blood pressure target of 120 by 129 may not generalize to the specifications of people who are clinically severely frail at any age. Okay. Renal denervation previously was 3B, now it is 2B. Already the speaker has already spoken about this, will not bore you by again telling you this. Okay, in women with gestational hypertension, starting drug treatment is recommended for those with confirmed systolic blood pressure of more than 140 or diastolic blood pressure of more than 90, which was class 1C previously, is now 1B. In pregnant women with chronic hypertension, starting drug treatment is recommended for those with confirmed office systolic blood pressure of 140, is now 1B. And this is old. ACE inhibitors, ARBs, are more effective in reducing albuminuria than other blood pressure lowering agents and should be considered as a part of treatment strategy, which has already been spoken about. Here there was not change, right? In patients with confirmed blood pressure of more than 130/80 with history of TIA or stroke, a systolic blood pressure target of 120 by 129 is recommended to reduce the CVD outcomes. This was previously 2B, now it is 1A. And for black patients, well, we don't have black patients, we're not treating them, so I'll skip that. And in patients resistant hypertension and uncontrolled blood pressure, despite use of first-line blood pressure lowering therapies, the addition of spironolactone to existing treatment is now 2A/B. With now, yeah, in patients with intracranial hemorrhage, immediate blood pressure lowering within 6 hours of onset should be considered to a systolic target of 140 to 60 to prevent hematoma expansion and improve functional outcome. This was 3A, now it is 2A. Okay. Recommendation for measuring blood pressure. We already said previously this it is that it should be through a calibrated device, Adult patients of more than 18 years should have their office and out of office blood pressure measurement. And mm, to rule out white coat hypertension and masked hypertension, out of office measurements should be done. If not possible, then repeated blood pressure measurement should be done in the office, that is in the clinic. And in patients with arm difference of more than 10 mm systolic blood pressure is recorded, then the subsequent blood pressure should always be measured from the arm which has the higher blood pressure reading. Okay, this was previously class 3, now it is class 1B. Okay, so summarizing, so out of office blood pressure measurements, people should be explained how to sit and take the blood pressure. We should assess for orthostatic hypotension at their first visit after the symptoms, and after the treatment has been initiated, at least once in 3 months, the orthostatic hypotension should be checked for. That should also be used for titrating their medicines. Then home-based blood pressure measurement, it should be a machine which should be calibrated, or we should ask them to bring their machines and we should check them in the clinics along with the blood pressure we are taking. And as because home blood pressure measurement is now also a dictum according to the ESC 24, and so is ambulatory blood pressure monitoring. So recording all the average readings is important. Then ambulatory blood pressure measurements, we should be used, should be done with a validated device. And hypertension with ambulatory blood pressure measurement is 130 by 80 over 24 hours, or 135 by 85, more than 135 by 85 in daytime average, or if it is more than 120 by 70 in the night average. So this is a very important thing when you're seeing an ambulatory blood pressure report. So as I already told you, so now there are 3 classes: non-elevated, elevated, and hypertension. So we already said this. So office blood pressure less than 120 and diastolic less than 70 is normal. Elevated blood pressure is 120 to 139 and diastolic of 79 by 89, and hypertension is more than 140 by more than 90. Okay. So yeah. Then high-risk cardiovascular conditions which warrant blood pressure lowering treatment among adults and elevated blood pressure. So these are the patients: CKD, other forms of hypertension, mediated organ damage, diabetes, familial hypercholesterolemia, established clinical cardiovascular disease. These are the patients whose target blood pressure is now to be adhered to very strictly. And the cardiovascular risk modifiers to consider for up classification of risk. So if you have a patient who has any of these, for the score 2, we have to increase the risk by 10%. That is gestational diabetes, gestational hypertension, preeclampsia, preterm delivery, 1 or more stillbirths, recurrent miscarriages, high risk ethnicity, familial history of premature onset cardiovascular disease, socioeconomic deprivation, autoimmune inflammatory disease, severe mental illness, and HIV. Okay, so these are the things which we increase the risk in score by 10%. I thank you for patient listening, and Jai Hind. Stay healthy and stay safe.
Thank you. Thank you so much, Gaurav. That was really, really fast, and I'm really thankful to you. Any comments, any questions for Dr. Gaurav? So kindly accept the certificate. Thanks, Dr. Gaurav, Dr. Nitin, Dr. NAP for chairing the session. Thank you so much. Somehow we are skipping some of the sessions. We are running quite late, so we are skipping some of the sessions. Kindly excuse us for that. So next we are moving to session from Dr. Hitanshu Panchal, who will be talking on stress echocardiography beyond CAD. Dr. Indra Panda and Dr. Jaya Sharma is the chairperson. Over to Dr. Indira and Dr. Hitanshu for the next session. They are clinical cardiologists from Bhubaneswar and Vadodara. So over to Dr. Hitanshu and Dr. Indra.
Thank you so much, Dr. Vinitsa, for kind introduction. Let me share my slide first, then I'll start discussing. Just give me 1 sec. The slide visible?
Yeah, it's visible.
Okay, then. Okay. So today I'm going to discuss about role of stress echocardiography beyond coronary disease diagnosis. So we all know it is commonly used nowadays to assess coronary disease. However, its application extends significantly beyond CAD, which provides crucial information in various non-ischemic heart disease like valvular heart disease, hypertrophic cardiomyopathy, diastolic heart failure or heart failure with preserved ejection fraction, and post-MI risk stratification as well as viability assessment. So I will cover all those non-ischemic heart condition and role of DSC step by step. So what are the limitations? Resting echocardiography. So because in case of resting phase, there is well balanced myocardial oxygen supply demand, then control heart rate, control blood pressure, whereas exercise or stress physiology will unmask that variation in heart rate and blood pressure during stress, which causes variation in preload, afterload, and subsequent variation in cardiac hemodynamics. And DSC has enhanced sensitivity for dynamic pathology that we are going to discuss in upcoming slides. So, sorry, yeah. So exercise itself is associated with an increase in cardiac contractility, heart rate, intracardiac flow, stroke volume, and subsequent cardiac output. If the cardiopulmonary system gets compromised by mean of ischemic or non-ischemic heart diseases, then there will be increased filling pressures, inadequate increase or actual decrease in ventricular function. There will be increased valvular gradients, increased valvular regurgitations, increased pulmonary pressures, and subsequent pulmonary congestion. So all of the above can be evaluated and it should be correlated with the symptoms of the presenting patient. Then in valvular heart disease, the role of DSC is applicable to aortic stenosis, especially low flow, low gradient aortic stenosis, to determine contractile reserve assessment. Then in mitral stenosis for symptom evaluation to determine pulmonary artery pressure response, especially in those patients who are asymptomatic and having more than moderate stenosis of underlying valve disease. Then it is also applicable in mitral regurgitation to determine exercise-induced worsening of the symptoms and decision making for surgery. So just give me 1 second. I don't know. Yeah. Okay. So first we'll discuss about low flow, low gradient aortic stenosis, where valve area is less than 1 centimeter square with mean pressure gradient of less than 40 millimeter of mercury, as well as stroke volume index that is less than 35 ml per meter square. So when all these three criteria are met, it is labeled as a low flow, low gradient aortic stenosis. And there are two possibilities to have low flow, low gradient aortic stenosis, especially in case of EF. So when EF is less than 50%, then it can be because of severe aortic stenosis with alveolar dysfunction. And in case of your EF of more than 50%, then it could be because of paradoxical low flow severe aortic stenosis. Then I'll explain you in upcoming slides. So first we'll discuss about formula for stroke volume calculation. It is nothing but the cross-sectional area. It is a product of cross-sectional area of alveoli and VTI of alveoli. That will give you stroke volume, and when you correlate it with the body mass index, it will give you stroke volume index. And cardiac output, we know that is a product of stroke volume into heart rate. So case 1, here we have a 69-year-old male with alveolus-systolic dysfunction of EF of 40%, having aortic wall area of 0.9 centimeter square, with alveolar aortic diameter of 22 millimeter and stroke volume index of 25 ml per meter square. Here you can see that patient is having AV gradient of 33/20 and LVOT VTI is around 14.8 centimeter. After initiating dobutamine stress echocardiography with a dose of dobutamine of 20 microgram per kilogram per minute, you can see the gradient has increased drastically with the peak gradient of 65 millimeter and mean gradient of 33 millimeter of mercury, with aortic peak velocity of 4 meter per square second, and alveolar VTI has reduced from 25 to 22.5, which consistent with the presence of contractile reserve. Sorry, my mistake. Yeah, it was before initiating dobutamine, it was 14.8 alveoli VTI. Now we have alveoli VTI of 22.5. So it has raised after initiating dobutamine, that is consistent with the presence of contractile reserve. And aortic wall area remains almost same, that is 1.0 centimeter square by continuity by VTI. So we can unmask true severe aortic stenosis by mean of dobutamine statistico in case of low flow, low gradient aortic stenosis. So it was true severe aortic stenosis in that patient. So whenever there is increase in Vmax of more than 4 meter per second with mean gradient rise beyond 40 millimeter of mercury and wall area remain less than 1 centimeter square after dobutamine statistico, we can label it as a true severe aortic stenosis. But if there is Vmax of more than 4 meter per square, second, with mean gradient of more than 40 millimeter of mercury, but wall area also raised similarly after initiating dobutamine, that is more than 1 centimeter square, then we can label it as a pseudo severe aortic stenosis. Okay, so again we have case 2 for mitral stenosis, but before that I'll explain you one more thing. So whenever we face or we come across low flow, low gradient aortic stenosis, make sure we should check all those 3 criteria that we discussed before, that is aortic wall area, then mean pressure gradient and stroke volume index, and for that you have to calculate patient body mass index as well. So whenever there is increase in peak velocity with subsequent increase in mean gradient and subsequent decrease in wall area, we can label it as a true severe aortic stenosis. But if there is a significant rise in there is increase in wall area, we can label it as a pseudo severe aortic stenosis. Now move on to case 2. An asymptomatic 68-year-old female with a history of rheumatic heart disease. The colored of Doppler study shows that valve area, this mitral valve gradient is 18/7, peak gradient followed by mean gradient, and the pulmonary pressure by mean of TI jet velocity was around 49 plus 10, that is around 59. So you can say the patient is having like moderate mitral stenosis by mean of gradient criteria with the moderate pulmonary hypertension. But after injecting dobutamine at a dose of 15 microgram per kilogram per minute, we can see here that patient became symptomatic with a complaint of dyspnea worsening, and there is significant increase in the gradient from that is 33/21 peak gradient followed by mean gradient, and there is significant rise in pulmonary hypertension by TIZ velocity criteria as well. So increase in wall gradient, increase in pulmonary pressure, and become patient is having or facing symptoms makes that moderate moderate mitral stenosis severe after injecting dobutamine. So that patient has been posted for mitral valve replacement. So what we have to interpret in case of severe mitral stenosis with no symptom by mean of stress echo. So if you have valve area less than 1 centimeter square, we have to look for the symptom development at log threshold. And if it is so, then it is in the class 1 indication for intervention by guidelines. Then if patient is having mitral valve area of 1 to 1.5, that is say moderate mitral stenosis, there should be development of symptom at low exercise threshold, especially if the main transmitral gradient if is more than 15 millimeter of mercury with pulmonary systolic pressure of more than 60 millimeter mercury. So in such scenario, again, it is a class 1 recommendation for intervention by mean of either BMV if while suitable for the BMV, or may go for mitral valve replacement. And again, if patient is having moderate mitral stenosis, prior pregnancy or prior to non-cardiac surgery, again we have to look at the same criteria that we have discussed in a previous previous line. But again, if patient is having severe pulmonary hypertension, pulmonary gradient of more than 50 millimeter of mercury with dobutamine statistico, again class 1 indication for intervention either by mean of BMV if it is suitable for BMV, or go for mitral valve replacement. And what to look for non-severe MS with symptoms. Say for example, patient is having moderate mitral stenosis. Again, we have to look at the mitral valve gradient. If it is more than 15 millimeter of mercury, mean gradient with pulmonary systolic pressure more than 60 millimeter of mercury on exertion, and there is early rise in PSV even more significant. Or we have to look at the transmitral gradient of more than 18 millimeter of mercury with dobutamine, and PSP response may sometimes not helpful just because difficulty in getting proper views, proper signal. So again, when there is a significant rise in the transmitral mean gradient, again patient is eligible for the intervention, and patient is having mild mitral stenosis, that is mitral wall area of more than 1.5 centimeter square. We have to look again transmitral gradient of more than 50 milliliter of mercury, rise in the pulmonary pressure on exertion, and then it is class 2B indication for BMV if it is suitable for the BMV, or we can go for the optimal medical management. What to look for in case of mitral regurgitation in case of stress echocardiography? So if patient is having severe mitral regurgitation and if patient is asymptomatic, but there is a development of symptom with the stress, with there is increase in RVSP or PSP of more than 60 milliliter of mercury, there is a development of LV dysfunction or onset of atrial fibrillation, abnormal heart rate recovery, then in such scenario we have to go for mitral valve replacement. Again, if patient is having secondary mitral regurgitation, severe mitral regurgitation, severe, but patient is asymptomatic, but there is RWMA development consistent with the ischemia territory, there is a development of acute pulmonary edema without obvious cause, and effective regurgitant orifice area increased by more than 13 millimeter, then again patient is eligible for mitral valve replacement as early as possible. And in case of moderate MR, again patient is become symptomatic, there is a increase in the severity of MR from moderate to severe. Again, such patients should be posted for mitral valve replacement after having documentation from dobutamine stress echo. Then we have to look for pulmonary hypertension. So we have to look for exercise-induced pulmonary hypertension. It will be helpful to diagnose early detection in case of systemic sclerosis, scleroderma, and evaluation of unexplained dyspnea. So again, you can see here, whenever there is a need for diagnosing pulmonary hypertension or there is a need for determining underlying RV function, so again dobutamine stress echo will be helpful. So for such scenario, we have to calculate right ventricle S prime velocity, TAPSE. We have to look for right ventricle free wall longitudinal strain, and TR gradient, which will be useful for determining pulmonary arterial systolic pressure or RVSP. So you can see here in baseline, the TAPSE divided by PSP, the score is around 0.48, whereas right ventricle free wall longitudinal strain divided by pulmonary arterial systolic pressure is around 0.9, and these are the indicator of underlying subclinical RV dysfunction, systolic dysfunction. So these are the normal values, but when patient is posted for dobutamine stress echo and after giving dobutamine, you can see here the values become decrease. So again, the TAPSE by PSP score became 0.22, and right ventricle free wall longitudinal strain and PSP ratio become 0.41. So it has this value got reduced from the baseline value. So again, by mean of these values, we can say that patient is having subclinical RV dysfunction, patient is having pulmonary hypertension tendency during exercise. So such patients to be treated according to guidelines. So whenever patient is having normal LV ejection fraction, patient is having baseline E by E prime normal, but again patient is having unexplained dyspnea, there comes the role of DSC to calculate not only pulmonary artery pressure, but we have to calculate TAPSE, we have to calculate right ventricle free wall longitudinal strain as well as right ventricle S prime velocity, and all those parameters to be included during doing DSC to determine the underlying cause of dyspnea. And when we have decreased value, it will tell you about RV dysfunction as a underlying cause of dyspnea. Then comes the famous topic, that is HFpEF, that is respiratory dysfunction, which is most commonly diagnosed nowadays by mean of dobutamine stress echo as per the recommendation from famous guidelines. So we have to look at the E by E prime during stress, and it will also helpful in those patients having exertional dyspnea but normal resting LV ejection fraction. So you can see here, whenever there is having normal myocardial relaxation with normal diastolic function, E by E prime, they both values get increased before and after injecting dobutamine. So when you have near normal E by E prime before and after dobutamine systolic, we can say that patient is having good myocardial relaxation and normal diastolic function, and then we have to explain that patient that underlying dyspnea may be off because of some other non-cardiac causes. But when there is a increase in mitral E velocity with subsequent decrease in mitral E prime velocity, it will cause significant rise in E by E prime ratio. That is consistent with the increase in LA pressure or LV filling pressure, and that will explain you unexplained dyspnea or especially exertional dyspnea. So whenever there is a pattern with normal E by E prime before DSE and there is increase in E by E prime velocity or ratio after DSE, that will tell you about impaired myocardial relaxation and subsequent underlying cause of dyspnea. Now, fourth indication is hypertrophic cardiomyopathy. We have to find out underlying dynamic alveolar gradient. Most of the time, they remain asymptomatic. They remain undiagnosed because of latent HCM. So by mean of dobutamine stress echo, we can make them diagnosable. So, and it is also helpful not only in diagnosing but also helpful in risk stratification and also helpful in guiding treatment whether patient is eligible for myectomy or alcohol septal ablation. So here we can see here that patient is having maximum peak gradient at the level of LVOT during resting phase. It is around 17.9 millimeter of mercury, which is non-significant. But during Valsalva, it started rising. During standing, it is also again increasing to near 20. Then post dobutamine, we can see that gradient increase from 18 to 67.5. And post 30 seconds of dobutamine injection, it has significantly increased, again remains near to 67, 65. And post 6 minutes, it started coming back to normal. So we can see here, before initiating dobutamine stress echo, the gradient was not significant, but with the dobutamine stress echo, it becomes evident. So this kind of HCM is labeled as a latent HCM, where you have normal gradient during resting phase, but on provocation, it becomes elevated. So such patients should be eligible for therapy. Then it will helpful, as I told you before, that will be helpful in deciding underlying treatment strategies, whether go for myectomy or alcohol septal ablation. So DSE can help identify the precise location of obstruction, guiding the surgeon in resecting the appropriate portion of hypertrophied septum during myectomy. It also helps determine the adequacy of myectomy by assessing the residual gradient after the procedure, again by mean of DSE and resting phase, and if further muscle needs to be resected to relieve the obstruction. Whereas DSE also helpful by for guiding ASA, that is alcohol septal ablation. So DSC can identify the specific septal branches or branch supplying the obstructive portion of the septum, and it will guide the precise injection of the alcohol to induce the control infarct in the target area. Then prosthetic valve evaluation, the concept remains similar to that we have discussed in valvular heart disease, so I am not going in much detail about the prosthetic valve evaluation. Then intracardiac shunt. Few centers are using DSE to determine the intracardiac shunt, to determine PFO with exercise, just to document whether patient is having platypnea, orthodeexia, or dynamic shunt reverse. That is nothing but the determining or unmasking the Eisenmenger syndrome. Okay, but what are the limitation? Because echocardiography may alone it not accurately quantify the shunt ratio, that is QP/QS, because it is a critical factor in determining treatment option. So why is it so? Because estimating blood flow using echo data technique can be unreliable due to assumption that laminar flow and fixed cross section area, which may not hold true in case of turbulent or variable flow, that is common in case of congenital heart disease. And in some cases, we need to back up by mean of prescribing cardiac MRI or cath study. So that's why use of DSE in intracardiac shunt is very limited. It is to be done under observation by experienced personnel. Then chronopic incompetence, similar to treadmill test, we have to look out for the blunted heart rate response, especially in those patients which are having syncope or infarct intolerance. So if you have blunted heart rate response during dobutamine stress echo, peak dose of dobutamine stress echo, again we can label it underlying cause for having syncope or effort intolerance in the patient. Then we have to determine left ventricle contractile reserve. So it is helpful in case of LV function evaluation in case of cardiomyopathy, CRD response in case of cardiomyopathy, and heart failure prognosis. And now, what is contractile reserve? It is nothing but the heart's ability to increase its contractility beyond its resting level, either during exercise or with medication like dobutamine. So those patients who are having improved or having good contractile reserve, they are having good prognosis, they have good outcome with the CRT implantation. Then myocardial viability, which is similar to application in coronary disease. So If there is a viable myocardium, then it will be like biphasic response where the dysfunctional segment or akinete or hypokinetic segment improves its wall motion at low dose of dobutamine, but then worsens at the high dose due to oxygen demand supply mismatch. Whereas non-viable myocardium, there is no any improvement in wall motion whether at the low dose or peak dose of dobutamine stress echo, and they are considered as a non-viable or scarred myocardium. And those persons having viable myocardium, they will be having good prognosis after undergoing reoxygenation therapy, and those persons having scarred or non-viable myocardium, there will be no fun with the underlying with the rehospitalization, and they have bad prognosis or outcomes. Additional applications, as I told you before, that is dynamic MR, functional MR quantification, transplant heart evaluation, similar application, a similar concept that we have discussed in previous slides, and athlete's heart versus pathology, that is the role of E by E prime that we have discussed. So those patients having athlete heart, their E by E prime will remain normal even during peak dose of dobutamine stress echo, whereas in case of pathology, there will be increase in E by E prime. So the listing of increase in LV filling pressure. So that will helpful by differentiating whether patient is having athlete's heart or pathology abnormal relaxation. What are the common limitation and pitfalls in DSC? So it depends on the operator who is performing, how is performing. Then limited acoustic window, because most of the time when patient is having increased heart rate, that will be very difficult to achieve good views, and it requires expert interpretation, especially in case of valve function evaluation as well as I told you before, myocardial viability assessment. Future direction, so AI assisted interpretation, integrating strain imaging during stress, and portable handheld stress echo that will come in upcoming futures. So summary, stress echo is a dynamic versatile tool. It is having valuable value beyond CAD diagnosis, and it is helpful in providing personalized cardiac care in patients suffering from non-valvular non-ischemic heart disease as well. So thank you audience, chairpersons, and Dr. Vinit Jagnany and team Clinet. I'm very thankful to you all and happy independence to you all. Thank you so much.
Thank you so much, Dr. Hitanshu and Dr. Jaya and Dr. Indra. Since we are running late, we have skipped some of the lectures. Next, we are moving to Dr. Tarang Shah's lecture. And before that, I request our current speakers to kindly accept the certificate online. Thank you so much.
Thank you so much, Dr. Jagnany.
Thank you so much, madam. We are missing this one as of now. We'll try and make up sometime later, maybe. We are missing this one also as of now. So this one also we are missing. Very sorry to the chairpersons. We have taken a consent from the speaker for missing these lectures. So we have an important lecture from the speaker of the day, antiplatelets and surgical procedures, by Dr. Tarang Shah, who is an interventional cardiologist at Vadodara with various posters and papers to his credit. To chair the session, we have Dr. Pramod Bansod. We also have eminent electrophysiologist with us online. Dr. Yash Lokhandwala sir is here. So over to Dr. Tarang Shah for the next session, and of course input from Dr. Yash Lokhandwala sir.
Good afternoon, everyone. Am I audible?
Yeah, you are audible, doctor.
Happy Independence Day to all. Thank you, Dr. Prakash sir, Dr. Vinit sir, for inviting me. So this is very important topic, antiplatelets and surgical procedure. As antiplatelets are one of the most commonly used class of and I would say in some vascular disease remains the leading cause of CVD. Mortality has nearly doubled from nearly 270 million to 520. Routine PCI procedures and worldwide increased focus on cardiovascular risk factor modifications. Deaths have certainly decreased from cardiovascular disease, which has actually decreased over 50% in some of the countries. Again, antiplatelet therapy forms the cornerstone for the management of patients with CVD, and prescription of P2Y12 inhibitors have increased significantly in recent years. The issue of management of patients who are receiving antiplatelet therapy who requires a surgery or procedure is very common. In a higher risk of group of patients who have undergone recent PCI or coronary stenting, 4 to 6% of patients will require major surgery in the year following the PCI. Before going into the details, I would like to highlight the mechanism of action. The most frequently prescribed antiplatelet drugs are aspirin and P2Y12 inhibitors like clopidogrel, ticagrelor, and to a lesser extent prasugrel, which is commonly used in certain high-risk population. Antiplatelet monotherapy usually comprises of aspirin or clopidogrel, whereas DAPT refers to the combination of aspirin with P2Y12 inhibitor. So if we briefly look into the mechanism of action, aspirin inhibits the COX-1 enzyme, which inhibits the formation of thromboxane A2 and ultimately decreases the platelet activity. Whereas P2Y12 inhibitors inhibits the binding of ADP to P2Y12 receptors. So ultimately, which leads to decreased formation of fibrinogen-mediated platelet activity. So summarizing, aspirin, clopidogrel, prasugrel, all are irreversible inhibitors of patients taking antiplatelet agents involve multiple consideration, including the indication for antiplatelets, why it was primarily started, whether it was initiated for primary prevention or whether it was initiated for secondary prevention, where patient has suffered from ACS, patient is suffering from chronic coronary syndrome, use of DAPT or monotherapy, whether the surgery is required urgently or we can plan the elective procedure, and associated bleeding and thrombotic risk. So we have to balance whether patient will have high bleeding risk, thrombotic risk are high or low. So low thrombotic risk conditions are patients with coronary artery disease who do not have implanted, who are not implanted with CAD with DES who is more than 12 months old, CVD, atherosclerotic peripheral vascular disease. And high risk individuals are those patients who have undergone PCI less than 12 months. So if we look into the patient spectrum, like we will divide into C, V, and D. C means prior coronary event, high risk coronary anatomy, like patients with left main PCI, bifurcation PCI, patient having multivessel disease, vascular events like established peripheral arterial disease, cerebrovascular disease, and patients having diabetes who's suffering from CKD, patients having micro and macroalbuminuria, and patients suffering from heart failures. Those patients with chronic coronary syndrome and these clinical risk factors are calling into the high thrombotic risk categories. So if we divide the surgery into three parts, there are certain surgery which are associated with very low or low bleeding risk, some are moderate risk, and some are very high risk procedure. So what are the very low risk procedure? Dental extractions like 1 or 2 teeth only, endodontic procedures, cataract surgeries, dermatological procedures like simple biopsy, simple coronary angiography, pacemaker implantation, yeah, pericardiocentesis or arthrocentesis are very low risk procedure. At the same time, what are the very high risk procedure? Any surgery which involves the spinal or epidural anesthesia, neurosurgeries, cardiac surgeries like CABG surgeries, major intra-abdominal surgeries, major vascular surgery like aneurysm repairs, lung resection surgery, urological surgeries, moderate risk surgery, which excludes both of the same, like gastroscopy, colonoscopy, and selected procedures like bone marrow biopsy or lymph node biopsy. So if we look into all of the guidelines, it is very confusing. All of the guidelines says that in elective procedure, you can continue the aspirin, clopidogrel should be stopped at least 5 days prior, ticagrelor should be stopped 3 days prior, and prasugrel at least 7 days priorly it should be stopped. But in the neuroaxial procedures, guidelines are controversial. There are no specific recommendation. In high risk procedure, it is said that we should avoid aspirin also. And in some of the very high risk procedure where thrombotic risk is very much high, there it should be bridged with the IV platelet inhibitors. So, these are the therapeutic risks. All the antiplatelets like dual antiplatelet therapy has to be stopped for the required. Therapeutic risk is very high. We have to stop the antiplatelets, but we have to bridge with tirofiban or FTP by where bleeding risk is also low and thrombotic risk is also low. Aspirin has to be continued, but clopidogrel, prasugrel, and ticagrelor has to be stopped for the required period of time. And as soon as after the surgery is completed and bleeding is controlled, we have to again initiate the aspirin and other P2 Y12 inhibitors with the loading dose. So, if we go by monitoring management of patients who are on aspirin monotherapy, having low to moderate bleeding risk surgery, where interruption is in patients who have undergone PCI or stenting, perioperative aspirin continuation was associated with significantly lower rate of non-fatal myocardial infarction without significant increase in major or life-threatening bleeding. If a clinical decision is made to withhold the aspirin prior to high-risk bleeding procedure, adequate recovery of platelet function for hemostasis can be expected within 3 to 5 days following cessation. So multiple guidelines like ESC and 2022 American College of Chest Physician guidelines would say you should stop the aspirin at least 5 days prior to the procedure if you are planning to stop the aspirin. British Society of Hematology says that 3 days of aspirin interruption is sufficient. And for patients taking high dose aspirin, the American Society of Regional Anesthesia says that discontinuing of aspirin more than 3 days prior to the planned procedure is required. Next, we will go into the P2Y12 inhibitors. DAPT is commonly used in patients who have undergone PCI with coronary stenting insertion. Up to 14% of these patients may require surgery in the coming year. So rates of major adverse cardiovascular events, which includes the death, myocardial infarction, and stent thrombosis, are particularly high during that 1 year period. And maximum chances are in the first 6 weeks after the stenting. So timing of discontinuation depends on the drug pharmacokinetics and patient's hemodynamic risk and procedural bleeding risk. Platelet inhibition persists for longer following prasugrel cessation. The current major guidelines therefore recommends that ticagrelor and clopidogrel should be ceased 5 days before surgery, and prasugrel requires at least 7 days. For patients who require non-cardiac surgery with a history of recent MI or who have undergone PCR or stenting, surgery should be ideally postponed until the time DAPT is required. That is a minimum period of 1 to 3 months based on the patient underlying illness, underlying hemodynamic stability, underlying LV dysfunction and everything. Both ESC and American Heart Association currently recommends at least 6 months of DAPT after PCI and 1 year who have suffered from ACS. So in chronic coronary syndrome who have undergone PCI, 6 months is optimal, but who have suffered from acute coronary syndrome, whether STEMI or NSTEMI, at least 1 year of DAPT is optimal. So current recommendations suggest that a minimum period of 1 month should be elapsed after elective PCI and 3 months after the ACS before patient can even think of patient is planning to undergo non-cardiac surgery. So this we have all discussed about the elective surgery, but if patient requires the elective surgery, if patient is suffering from some disease with high thrombotic risk, bridging therapy can be considered. What is bridging therapy? So bridging therapy in the context of perioperative DAPT management refers to the interruption of P2Y12 inhibitor and aspirin both and starting an intravenous short-acting antiplatelet agent, which can be stopped shortly before the surgery. Bridging agents include the GP2B3A receptor antagonists like eftifibatide and tirofiban, and the intravenous P2Y12 inhibitors, which is short-acting antiplatelet agent like cangrelor. So what is exactly bridging therapy? As I previously said, in elective procedure, we have to stop prasugrel 7 days before the surgery. Clopidogrel, ticagrelor has to be stopped 5 days before the surgery. Aspirin can or can do in high thrombotic risk in scenario. We can start GP2B3 inhibitor or cangrelor at least 3 to 4 days prior to the planned surgery, and it has to be stopped 1 to 6 hours before the surgery. And then after the surgery is completed, we can again start with directly with the loading dose of antiplatelet, or again we can do the bridging therapy where we can start again this cangrelor and GP2B3 and inhibitor antiplatelets until the efficacy of these antiplatelets is achieved in the blood. So this until now we have discussed about the elective surgery, but what about the emergency surgery? Patient who have undergone PCI or patient who are on DAPT may require emergency life-saving surgery. So unlike warfarin or direct oral anticoagulants, there are no reversal agents available specific to the antiplatelet agents. So when the patient taking DAPT requires the emergency surgery after immediate cessation of P2Y12 inhibitor, non-specific therapies can be considered like platelet transfusion or administering lexamic acid or desmopressin. But we have to explain the patients that there may be increased chances of MACE in the perioperative period. Whether this strategy is likely to improve or potentially restore hemostasis is unknown. The evidence in support of platelet transfusion is also sparse. So even in the event of life or limb-threatening bleeding in those taking DAPT, emergency surgery, aspirin can be effective Y12 inhibitors. High doses of clopidogrel associated bleeding. And ticagrelor cannot be effectively reversed by the platelet transfusion because it is long-acting. So we have to wait for at least 24 hours before giving the platelet transfusion who are taking the ticagrelor therapy. So if patient requires emergency surgery, we have to consider the last intake of antiplatelet drug. If patient is on aspirin monotherapy, only 2 adult doses of platelet transfusion are sufficient and surgery can be considered. If patient is taking clopidogrel or prasugrel, 2 to 4 adult doses of platelets are required, and clopidogrel and prasugrel's last dose should be more than 6. And if the patient is on ticagrelor, platelet transfusion may not be helpful and usually ineffective if the last ticagrelor is taken within 24 hours of the surgery. So, in the end, I would like to summarize when to withhold the antiplatelet agents. We will divide into 2 parts, elective and emergency surgery. In elective surgery, aspirin, usually it is safe to continue. Clopidogrel, stop 5 to 7 days before. Prasugrel, stop 7 days before. And ticagrelor, you have to stop the 5 days before. If patient is very high thrombotic risk, consider the bridging. And in emergency surgery, platelet transfusion can be considered, but its efficacy is largely unknown. Thank you. Thank you very much.
Dr. Tarang, आप presentation इतना अच्छा था. Everybody is asking for your slide. Kindly share if you are comfortable. Any comments, any questions for Dr. Tarang?
Yeah, sure.
Yash Lokhandwala sir is here. He can have some comments, some opinion. Any other questions for him?
Am I audible?
Yes, sir.
Yes,
So
sir. Yes,
I
sir.
think it was an excellent talk because these are very practical problems, and we are increasingly, all of us will be facing these problems with the number of antiplatelets going on. The question comes in the in urgent surgery, emergency surgery. We are of course going to go ahead, but many times the problem comes in the urgent surgery, and we feel that sometimes we are like many times we have to do pacemaker urgently. So we just go ahead, even if there is a single antiplatelet, there usually should not be a problem. Surgeons sometimes do an urgent bypass with dual antiplatelet going on. So Cangrelol has been a big plus point when it comes to it, but I think it's quite expensive. So in the practical setting, I think as long as you have got a good hemostasis, then one should not defer surgery just because of antiplatelets unduly. Of course, with a spine surgery, there is no question. There are certain very critical areas like spine, but otherwise, or brain. But otherwise, one should not defer or urgent surgery just because of that fear of the antiplatelets. It should not be over. You should, not let the patient suffer just because of that.
Thank you.
Thank you. Thank you so much, sir. Anything else for Dr. Tarang?
For example, I may just add, for a
Sure,
cataract surgery, we don't even have to stop the antiplatelet. But very few ophthalmologists I see will do a cataract surgery if the antiplatelet is going on. So we just need to have more
Exactly.
awareness.
Even the same problem with dentists, sir. If we say on the paper, yes, yeah, you can continue the aspirin, but many of the dentists are also not comfortable with continuing the aspirin in simple tooth extraction also.
Good afternoon, everyone. Gaurav this side, the only cardiac surgeon around. So the thing is important to understand as per the guidelines, even vitamin K antagonist need not be stopped for a cataract surgery. Those are the recommendations. And secondly, aspirin in the dose of 150 milligram, if it is continued intraoperatively during a CABG or any other surgery also, it reduces drastically the risk of stroke. So these two take-home messages from a surgeon's side. Thanks a lot for having me first. And because we forget that everything is important. Even a 150 mg of Ecosprin never increases your re-exploratory rates or bleeding rates or transfusion rates, and that is proven beyond point, at least for cardiac surgery.
Yes, sir. So with this, we now have Dr. Goel sir here. We'll have some insights from him also. Before we move to the next session, I request Dr. Tarang to kindly accept the medallion and the certificate also for our chairpersons. With that, we move to our next session to Dr. Gaurav Goel's sir's session we will have. We are skipping one or two in between as of now. So for the next session, we have Dr. Gaurav Goel, who is cardiovascular surgeon with plenty experience of more than 20 years, a specialist in adult cardiac surgery with including high-risk coronary surgery and total arterial bypass surgery also with valve replacements, and minimally invasive surgery also is doing, including aneurysms, which is off pump beating heart surgeries, what not. So for that, he is now again adding on to the previous talk with anticoagulants guidelines post MVR and AVR, and he will be talking as Shushrut Samvad speaker. And for that, we request him to kindly accept the medallion before the start of this thing.
Thank you, sir. Thank you. Thanks a lot, sir.
And now I'll try and share Sarka slide.
सर आई एम ऑन अ लैपटॉप लेकिन मेरे को शेयर करना आता नहीं है.
नो इशू सर, आप सर्जरी कर रहे हो ना, ये सब काम हम लोग कर लेंगे. Just a minute, I'll just share it.
I'm trying, but I'm unable to share it.
Sir, do you want me to guide you? Hello.
It's a small presentation.
Sir, there is a... Okay, Vinit sir is sharing.
Yeah. Sir, I guess slides are visible.
Yes, sir. Thanks a lot.
Yeah. Over to you.
So I'll start, sir. First, thanks for having me and happy Independence Day to all of you. So the thing is that I'll be talking of something which is very dear to me, and that is anticoagulation in prosthetic heart valves. The thing is, changing a valve is like substituting one disease with another disease. Valve बदलना बहुत आसान है. For a surgeon, for like me, it's a 2 hours job, skin to skin. But what we don't realize is if we don't manage these patients for 20 coming years of their lives with anticoagulation, we are definitely going to fail in the long-term requirement of the procedure that we are doing. So next slide, please. Can I have the next slide, sir? So what is anticoagulation is basically the process to stop blood from clotting. And we use it for AFibs, we use it for DVT patients. And today I'll just be talking on prosthetic heart valves, and vitamin K antagonists are the class which is the most commonly used in our day-to-day clinical practice. Next slide, please. Next slide. So this is a vitamin K and produced by the liver, and most of the anticoagulants, they will work as antagonists of vitamin K. So we know we call them VKAs or vitamin K antagonists. And we all know that there is a simple blood test, which is PT-INR, which tells us about the effect of these agents. By increasing the PT-INR, we come to know how much the blood is fluid or not going to clot. So these two things for today's talk are important. One is VKA and second is PT-INR test. Next slide, please. So these are the two main VKAs which are available worldwide and used most commonly. One is warfarin, we all know as warf, and second is acinocumarol, we all know as acetrom. And there are many other drugs also available. So both are rapidly absorbed. Both have a half-life which is different. Here is the point we have to understand, that warfarin has a very long half-life, something around 2 to 3 days, compared to acinocumarol, which is having a short half-life. So reversal of acinocumarol is faster and easier. Again, if you'll see the next point, effect on prothrombin time, it peakly starts at 4 hours and effect comes into 24 hours, whereas acinocumarol is a faster acting, short half-life molecule, wherein the effect comes up in 15 to 20 hours. So post-surgery, if there is a double valve or something and we want to initiate anticoagulation faster, so we use acinocumarol. But warfarin is an equally good drug. Believe me, we've been using both with good results. Next slide, please. This is something as family physicians we need to know, that there are some diet interactions of VKAs, wherein foods which will be containing high amount of vitamin K are definitely going to interfere with the absorption and the pharmacokinetics of VK antagonists. So green leafy vegetables, beans are the main things which you have to tell your patients when he is on these drugs to limit or avoid. There are some fish like cod liver oil, tuna oil, which we should resist from having, and such is the case. Next slide, please. So what is the evidence as per the current practice of vitamin K antagonists, or commonly what we are discussing today, anticoagulants post-valve scenario and in a patient with prosthetic valve? So in 2019, our association, Indian Association of Cardiothoracic Surgeons, we came up with a Indian clinical practice, wherein I was also a part of that team, and we formulated clinical practice guidelines for the whole country. And this is the only clinical practice guideline available for Indian patients. So if you see with a mechanical bioprosthesis, you should, as a thumb rule, if there is a valve in the aortic position, the INR should be 2 to 3 without risk factors. With risk factors, 2.5 to 3.5. In MVR, 2.5 to 3.5. In double valve, 2.5 to 3.5. And you should add an antiplatelet agent, something like aspirin, up from 75 to 150 milligram, which I'll tell you when to put it to 150. And if you can start with warfarin, it is a cheaper molecule, and if you have reached a maximum dose of maybe 10 mg and the patient is still, you are not able to achieve the targeted INR, then you should shift to acinocumarol. So this is the wide, broad-based thing. As a doctor who is in day-to-day practice, to remember a range of 2.5 to 3.5 across the board for all patients with mechanical bioprosthesis, whether high risk, low risk, or in aortic or mitral position, is fair enough. So if you just in your practice put them to 2.5 to 3.5, you are doing more good than harm to the patients. This is again a table which tells you what kind of valve, what kind of INR should be achieved. I'll be sharing the presentation with you for the archive, so you can take to on it later. Next slide, please. So in a bioprosthesis, even there we need some kind of an anticoagulation for at least 3 months. And the target INR, irrespective of any valve or number of valves, should be 2 to 3, because it takes at least 3 months for the struts as well as the cloth on which the bioprosthesis is laid to get epithelialized. Once it is epithelialized in 3 months, then the risk of thrombosis is minimal. Next slide, please. Nowadays we do a lot of TAVIs. So this is something where anticoagulation has taken a next step ahead. So post-procedural plain aspirin or clopidogrel is more than enough, that the current literature says. Next slide, please. So as a clinician, we are more interested as how to initiate and how frequently should we adjust and monitor the INR of our patient who is who has undergone a valve surgery, either in the mitral or aortic position, whether mechanical or a bioprosthesis. So this is the thumb rule, that you initiate it with 5 mg warfarin or 2 mg acinocumarol on day 1 of the surgery. You take a baseline INR and repeat INR after 2 to 3 doses. So you'll start with 5 mg or 2 mg OD, same time every day, at least 2 hours empty stomach, and then do it after 72 hours or prior to discharge. So the next slide, sir. So if you have achieved the target INR, then you are happy and you will repeat it on the first follow-up. If you haven't, then you try to do it itsy bitsy things. You'll increase or decrease as per the INR, achieve an INR of 2.5 to 3.5, and then start working on it. The next slide elaborates how the dosing can be done. This is an elaboration for warfarin, that if the INR is less than 1.5, what you should do. If it is in the therapeutic range but on the higher side, what you should do. So these slides will be there, so you can refer it to in your free time. Next slide, please. This is the same with acinocumarol as to how you should go around, that you started with 2 mg, then perhaps the INR is something around 1.8, 1.9. So you should not increase it to 3 mg directly. You should add 0.5 mg, that is 2.5, then increase it accordingly. Next slide, please. This is one thing which is the most misunderstood topic. What to do that you have a patient who has undergone a valve surgery, has a mechanical valve in situ, and is of a childbearing age and is on either warfarin or acetrom. So the thing is, you cannot time pregnancy. And the basic idea is that whatever vitamin K antagonist related pregnancy issues are going to happen in the first 6 weeks. The genetic issues with the kid, the fetus, is going to happen in the first 6 weeks of pregnancy. And by that time, when the lady misses her first periods and comes to know that she is pregnant, it's already 6 weeks. So it is a natural selection that has already happened. So fetal wastage is something around 0.3 to 5%, which is reported in most of the literature. But try and understand one thing, that VKAs are pretty good for the whole pregnancy. no problems. The only problem is in the first 6 weeks of pregnancy, which has already happened. So you cannot do anything about it. You cannot program. You cannot have a patient who will come down to you and say, "Sir, हम बच्चा पैदा करना चाहते हैं, अब क्या करें?" And then you'll stop them or do that. And if that don't get pregnant, you'll stop the valve and kill the patient. So in a natural course of history, what is going to happen is they are going to get pregnant. They'll be coming to you when it's already 6 weeks, and if the fetus has survived, you are very happy. So the next thing is that you can continue VKAs throughout pregnancy till 36 weeks. Keep a target INR of at least 3, and try to keep a warfarin dose less than 5. If it is requiring more warfarin, then switch over to acinocumarol. Why you have to keep the INR 3 is because pregnancy is a hypercoagulable state. So 2.5 doesn't work. On the 36 weeks of delivery, post that, and 1 week prior to EDD, that is the expected delivery date, replace it with unfractionated heparin, and post delivery, you can restart VKAs with the same dose, maintenance dose the woman was after day 1 of the surgery. Next slide, please. Can I have the next slide? Yeah, in elderly and cancer patients, it is individualization is required. There is an increased bleeding risk in the adult, so we should tend to accept a lower range. And since cancers are hypercoagulable state, we may have to titrate it to a higher level, and more frequent monitoring may be required. Next slide, please. So, which we were just discussing about cataract surgeries and all, we prepared this document and we came up very well with the bridging therapy required protocols also, that you don't need to discontinue VKA for simple dental, dermatological and cataract surgery. If AVR with leaflet surgery was done and no AF is there, you may stop VKA without bridging therapy. That means if some patient has a bileaflet AVR done and does not have AF, you can stop it for 4 or 5 days, get the second surgery done, whatever it is, a general surgery or whatever, and restart it. No harm done. Bridging therapy is recommended otherwise in all other cases. So the recommendation is to stop it at least 2 to 4 days. Prior to procedure, bring the INR below 2 and restart the drugs after 12 to 24 hours of the procedure. In an emergency, administering FFP is recommended to bring down the INR below 2 for the surgeon's comfort. Next slide. So this is how you can bridge it. The slide will be available to you. You can stop at least 4 to 5 days in advance. You can start using Clexane or unfractionated heparin as per the institutional and financial things, and then get the second surgery done or the procedure done. And then after the drains are less or there is no bleeding risk due to the second surgery, you can restart the things. One thing which we are always scared about is thrombosis in a prosthetic valve and how to manage it. The first thing is you have to recognize the early symptoms that the patient has started deteriorating on his day-to-day activities. If it is severe, then you will definitely have low cardiac output with calm, cold peripheral circulation with pulmonary edema. Urgently take the patient for a transesophageal echo and fluoroscopy and manage them accordingly. This is the management of valve thrombosis. This is pretty technical. We look on the load, but as a family physician, and if you are practicing in a periphery, never ever think that you cannot do a fibrinolysis. You can use TPA or streptokinase, whatever is available to you, and at least do that bit before you can shift the patient to a higher center. A lot of patient lives can be saved by this simple streptokinase in a stuck valve situation. Next slide. Thromboembolic event, you may follow the same protocols which for any thromboembolic event is done. You can, if there is a brain stroke or a splenic infarct post or even on the femorals there is some clot, you can just thrombolize or go in for a surgery as required. Next slide. So this is for the bleeding complications which we see when we have operated the patient and he goes back to the community, the family physician is the first point of contact for this. So this is a flowchart which you should keep in mind, that if it is, even if the INR is high and bleeding is not active, the best thing to do is stop the VKA. Don't administer FFPs or anything. But yes, if there is active bleeding, you can, as per availability, you can give vitamin K as single ampule and then check for the, after 10-12 hours, you can check for the INR, or you can, if there is massive bleeding with a deranged INR, you should then work accordingly, that you may require FFP as well as vitamin K. Next slide, please. So this is what is my final slide. Thanks a lot. Thanks a lot for having me. ये दिल और दिमाग का झगड़ा हमेशा चलता रहेगा. And happy Independence Day to all. Open for questions, sir.
सर एक पेशेंट के बारे में पूछ रहा हूँ, थोड़ा सा
हाँ जी
डिफिकल्ट.
सर.
एक पेशेंट who is post MVR on anticoagulants, somehow he suffered from hemorrhagic stroke.
Sir, that is a very bad subset to have. You will have to stop your antiplatelets as well as your VKAs for certain time till the brain edema is there, till your because if there is edema and there is space, जैसे बोलते हैं वो क्या बोलते हैं इसको ये लोग, कि your ventricles of the brain are shrunken and there is a mass effect of the hemorrhage, then definitely it becomes that you have to save the life first, because that may result in coning and you may lose that patient. So the surgeon might have to even undergo an urgent thing. You'll have to pump in vitamin K, you'll have to pump in FFPs, go in for the surgery, and later then God's wish. But that's a very difficult subset of patients to manage.
Yes, sir.
Sir. Dr. Goel, can I ask one question?
Sir, it is an honor, sir, to have you.
No, not at all. From a long time we learned that, aspirin in a dose above 75, for stroke at least did not make much difference. But below 75, the microaspirin went out of vogue. And as cardiologists, generally everyone uses 75. So is there data that 150 or is more significantly more potent, and beyond 150, then what do you say?
Sir, I use 150 and the data is for 150. I'll be very honest to you, sir. I'm a pretty aggressive surgeon. Pragnesh knows it. I don't even stop my clopidogrels. Sir, the issue is that even there is enough data that at least 40% of the Indian population is clopidogrel resistant. So we are just giving clopidogrel as chana mamra without even knowing whether the patient is benefiting from that or not. Secondly, we don't have Indian data, but the Western data says that aspirin plus clopidogrel does not lead to increase in re-exploration rates as well as the drain outputs or blood requirements, which I firmly believe. And I have seen that it really is protective for the brain, at least 150 mg of aspirin, as you've rightly said. Yes, but ticagrelor and prasugrel, these are two drugs which I definitely wait for 3 days minimum, because prasugrel is something, sir, I've seen it just turns your blood into water. It's a very potent antiplatelet. And something more that now I'm talking as a surgical experience, I've seen that patients who are on pretty good doses of ticagrelor as well as prasugrel, their vessels are also a bit more friable. I don't know why, because it is a massive kind of an inhibition, endothelial inhibition. So when we try to take down the IMAs, the limas or something, we tend to bleed more and injure them more. Whether it is because they are bleeding more, we injure them, or they are friable and we bleed more or injure them, I am not aware. But yes, prasugrel and ticagrelor, I am shit scared. Till aspirin and clopidogrel, no, nothing. Even if you tell me in the 12 in the night कि patient ने 10 बजे खाया है, I'll take him if it's a left main. left main with STT changes, you have to go in. And then even a prasugrel won't stop me from taking the patient because it becomes a life-threatening issue.
Very good information, sir. Thank you so much.
Thank you, sir. Thank you for having me.
I'm highly appreciate your courage, and you should be continue and know the resistance of the clopidogrel.
Thank you, sir.
Thank
Welcome,
you.
sir. Welcome.
Thank you so much. Kindly accept the certificate. Next, we have another very interesting session from Dr. Yash sir. Dr. Pragnesh Shah is here to introduce him. Over to Dr. Pragnesh Shah.
Thank you, Dr. Jagnany. It is my great pleasure to introduce Dr. Yash Lokhandwala sir. He is a senior interventional cardiologist and electrophysiologist from the Baroda. I always learn something when I listen to Dr. Yash Lokhandwala sir. And I am used to listen him once a year in Karn at Vadodara by the Banker Heart Institute. He is having a more than 40 years of experience as a cardiac electrophysiologist. He is also running a EP training programs and arrhythmia clinics, and he did more than 18,000 RF ablation, and he is author of almost 200 publications across the world. So, it's over to you, sir. Dr. Yash Lokhandwala, sir.
Thank you. Thank you. I will try to just share my slide if possible. I have sent the presentation, but I really don't know how to do this share. So I'll try to share screen.
Swastika, kindly do the needful.
Yeah.
Hello?
Yeah, I have sent my presentation. Can you load it on?
Yes, sure, sir. I'm sharing my screen, sir.
Yeah. So my topic is something which is very close to my heart, sudden death. And the reason why it is because from many years, maybe 1 decade ago, one of our colleagues who is in USA based now, would living in Vadala. He used to come every 6 months to meet his parents and say that every time I come, I hear of somebody in our extended family, friends, and neighbors at a relatively young age has just died suddenly. And is the incidence of sudden death high in India? Now we know that coronary artery disease is commoner in India, occurs at a younger age, but sudden death definitely is significant problem. And then in around 8 years ago, we lost 3 doctors in their 40s and 50s. Either while giving a lecture, second one was at home, and third one was in fact jogging on a Monday morning, and to sudden death. So we decided that we will do something about it, whatever we can, because the survival rates in India of sudden death were pathetic. So now, can I have the next screen, please? Next slide, please. Yeah. So what is sudden death? It's unexpected deaths in a person who may or may not have heart disease, but was not expected to die suddenly. So it's natural, it's rapid, and it's unexpected. Next slide. Next slide, please. Yeah. So remember that most of the sudden deaths will occur in adults. But a very important thing to remember is it's not the very elderly. In fact, in the very elderly, above 70, above 75, the deaths which they are cardiac, they will be because of heart failure. Or let's say there will be cancer or there will be other things. But in the cardiac deaths, majority will be heart failure. It is the relatively younger group between 40 and 60 in whom 60% of the cardiac deaths are sudden. That means they are okay, within 1 hour they deteriorate and are gone. Next slide. If you look at the overall incidence in the adult population, it is about 1 to 2 per thousand, which in India comes to an incidence of about 15 to 20 lakh people die suddenly every year in India. That's not a small number. It's more common in men, but as the people get older and after menopause, this ratio of 4:1 male is to female becomes less and less. Now we say athletics. Yes, sure, athletes are more healthy. But if you go towards extreme athletics, remember, you are doing it for your own kick. I know many people running marathons do it for your own kick because sudden death definitely is higher in any form of extreme athletics or sports. And again, much more common in men. Next slide. If we look at the causes, then in the younger population, you can see the below the line showing that below 35, it is more of the different types of arrhythmogenic heart diseases like hypertrophic cardiomyopathy or arrhythmogenic cardiomyopathy, or a primary electrical disturbance like a long QT syndrome. But above the age of 35, it is predominantly coronary artery disease related deaths or some other type of valvular or cardiomyopathic etiology. Next slide. What is if the heart is beating normally and you die suddenly, 90% will be ventricular arrhythmia. Primary bradycardia, that means heart suddenly stops or becomes extremely slow and stops like heart block, is only about 10 to 15%. 85% of sudden death start off because of a ventricular arrhythmia. Next slide. Now, this is a very famous slide. It is a Holter of a person who died suddenly, and then the Holter was retrieved. Please look at the timings on the graph. At 6 o'clock and 2 minutes, the patient has a normal rhythm, which goes into ventricular tachycardia. The strip below that shows that the ECG progressively becomes disorganized, and at 6:11, it is a flat line. Flat line means we call it asystole. There is no mechanical, there's no electrical activity. The chance of reviving somebody with asystole is nearly zero. Zero. So therefore, when someone has a cardiac arrest, 10 minutes if are gone without any form of resuscitation, the chance of survival is nearly zero. Why is this important? I will come to. Next slide. Now, we modern medicine by intervention, bypass surgery, drugs, anti-anginal, antiarrhythmics, pacemakers, defibrillators, etc., we are all targeting the patients who already have heart disease and serious heart disease. Look at the left side, the pink graphs. The pink graphs are showing you that these high-risk patients, that means heart failure patients or survivors of a major event, have almost 20 to 30% chance of dying suddenly within a year. If you look on the right side and you look at the top, which is circled in red, the blue bar, it is the general population. Now, looking at the incidence in the general population, again coming back to the pink graph, the incidence is very, very, very low, 0.1% per year. So we think that by modern medicine, we can target all these identified last three pink lines, and we will prevent most of the sudden deaths. Now, the blue lines show you actually who are dying suddenly. The majority are in the general population who have no risk factors, not known to have any heart disease. So why this paradox? It is called the Meyerberg paradox. The paradox that most of the sudden deaths are occurring in those in whom the incidence is very low. That is because the denominator is huge. The general population in our country which doesn't have heart disease may be something like 130 crores. And those who are known to have heart disease may be 2 or 3 crores. And that is why it is very difficult, whatever we may say, to beforehand know who is going to risk for sudden death. It's very difficult to know. Most of the sudden deaths will occur without a warning. Very important message. Next slide. Next slide. Yeah. Can we skip this slide? Next slide. Next slide. Yeah. So defibrillation, cardiac massage is one, but defibrillation is what dramatically saves lives. And actually 1947 was the first time it was done in the cardiac OT in a open chest boy, where the chest is open. Closed chest was in 1954. But if we really want to impact sudden death, it has to be in the public, not in the operation theater, not in the ICCU, not in the hospital. Because 80% of sudden deaths are OHCA, out of hospital cardiac arrest. And therefore, in 1980s was the first time we saw defibrillators going public by automated external defibrillators. And in our country also, in at least the many of the major cities, we are now seeing AEDs being deployed. So, of course, a long, long road ahead awaits us. Next slide. Look at this Swedish registry. They have 100% data of their population, and therefore we get the actual incidence properly. It shows on the vertical the survival rate, and the horizontal shows how much time from cardiac arrest till the first shock was delivered. And you can see that if the first shock is delivered within 2 minutes, 50% of cardiac arrest can be revived. But let's say 2 minutes is extremely unrealistic. Let's take a realistic time in a country which is well organized, in a city, of 10 minutes. In 10 minutes also 20% of people can be revived. But if you go more time, then the chance of revival becomes less and less and less. Therefore, every minute is crucial. Next slide. This was sent by many years ago. I have received this slide. This man actually, so many people are gathered around a car. He had collapsed on the road and someone has put him against a tire of the car. He's actually dead. He's in cardiac arrest and people are watching to see whether he will wake up. Now, this was the state of knowledge and response in our country. Nobody wanted to get even involved because who wants to get into jhamela with police? But please remember, we have now a Good Samaritan Act. If you try to revive somebody and that person does not survive, you cannot be held liable for that because you're only trying to do something good. Next slide. So when we were medical students for cardiac arrest, see the top half, the hospital was most important, followed by the ambulance. That time communication also was poor. Now look at the lower half. It is the immediate response at the site of cardiac arrest, not in the hospital. Hospital has become very small circle. So calling someone, starting the chest compression. Please, there is no mouth to mouth now. It is only chest compression. Compression only, life support. And continuing the chest compression till a defibrillator arrives. Either somebody runs or you call for an hospital ambulance, or in the neighborhood there is a defibrillator where someone gets it. So those are the three most crucial. So call, check, and compress. That's what we say are the three C's. Call for help, check if the person has a cardiac arrest, and start compression till a AED arrives. Next slide. Now look at this. This is in Seattle. They say if you want to have a cardiac arrest, have it in a casino in Seattle. Mostly you will be revived because there will be a CCTV which is looking at you all the time. There are everybody trained in this thing. But even in the outside, lay public in Seattle are all trained in CPR. Now their data shows that even if there is a delay to getting a defibrillator, for example, it takes time sometimes. You call, ambulance will come, there is no defibrillator close by, but you start CPR within 4 minutes. Then look at the star, the blue star. 23% of people you can revive, and who will revive well. So don't lose hope just because there's no defibrillator. Sometimes we may continue
chest compression for 20, 30, 40 minutes. But it's very difficult for one person to do it. And therefore, there's only one person who knows how to do it. While that person is doing it, he tells somebody else in the people around, because people always gather around, that please see what I'm doing, relieve me for some time. Then if two people can do by turn, you can continue for 30 minutes, 40 minutes also, till a defibrillator arrives, and still you will save at least 1 out of 5 patients. At present, I can safely say, safely but sadly say, that in India, the chance of revival from out of hospital cardiac arrest is less than 0.5%. People, if there's an arrest, they will put person in car, ambulance, rickshaw and take to hospital. No. When there is a cardiac arrest, you are the doctor, you are the hospital. The defibrillator has to come to you. Patient cannot go to defibrillator. Next slide. Look at the efficacy of out of hospital cardiac arrest when there is public access defibrillator. We know it. All our airports, there are defibrillators. And that day I had gone to Ahmedabad airport. I saw the defibrillators and a lock and key. Then I went and told the airport superintendent, the whole idea of defibrillators, it is idiot proof. Someone who has never used the AED is supposed to be able to use it because it gives instructions. If you keep under lock and key, you are defeating the purpose. I hope they have changed that. In many of the places, they say there's maybe a lock, but you just break the glass and you can take the key. So see the efficacy, 70% survival. That is unbelievable. 70% survival in Sweden. And again, if you see overall, in many countries, pool data, 40% survival when there is public access defibrillator. Public access means railway stations, banks, police stations, post offices, large colonies, housing colonies, large office complexes, educational institutions, etc. Next slide. Now here it's a busy slide, but there is something called as, making some of the population little, everyone knows chest compression, but some of them are little, they have taken second training. We call them heart marshals. We have also trained about 500 heart marshals in Mumbai. Now, the system works in those cities like this. There is someone has cardiac arrest, immediately someone in the neighborhood presses a number and it goes to the police, goes to the hospital and goes to the heart marshal. So, so when there is this person you can see in red running, he's not a doctor, he's not a paramedic, he's somebody who has taken a little more training in resuscitation. And with that, look on the right side that after introducing in residential complexes, the survival increased from 26% to 39%. And in public places, the survival is much more because public places, there will be somebody around. Even before this alert system, they had 50% survival. So we should in India at least aim that we should at least reach 5%. And I feel that while I'm alive, if we reach 5%, I'll be happy. Next slide. Next slide. So our aim should be that a simple 45 minutes course is enough for somebody to learn chest compression. It's not a rocket science, and to understand how to recognize cardiac arrest. So 45-minute course is something, in fact, which is mandatory in high schools and colleges in many countries. And hopefully in our country also, it doesn't cost anything. Hopefully in our country also, some cities will start, others will, take over the example till at the central level, it becomes mandatory that before you pass out, you are trained in CPR and the use of AED. Next slide. We at Revive Heart Foundation, which was previously called iCare, have been doing this in our own way. And so far, despite a very small workforce, as you can see at the bottom right, it is 4 lakh something. So we have trained about more than 4 lakh people in recognizing cardiac arrest and responding to it. Next slide. And these are people who have actually been saved. This was on the left was a very prominent architect One of the first people who was saved not by a doctor, not by a paramedic, but on the Carter Road at Bandra morning walk when he collapsed, Mr. Samir Firesta, who was a lay person trained by us, saved him. And he not only saved him by massage, but made somebody run to the neighboring authors club to get the AED and shocked him. Next slide. Now, when we retrieved what had happened to Mr. Premnath, the prominent architect, incidentally, he was the architect of the Nehru Planetarium, which many of you may be knowing. So you can see that he has gone in ventricular fibrillation and bottom line shock has been delivered and he comes back. So the AED stores all this information. Next slide. But he remained in normal rhythm or some sort of rhythm for some time. Next slide. And again went in ventricular fibrillation. And the second shock, and after that you can see flat line almost, and then the rhythm came back and he got revived, came to hospital, subsequently underwent angiography, bypass surgery, and he's fine and alive and one of the big supporters of the CPR campaign today. Next slide. So we have actually at our level, with help of colleagues also from different parts of the country, including many places in Gujarat and UP and Andhra, many states of the 14 states of the country have been training people. And this is just this year, we have trained already in Mumbai around 9,000 odd people. Next slide. And we have also got some, we do not, of course, give free AEDs, but we get sometimes donations and sometimes encourage people. What does a AED cost? 1 lakh rupees. People in Bombay for a flat are spending 5 crores. What is 1 lakh? And it lasts for 5 years. But many of these places in the western suburbs now have AEDs. Next slide. Dr. Akshay Mehta, a cardiologist from Juhu and a very prominent Rotarian, organized a music program by doctors just for donation of AEDs and got 66 donated. And the good thing is the railway stations now, see, airports have more than 50 AED. The Mumbai International Airport, railway stations had none, and many more were dying at the railway stations than at the airport. So now 50 railway stations in Mumbai not only have AED donated by Rotary, but also their personnel have been trained. And I will show you the results. Next slide. Can you please click on the play button? Actually, we realized that when can you click on that play button so it will play the screen? I can't do it here.
Okay, sir. So I will be like resharing it because it's not playing it from my end. I am resharing it once again, sir.
Okay. In the meantime, I'll tell you that we do this and we post it here, there, try to get people to this. We reach to few thousands. Luckily, being in Mumbai, we have access to some of the celebrities of the film world. And for example, one of the posts recently, which this year's brand ambassador, or we can't brand this year's our personalities, Ananya Pandey, she posted one and it got 1 million views. So that we use many sports persons have helped us giving clips, including Neeraj Pandey, Sachin Tendulkar, Sunil Gavaskar. When they post, it really creates much more, many more people. Yeah, click on the play. Yeah, it will play. Yeah. So please see this. This was again made and for us by Ajay Devgan, who was our first this thing. I don't know if the sound is coming. Are you hearing the sound? No sound. Now it's no sound is coming. Huh? You have to click on that.
Okay, I'm resharing it once again.
So when such people post, it generates much more awareness. And if it is working, fine. Or we go to the next slide. Try once more last time. I think that sound, if it comes, it's fine.
नमस्कार, मैं हूं अजय देवगन। आपने हाल ही में कितनी बार सुना होगा कि किसी की मृत्यु अचानक कार्डियक अरेस्ट से हो गई। अगर कभी आपके सामने कोई अचानक कोलैप्स हो जाए या बेहोश हो जाए तो सबसे पहले आप चेक कीजिए कि वो सांस ले रहे हैं या नहीं। अगर उनकी सांस बंद है और वो रिस्पॉन्स नहीं दे रहे हैं तो ये एक कार्डियक अरेस्ट है। अब आपको क्या करना चाहिए? सबसे पहले नजदीकी हॉस्पिटल में फोन करें और एक कार्डियक एम्बुलेंस बुलवा लें। अगर भीड़ जमा हो गई है तो बोलिए कि आपको CPR आता है और सबसे मदद की रिक्वेस्ट करें। उस व्यक्ति को एक हार्ड सरफेस पे लेटाएं। अगर आसपास कहीं AED मशीन हो तो मंगवा लें। अब आप जल्द से जल्द इस पोजीशन में आकर अपने हाथ ऐसे जोड़ें। पेशेंट के चेस्ट के बीचों बीच कंप्रेशन शुरू करें। आपका यही कंप्रेशन उनके खून को ब्रेन तक पहुंचाने का काम करेगा। याद रहे, कंप्रेशन 100 या 120 बार प्रति मिनट की स्पीड से करें। हर बार छाती को 2 इंच तक दबाएं और ऊपर आने दें। अगर AED मशीन आ जाए तो उसे चालू करें और पैड्स को पेशेंट पर लगाएं। मशीन के इंस्ट्रक्शंस को सुनें।
Place pad. No one should touch the patient.
और शॉक दें।
Shock advised.
ये मशीन गलत शॉक नहीं दे सकती। आप चिंता ना करें, पेशेंट को नुकसान नहीं होगा। एम्बुलेंस के आने तक CPR चालू रखें। अगर पेशेंट को होश आ जाए तो CPR देना रोक दें। हमारे देश में रोज कितनी जानें कार्डियक अरेस्ट से जा रही हैं। CPR से अगर इनमें से कुछ जानें भी बच जाए तो और क्या चाहिए? इससे बड़ा पुण्य क्या हो सकता है? नमस्कार।
Next slide, please. Next slide. Yeah. So every week we thought we have a awareness week in different parts of the country. And we started this in 2021. And as you can see, it generated a lot of interest. The first awareness week, we had 45 lakh social media impressions. Next slide. In the second awareness week, you can see these were the cities which participated in a major way. Pune spearheaded it, and we had 2.5 million online views. Next slide. L- 23 more cities participated, and we had many more training sessions. Every year we target a particular type of audience. This year it is teaching institutes. Next slide. And last year, again, was a successful campaign. Next slide. Can you play this? This year, Ananya Pandey is helping us to spread the word.
Hi, this is Ananya. This year, the National Cardiac Arrest Awareness Campaign is focusing on college and university students. It's time the youth steps in to make India cardiac safe. I urge every college and university to organize CPR training workshops on campus and help students learn this life-saving skill. So don't wait. Learn CPR today, not tomorrow.
Next slide. Incidentally, Ananya's grandfather, Dr. Sharad Pandey, was a well-known cardiac surgeon who was one of our teachers at KEM Hospital. Now, with the help of some of the industry colleagues, we have created this Revive CPR app. It is free, and it will tell you not only how to do CPR, but also give you a map of the AED closest to you in case someone has a cardiac arrest. Next slide. So if any of y'all want, you can scan this right now. You can scan it. You can use it with Apple phone or the Android, whatever. And please encourage, share it with your friends, share it in your social media groups, so that people have it on their phone. It's easy. We are trying to refine it and update it all the time. An important thing is it will also tell you which AED is closest to you. Next slide. Now, these are people who, trained by us or colleagues around the country, have been, those people have saved. Now, I will focus on the second patient who was saved by a traffic head constable. I will also focus you at a very interesting, a very heartwarming and gratifying at Marine Line Station C12. Mr. Subhash Joshi is a survivor who was just 2 weeks ago. Akshay Mehta had trained Marine Lines staff on CPR AED and placed a AED by behalf of the Rotary. 2 weeks after that, a passenger had cardiac arrest. And station masters, Mr. Biswas and Mr. Roy, not only gave him massage, gave him shocks, saved him. So we are, although this number of 16 sounds small, there are many which we don't know. But we once we reach the critical mass, believe me, that we will have many, many more lives saved in our country. And that's why I encourage all of you to please help us and let's join hands to achieve success. Next slide. These are some of the photographs of people who were saved by the lay public, by resuscitation by the lay people, by out of hospital cardiac arrest. Next slide. So to finish, let us come to this thing where initially when we started, the resistance was very high. How will I do CPR? I don't know. What if I get into police problem? Then even doctors, some doctors did not know how to. Actually, we were never trained when I was in proper this thing, resuscitation. Please, there is no mouth to mouth. Luckily, that was one good effect of the horrible COVID, that we stopped this mouth to mouth, because when you release the compression of the chest, you create enough negative pressure for oxygen to go in with the air. So it's compression, only life support. And the second thing is that, the worry that AED, some doctors were again putting AED. What if someone gets a wrong shock? Please, it doesn't happen. The machine analyzes and then you have to manually press to give the shock. So I hope this talk has helped enthuse you all to join this crusade. Thank you.
That was definitely a wonderful insight and motivating presentation, sir. Thank you so much for being here with us on this holiday afternoon, sir. Any questions? Not only on this topic, on any topic, sir is here to help us out. Anything for sir.
And you can actually share my presentation with everyone, whoever wants to utilize it, because the idea is to, spread it out, whatever they want. So please feel free to make it public.
Swastika, kindly put that in the group, that presentation.
Okay, sir. I will tell the coordinating person to send it to you.
Sure. Thank you so much. Thank you so much, sir. That was definitely a very lucid presentation, sir. Thank you so much. We'll look forward to more and more sessions from your good self, sir. I wish sometime you can come to Ranchi and bless us, sir. That will be definitely a pleasure for us, sir.
Yeah, Ranchi, I have been several times in long past, and it's a wonderful place and a lot of educational institutes. So anyway, I wish you all the best for the rest of this meeting. Thank you.
Thank you so much, sir. Before we move to the next session, I kindly request sir to kindly accept this medallion on behalf of the conference and the certificate. We'll post it to you, sir. It will reach to your good self on by post, sir. Thank you, our chairpersons. With this, we move to our next session, which is from Dr. Hiren Gala. He will be talking on Finrenon, role in cardioprotection. Dr. Hiren Mehta is here to introduce him. Over to Dr. Hiren. Yeah.
Good afternoon, everybody. Good afternoon.
Good afternoon.
So our today's next topic is Finrenon, role in cardioprotection. Basically, this is a drug which is used in chronic renal disease. So it is novel approach. Its use and role in cardiac protection. For this, we have a special cardiac clinical cardiologist, Dr. Hiren Gala, sir, with us. Welcome, Hiren, sir.
Yeah, please.
So we have two Hirens here right now, one chairperson and another speaker. Over to you, Dr. Hiren.
Yes, it is Hiren to Hiren.
Ah,
Yes, sir. Please welcome and you are welcome and please start that topic. The mic is over to you, sir.
Yeah, thank you to all the colleagues who have full conference, web conference, which is focusing on cardiology, and it gives me pleasure as well as immense, responsibility to continue new session after what Dr. Yash Lokhandwala sir has, put forward. Sir has given a very wonderful talk on sudden cardiac death. But my focus today is on a new, kid on the block, which is being promoted or being, discussed in the circles with regards to kidney and heart protection. The new kid on the block is Finrenon. So let's start. Oh, sorry.
you can just make it full screen, doctor.
Yeah. I just there's some problem with the network, I guess. So yeah. So, as we know, type 2 diabetes is a leading risk factor for onset and progression of cardiovascular and kidney diseases. And sorry, the cardiovascular diseases is 2 to 3 times more in patients with diabetes as compared to a normal population. And symptoms keep worsening in patients with type 2 diabetes. The heart failure symptoms and the quality of life is also affected in these kind of patients. The CKD or the chronic kidney disease also is quite prevalent in patients who suffer from a strong connection between albuminuria and heart failure, cardiovascular disease, mortality, and chronic kidney disease. Okay. Going forward, I'll show you where there is a strong correlation between albuminuria, which is present, and the CKD and heart failure. Okay. So, chronic kidney disease, diabetes, and heart failure, all of the three share quite a bit of common risk factors. Common risk factors include obesity, inflammatory, problems which are going on, the vascular, disease which happens in these kind of patients. Other factors which are there are older age, predisposition to male population, hypertension, and smoking. Okay. Uh, so as I spoke before that, we generally check on albuminuria, but as per the current guidelines, checking only on albuminuria may not be completely fruitful. So we have to check with creatinine. That is, we check both the creatinine levels and UACR, and we calculate EGFR after we have got the values of creatinine. In generally all the patients who have suffer from type 2 diabetes, generally it is recommended that it is to be done once a year in patients who are having these. These recommendations come from different societies, the ADA, the TDGO, and the American Association of American Heart Association as well. So, coming back to what we were discussing, what we were discussing before, that albuminuria is the common, pathophysiological problem which causes some linkages between the cardiovascular diseases and the kidney diseases. Although, as we know, there are shared risk factors which are present in both hypertension, diabetes, obesity, and chronic inflammatory state, and they form something which is called as a cardiorenal syndrome. These kind of causes problem to the glomerular filtration, and that causes endothelial cell dysfunction and basement membrane thickening, which happens, which leads to albuminuria. The cardiovascular dysfunction and kidney dysfunction have kind of cause shared pathogenesis, which includes chronic inflammatory stages, hemodynamic alterations, oxidative stress damages, and endothelial damage as well. So different studies have uh, done for these assessment of kind of linkages between albuminuria, which kind of causes which is a kind of increased risk marker, a risk for incident heart failure and progression. The renal trial, the MESA study, the ERIC study, and the Framingham Heart study, all of them showed that there is an increased linkage of USCR being high to increased incidence of heart failure. When the USCR, that is urinary albumin creatinine ratio, is high, you have increased risk of heart failure, which happens, which was shown by the CHARM trial and the SALT trial, which was done. This graph shows that when the UACR, that is when urinary albumin creatinine ratio, is more than 3, you have a higher incidence of cardiovascular events in the patients suffering from type 2 diabetes. The cardiovascular events or the composite outcome included MI, stroke, the first incidence of heart failure, unstable angina, the coronary and peripheral diseases, or cardiovascular death. In the kidney composite outcome, we saw that increasing trend of UACR kind of showed that the time of doubling to serum creatinine levels decreased. Incidence of end-stage kidney disease and death also increased in patients who have higher UACR. So, achieving maintaining this stable UACR levels and achieving the decrease in UACR levels are generally associated with increase in overall, increase in benefits with regards to overall mortality and cardiovascular outcomes. Uh, as we see that in the graph, when there is a decrease in USCR, that is more than 30% decrease in USCR, had highest overall survival, which was seen. So, cardiovascular diseases progression and chronic kidney disease progression in type 2 diabetes is driven by combined effect, that is inflammatory markers which are high, the hemodynamic changes which happen, and the metabolic component which is also causing problems. All the three kind of lead to mineralocorticoid receptor overactivation, and this overactivation of the receptor kind of contributes to the CKD progression in these patients. We have different drugs which work on different mechanisms. That is the hemodynamic, the subset where hemodynamic changes causes problem. We have different drugs like ACE and ARBs, the thiazide like diuretics, the CCBs, and the SGLT2 inhibitors which work on these. And for metabolic, that is the sugar levels are haywire. The SGLT2s, the GLP-1s, the metformin, and other hyperglycemic agents work. But there is nothing which worked previously. We did not have any drug which worked both on the inflammation and the fibrosis, or on specifically on, excuse me, mineralocorticoid receptor overactivation. So we have a new drug, the new kid on the block, which actually targets this, MR overactivation and kind of slows down the progression of disease in the heart and kidney in patients who suffer from type 2 diabetes. Finradone actually kind of blocks the overactivation and causes and kind of stabilizes the inflammatory markers. It also helps in stabilizing the hemodynamic factors, and thus it kind of gives a protection to the kidney and the heart. Finradone belongs to the subset where it is the MRA, but it is different from the spironolactone or eplerenone, which were previously there. Uh, Both spironolactone and eplerenone, as per the guidelines which were given, have been used for by us, all of us, for treating congestive heart failure or heart failure where the ejection fraction is low, and in few cases where there is resistant hypertension. Pindrenone as a different non-steroidal antagonist actually works on works in patients who have congestive heart failure, resistant hypertension, and also helps decrease, excuse me, decrease the progression of heart and kidney disease. With regards to its pharmacodynamics, it is a non-steroidal MRA, which has a short half-life. No metabolites are seen. The tissue distribution is even, and there are lower rates of hyperkalemia, which is noted. The Finlenone also showed similar sexual side effects, which were seen in placebo, although they are more as compared to eplerenone and spironolactone. So the holistic approach to treat chronic kidney disease involves different pathways and kind of decrease the progression or slower the progression of heart disease, where we are using currently RAS inhibitors, the SGLT2 inhibitors, GLP-1 and analogs, and now pindrenone. All of them act differently. The RAS inhibitors kind of decrease efferent arteriole hyperfiltration, kind of decreases endothelial dysfunction and helps in cardiac remodeling. SGLT2 inhibitors acts as anti-inflammatory and has antifibrotic effects, decrease hyperfiltration, proteinuria, and oxidative stress. The GLP-1 analogs decrease weight, dyslipidemia, again works on oxidative stress and endothelial dysfunction. Pindrenone actually decreases inflammation, fibrosis, causes tissue remodeling, decreases proteinuria, and decreases endothelial dysfunction. So basically, we are trying to target all the three mechanisms by which we actually had this problem. So the hemodynamic perpetrates the metabolic problems and the inflammatory and the fibrotic issues. So, as we discussed so much on Pindrenone, what are the studies or the trials which have been done for this drug? We had Fidelio trial, Fidelio DKD trial, which was there. There were around 5,700 patients involved in that, and it kind of showed that the kidney failure and the disease progression decreased. Then we had Figaro DKD, which was there. It also showed that pindrenone reduces cardiovascular mortality and morbidity in patients with CKD and type 2 diabetes. Around 7,400 patients were involved in these. I'm not going into the detail of the study, but generally both the studies were positive with regards to kidney failure and cardiovascular mortality. Again, there is an evidence of which we kind of got from the Fidelio and the Figaro trials. Here, the doses of 10 milligram or 20 milligram once a day were used. Total around about 13,000 patients, more than 13,000 patients were studied in both the trials, and we have got the composite endpoint actually were favorable for both. The Fidelio kind of showed that the time to kidney failure decreased, the time to kidney failure increased, and there was 40% reduction in kidney related deaths. Composite endpoint on the Figaro showed that time to cardiovascular death, non-fatal MI, non-fatal stroke, and hospitalization decreased. And then we have fidelity, which was a pooled analysis. Okay. And it also kind of, the outcomes, the cardiovascular outcomes which was studied was time to cardiovascular death, non-fatal MI, stroke, hospitalization for heart failure. Okay. Yeah. So the fidelity trial showed that there was 22% reduction, risk reduction of first heart failure hospitalization as compared to placebo. Then there was reduced risk of cardiovascular death and first admission for heart failure, hospitalization for heart failure was 17%, and the Figaro DKD trial showed that there was 32% reduction in new onset heart failure as compared to placebo. Um, all the studies were discussed in different at different platforms, and the ESA 2023 and the ADA in 2024 used the platform for recommending the use of finerenone in the treatment of the CKD and patients associated with heart failure in type 2 diabetes patients. So this is the whole thing on fidelity. I'm not going much into the detail because of the paucity of time. Again, here the finerenone reduced, risk of the EGFR. Uh, sorry. Uh, yeah. So here the EGFR reduction with
Looks like there is some network issue. I guess in that case, we can request Dr. Deepak Jain to join in as the speaker. And after Dr. Deepak, we have Dr. Mustafa with us from Ireland, who will be taking up. We have missed some of the sessions, and I'm really sorry for that. So over to Dr. Deepak. He will be talking on ARNI.
Thank you, Vineet. Is my
Dr.
slide
Madhav
visible?
Bansal is here. Yeah, please. Visible.
I think it's not visible properly. Just let me check.
Swastika, you can help, maybe.
Hello.
Just a moment. I think I need
Oh,
to.
yes.
It's visible now.
Yes, sir, it's visible.
I'll try to be brief and short because it's Independence Day evening. Am I audible?
Yeah. Yes.
I'll try to be short as possible. I'm going to talk about ARNI. Everybody knows about ARNI. I think there's nothing new about ARNI these days, except it's more few things. Well, first to talk about is burden of heart failure. Everybody knows heart failure is a very big problem around the world. Around 64 million people affected globally. If you look at the map, India is in red, not the So it's high morbidity. As you can see, uh, heart failure not only kills a lot of patients, but there is a morbidity cost to it as well, because many of our patients who have heart failure are not able to do any productive work. Need for therapies that improve survival and reduce hospitalization is important. Uh, if we look at the pathophysiology of heart failure and how ARNI works, there is damage to the heart, then NP system kicks in, ANP, BNPs are released, lead to vasodilation, decreased blood pressure, decreased fibrosis and hypertrophy, decrease aldosterone level, nephritis, and increase diuresis. Effect of RD. Basically, when we talk about RD, consists of two medications. So both of them have different action, but synergistically they have the favorable results. Angiotensin receptor blockage leads to vasoconstriction, increased blood pressure, increased fibrosis and hypertrophy, decreased cardiac output, so increase aldosterone level, uh, sodium and water retention. Now, what ARNI does? What is ARNI? ARNI is angiotensin receptor nephrolysis inhibitor, combination of sacubitril and valsartan. Before ARNI came in the market, there was some research going on for many years where they tried to combine both the drugs. They tried to give them separately as well. Valsartan had been in the market for a pretty long time as a separate drug, and it had decent results. They tried to give sacubitril as a separate drug in some trials, but it was not favorable. Even combination of both the drugs and combination of sacubitril with other ARVs was not that good. Eventually, they were able to find out a golden combination and dose ratio. It increases natriuretic peptides and blocks angiotensin 2 receptor. Sacubitril valsartan mechanism of action is simple. Uh, in heart failure, the problem is uh, there is a balance between salt, water in the body and dehydration. If patient doesn't drink water, there is dehydration. Dehydration leads to other problems. It leads to renal failure, other mechanism. If too much of water, then there is heart failure. So they need to have a balance. So diet cannot be the only way to do that. Now, natriuretic peptides are responsible for salt and water balance in the body. Naproxen holds natriuretic peptides. Naproxen is an enzyme that breaks down natriuretic peptide, preventing them from doing their job. Now, angiotensin 2 is a hormone that causes vasoconstriction and increases aldosterone secretion, leading to high blood pressure. Here, angiotensin receptor is also blocked. Sacubitril inhibits naproxen enzyme and valsartan blocks angiotensin 2 receptor. Key trials, there are three major trials which establish the benefit of these two drugs or the combination of the drug. First trial was Paradigm HF trial, where the population used was heart failure with reduced ejection fraction, and the patients taken were with ejection fraction less than 40%. In this trial, ARNI was compared with enalapril. If you remember, before ARNI came in the market, enalapril was the gold standard. Though recommendation was that ARB can be used in place of enalapril if side effects to enalapril are there. Result was decreased cardiovascular death by 20%, decrease in heart failure hospitalization by 21%, and all-cause mortality decreased by 16%. If we look in the graph, in all the three bar graphs, you see that sacubitril valsartan has lower incidence of cardiovascular death, sudden cardiac death, and worsening of heart failure. Second trial was Pioneer HF trial, where population use was acute decompensated heart failure patients, ARNI versus enalapril again initiated in the hospital. The result was decrease in anti-pro-BNP, just faster decrease, and safe initiation during hospitalization. I still remember when the Paradigm HF trial came up. Initially, our idea was to be little safe with ARNI. We saw few patients with side effects. Probably we were looking for side effects. That's why we had few patients. I remember initial 5, 6 patients, all of them had side effects. Some had hyperkalemia, 2 had hypokalemia, hypotension, everything. So initially, most of the patients we avoided starting ARNI in during heart failure hospitalization, and we started in the OPD later on when they come up in the follow up. But the Pioneer HF trial established the use of an ARNI early in the heart failure stage. And it showed 29% greater reduction with sacubitril valsartan in the endpoint. Third major trial was Paragon HF trial. Population here used was heart failure with preserved ejection fraction, with those with more than 45% of ejection fraction. Here ARNI was compared with valsartan alone, and the result was trend toward decreased hospitalization. This was the graph, the detail of the trial, where 4,822 patients were used, almost equally divided in the two subsections. Composite of heart failure, hospitalization, and severe mortality was compared. And when you see, you find that it is lower in the sacubitril valsartan group, wherein the valsartan group alone significantly higher. Here we see the change in anti-pro-BNP levels with the use of sacubitril valsartan in the Paragon HF trial. So look, see initially, if given valsartan, there is slight decrease in anti-pro-BNP. 2 to 4 weeks when the combination is started, there is significant decrease in anti-pro-BNP. And if later on we continue the patient on ARNI, the anti-pro-BNP level remains almost same as per their trial. It increased a bit, but if we shift over from ARNI to valsartan again, the level of anti-pro-BNP goes back to almost the similar as to what it was when we shift from valsartan to sacubitril valsartan combination. Coming to the dosage, recommendation is for 200 milligram twice a day. Many of our patients do not tolerate this high dose. So the advice is given in 2 ways. Those who are naive to ACE inhibitor or ARBs, 24 and 26, that is 50 mg twice a day is the starting dose. And later on, we increase it to 200 milligram twice a day. Those who were previously on ACE inhibitor or ARBs, they should be started on 100 milligram of dose and should be increased to 200 milligram. To be remembered, if patient is already on ACE inhibitors, then we need to wait for 36 hours before starting ARNI. No, if patient is on ARBs, then we can shift over immediately on earning. And monitoring of blood pressure, renal function, potassium is very, very important. Coming to the safety profile, common side effects are hypotension. We have seen hypotension in many patients actually. And that's why, though the recommendation is to start with 100 milligram if the patient was already receiving ARB or ACE inhibitor, we in our hospital usually start with 50 mg twice a day. Uh, uh, Hyperkalemia is again finding that we saw. I don't know why, but we saw a few hyperkalemia patients in the beginning when the drug just came out. These days, we rarely see them. Renal dysfunction does happen. Slight renal deterioration in creatinine and urea level does take place in most of the patients. And angioedema is rare, particularly if you have given a drug holiday for 36 hours if the patient was previously receiving ACE inhibitors. Clinical recommendation is for heart failure with reduced ejection fraction, ARNI is preferred over ACE inhibitor or ARBs. It should be initiated in the hospital if patient is stable. In those with heart failure with preserved ejection fraction, consider ARNI. It is to be considered, not a must, but for those who have heart failure with reduced ejection fraction, it should be preferred. Initial dose is 100 milligram twice a day. Patient for those on high dose ACE inhibitors or ARBs. Enalapril 10 milligram total dose or therapeutic equivalent dose of another ACE inhibitor. Patient on high dose ARBs, valsartan 160 milligram dose or therapeutic equivalent to another ARB. Initial dose of 50 milligram twice a day for those who were not receiving ACE inhibitor or ARBs, or those who are on less or lower dose of ACE inhibitors. That is enalapril less than 10 milligram. Most of our patients, even if started on enalapril less than 10 milligram a day, or valsartan less than 160 milligram. Those with moderate hepatic impairment should be started on lower dose. Severe renal impairment, which actually means GFR less than 30. There it can be started with lower dose. Till 2-3 years ago, nephrologists used to recommend not to start ARNI, but now they also agree for it. And those who are elderly above the age of 75, we should be little careful. Summary is ARNI improves outcome in heart failure with reduced ejection fraction, emerging role in heart failure with preserved ejection fraction. Safety and effectiveness has been proven in acute and chronic setting, and clinicians should prioritize ARNI in eligible patients. Thank you.
Thank you. Thank you so much, Dr. Deepak, for being here and giving us this wonderful talk. Over to Dr. Madhav for his concluding comments.
For the good presentation, highlighting the importance of use of ARNI and using it as a modality in heart failure patients as a new, which was not available earlier. So it needs to be promoted and encouraged use of ARNI, which I see is still not in very common use. So it's a good drug, and it's a good thing that it can also be considered in patients heart failure with preserved ejection fraction if they have symptoms. So it's a good drug that we have, and it was a nice presentation. Thank you, Dr. Deepak.
Thank you. Thank you so much, Dr. Deepak and Dr. Madhav. Doing the honors, Dr. Hiren, Dr. Avinash, Dr. Hiren Mehta, kindly accept the certificates of the previous session. Then we have Dr. Deepak, who is clinical cardiologist at Delhi and faculty speaker chairperson at various conferences. Dr. Madhav from Bhopal, kindly accept the certificate. For the next session, we have Dr. Mustafa from Ireland. We have Dr. Pragnesh Vacharajani and Dr. Anuradha Paramesh. He's consultant psychiatrist from Cork, Ireland. Over to Dr. Paramesh and Dr. Uh, Vacharajani for this particular session.
Yeah. Good afternoon, everyone, and thank you, Dr. Jagnany, for this AP Ranchi for his excellent cardiology feast of knowledge and having stalwarts in the field of cardiology for us today. And thanks everyone for joining. I will request Dr. Anuradha to continue with the session and request Dr. Mustafa sir for his talk. And he's going to talk on a very important aspect, that is psychiatric assessment and management of cardiovascular disorders, because we all know there are cardiologists to manage the cardiac issues, but patients have lots of issues. Patient in patient family is under a lot of stress because of cardiac event, and cardiac event might have occurred because of the stress and other elements. So this is a very important topic as far as we family physicians are concerned. Over to you, sir.
ಅಯ್ಯೋ ಆಫ್ ಮಾಡ್ರಿ So good afternoon, everyone. Happy Independence Day to one and all. And we are now looking forward to listening to the next speaker. So I would like to say a few words about him. Dr. Mustafa from Ireland.
Hello.
Yeah. Yes, Dr. Mustafa.
I've just shared my screen. Is that kind of clear? Am I successful with that?
Yeah.
Okay. So, as I said, yeah, my name is Dr. Mustafa. I'm a psychiatrist and I work in Cork in Ireland. And I'm going to shift the conversation a little bit to something hopefully will be interesting and of help for myself and for everybody who's there. And that is the role of psychiatry and the psychiatric assessments in monitoring and caring for patients who have either kind of problems with like cardiovascular system problems, or they're just susceptible to develop complications from the way they're presenting. They're presenting. So as we know that the patients, the psychiatric patients presenting to ED are a slightly different cohort of people. There are people they can be who are unwell, mentally unwell, who are could be aggressive, people who are insightless. They don't feel that they need help. So when you are dealing with psychiatric patients who are at high risk, which we all think that in psychiatry, that every psychiatric patient is high risk because of the level of engagement, the level of insight they have, the level of cooperation with the services. So psychiatric patients, all of them are difficult to manage. So I'm going to just speak about the difficulties that people would have in assessing psychiatric patients with a background of difficulties, physical difficulties with their kind of cardiovascular complications. So, why is it important that we look at the assessment of psychiatric patients who have or a chance of having like cardiovascular problems or any physical problem, that they are difficult to manage. Like if you look at the most of the calls that we get from ED, from like medical wards and things, asking for help to manage or assess or control a patient, that it comes from people who are psychiatrically unwell, mentally unwell. The patients who are mentally unwell, they could be paranoid. If you want to check the pulse of this person, you're just checking their pulse, it could be a very difficult task, because if you put your hand in their hands, they might think that you are going to stab them next. So just even checking their pulse is a difficult task for a patient to assess, a psychiatric patient. They could be catatonic, that they are not responding to anything. They could be sightless. They are in hospital and they don't know why they are in hospital. Like people, when they come to the ED seeking help, they would have self-presented to ED, they rang the ambulance, they asked for help, they're here, and any help is appreciated for them. They feel they need the help and they are getting the help. But the patients who are psychiatric, they are usually brought in by the police or by allied team or by their kind of relatives, and they're not happy to be there. So how can you assess a patient that is so uncooperative, and not because he's uncooperative, but just because he's unwell? And if they are kind of prescribed medications by their GPs, by the psychiatrists, then they would come and they say, oh, we don't take these medications because we don't believe that they are, we need the medications. Patients can be aggressive. So imagine if you are addressing a patient that is aggressive and you'd like to assess if he has any kind of cardiac risk. And the nurses and the ED staff have special this person because he is a risk to himself or he's risk to others. So the presentation itself really is a very tricky thing to assess physical problem or kind of mental health problem. Like I've heard one of the registrars was talking to one of the patients and he said to him that, we need to do an ECG. His pulse was like 140. And he said to him, I said, I'm feeling suicidal. Like, what, like, do I care? Like, I want to die. Like, imagine this kind of patients that you see, they're not looking for help. They're so aggressive. They're so uncooperative, and you are still looking to care for them and to provide them the advice and things. So the presentation itself is a real risk that you are dealing with people who are not looking for help, and not because they are not looking for help, but because they are not well. Now, the other thing is that when you are looking to control a situation in ED, in a ward, a medical ward, you are usually asked by the nurses and saying they expect you to prescribe something for this patient. So like before you kind of complete the assessment and kind of assess the risk, you are asked by the nurses, or even without asking, they expect you to kind of intervene with kind of giving some medication, prescribing some medication for a patient that you don't still know much about. We know that it matters because the medications we prescribe and ED staff would prescribe, they would give them something to kind of control situations. They give them antipsychotics. They would give them kind of sedatives, and even without knowing, like you have to tranquilize a patient without fully completing the assessment for this patient. And that kind of poses a risk for if that patient has, history of any cardiovascular disease, is not cooperative, you can't communicate with the patient, and you base on assessment on just kind of a general look and maybe a little bit of collateral, maybe background from what you know about the patient. You go looking in the computers and things to find if this patient has any history of any risk associated with this presentation or not. So the presentation in psychiatry and the assessment of the patient it goes beyond, you know, the classical ways of assessing patients, that history and physical examination and that. Now, we know that when we are prescribing these medications to them, that we know the antipsychotics would affect the heart. You know, some of the antipsychotics that you give, they can cause QTC prolongation. You know, the patient could be already, imagine a patient that has been brought in by the police. He's stressed, he's handcuffed. He will definitely be tachycardic. His blood pressure would be high. Maybe he's really, you know, his adrenaline is up the roof, like through the roof, and then you are expecting yourself and the patients and I mean, the staff are expecting you to intervene with giving more medications to help control the situation. We know that these patients could already be kind of diagnosed with bipolar or something, and he's on mood stabilizers that can, you know, the patient will be kind of overweight and is having metabolic, you know, syndromes or like all the complications that we know from psychotropic medications. This patient might be kind of diagnosed at some point in his life with ADHD, and that he has been on a stimulant for ADHD, and his heart is already suffering with problems. He's tachycardic, his blood pressure is high. He doesn't get that much of a follow-up, you know, from a GP. And then you know that, as I said, with the rapid tranquilization, it's like the haloperidol and the lorazepam. This regimen is almost one of the mostly used medications in EDs. In busy hospitals like the hospital we work in, I work in the prison as well. So, and most of the patients that are difficult to manage, they're immediately by people who are trained as doctors, but you know, they would go immediately to tranquilize the patients. And then I've seen so many times that the patient has just developed something that, you know, a risk that has been, you know, kind of escalated by using medications for them. So we use medications that are difficult. We're dealing with people who are difficult, medications that can cause, you know, complications, and patients that are difficult to manage. And then we are expecting again that patient has been fully assessed, and that patient has been, you know, under the care of the, you know, is getting the right care. And we know that, like you see a patient that is on, say, clozapine, you know, and then when you are able to do bloods on them, you find all the complications that you are expecting from a drug that, you know, cardiotoxic. And then at the same time, patients are, you know, either we don't even know whether that patient is taking the medications right, is not taking the. So what I was saying before is that the presentation in psychiatry is different from all the other presentations because of the difficulties that, you know, people face in EDs or just in the community. Now, there is a problem that we always see, and I think this is a really rising problem, not just in Ireland or in Europe, everywhere, which is the problem of the addiction. Now, in the last few weeks or months and things, we are starting to see new presentations with people who are taking something we don't even know what they are taking. They are taking some synthetic stuff that even when we do drug screening in ED, we don't see that. You have to send these samples to the lab to get more kind of refined, you know, testing for toxicology and things. And the patients are presenting with weird presentations that we don't even know. Like, you know, a person that comes in late age or something becomes very psychotic, very aggressive, very paranoid, and the only history we have is that this patient has been taking something. So the association that we have with the addiction is a huge problem, and is rising, as you know, like in everywhere. Like now we're facing other problems that are coming from addiction, and that patient is already taking something, is already taking substances are cardiotoxic, and then he comes to ED, he presents with, like as I said, could be very aggressive, very bizarre. You are looking to control, you are looking to assess, you are looking to assess the risk, and at the same time, you are looking to tranquilize this patient to control the situations, because he has assaulted a member of the staff, he has been, he wrecked the place, he broke everything around and things, and you want to control that person. And that person, when he presented, he's already addicted to something. He has already taken some amphetamines, and that you some of these you can't even detect in just a normal sample of urine. Plus, you are dealing with people who have personality issues. You see somebody who has a kind of an established diagnosis of an antisocial personality trait or an antisocial personality, and then they are antisocial. So they would have already presented with a kind of a drama. As I said, they are being brought in by the police, or the security staff in the hospitals are trying to kind of restrain them, and they're antisocial, and they are looking to assess them and assess the cardiovascular risk on these people who are already prone to something that would have developed from the situation itself. Some people we see this a lot, like as I said, they have the addictive personality disorder. They're addictive, whatever that, they're looking for medications, they're looking for addictive medications, they're looking for benzos, they're already on cocaine, they're already on kind of, say, taking excessive alcohol. And you are, you are kind of, they throw at you a very difficult presentation with so many things around you that you have to think of all of these things together. And at the same time, you are looking to control and assess the risk and manage situations. And sometimes, as you could see that in the practice, that you need to manage the situations around, and talking to the staff and talking to the nurses and the family, and more than actually looking just at the patient himself and assessing the patient. Okay, so it's just I know the time is limited, but I'm gonna try and go quick through that. So in this usual thing, if you manage to go through all these difficulties and you manage to control that patient and control the situation, you're going back to the classical way of assessing patients, which is that history and the examination. So you'll be looking at the history, which, as I said, after you pass the difficulties of being able to communicate with the patient, then you might, and I will mention at the end some of the helpful tips that are used now in our hospitals here in Europe. Now, the history, you need to know if this patient has any kind of history of cardiovascular disease. You need to kind of look, as I said, it's difficult, but with your, the staff that is helping you, you are also looking at the, presentations. Is there there are any cardiac symptoms, the patient's, the palpitations maybe, or the kind of, if you manage to check that pulse and see if the patient is breathless, is there any kind of history of family presentation similar to that, any kind of sudden death, any arrhythmias, any, and you've looked at the things, from the presentation itself. And then the physical examination, again, if you manage to get to hold the hand of this patient and check his pulse or check the blood pressure, like we've seen so many people who are refusing, declining any kind of help, But if you do get to see these things, they are quite helpful. Checking the blood pressure, just even being able to see what is the situation of the patient, so the assessment is very helpful. The weight, BMI, as much as what you are able to do, investigations, again, people might be very uncooperative. Like, I've seen people who are declining ECG, that is so kind of, like, it's a basic thing that you would do. to kind of make sure that this patient will tolerate the medications that you are going to give, blood tests that, echocardiogram, these are kind of usual things. If you get to do these things, then you are able to say that, this patient is safe to be, this is part of the assessment and finding the right intervention that you are controlling this patient. And so the red flags is that, and that would be kind of a standard for a cardiologist, a psychiatrist, a kind of a person, a physician, that you'll be looking at the flags, the red flags for assessing a patient that can have cardiovascular, high cardiovascular risk. But as I said, and people, everybody is here kind of aware of, and familiar with all these things. But my points that is the presentation in psychiatry is that sometimes even a patient might have a chest pain that is typical, that would really make you concerned about this patient. But the patient is so unwell, mentally unwell, that he's not even able to express that. Patient might have a pulse of 140, 160, we have seen that. But the patient is not even allowing you to hold his hand or check his pulse or put a machine there or check, for if there is any abnormalities in his ECG. Now, just going to the end, that documentation is very important, because these are all tricky situations, and people is like, situations, we have seen how situations can escalate into, as one of our colleagues just now spoke about, sudden death. It's very common that we have seen it in psychiatric wards, that the person would just die. And the amount of information that has been collected from this patient was not enough, to decide things. But the patient just comes and dies. Very common. Whether that was a suicidal attempt successful, or that patient was taking something. Also, there is all the probabilities are there, and then, so the documentation is so important. The communication, you are dealing with situations. You are not just dealing with the patient. You are dealing with difficult situations. And then, just to sum this up, that we are looking at something that is atypical presentation, the amount of help that you are able to find from the patient himself, from the surrounding, from the situation. You are dealing with something that is not, you're not looking at a patient that is coming to you asking for help, but you are also trying to manage situations around the patient, trying to convince the patient. You are aware of the medications that you prescribe for a patient that is already, vulnerable, and chances to develop complications are really high. You are giving cardiotoxic medications. Is a combination of kind of difficult things that you are not able to fully, So it's kind of, I feel this is a real challenging part of the, of our practice, that you are dealing with something that is difficult. The key points is that we always find the collateral. This is my last, might have exceeded my time, but this is my last slide. So the key points is that collateral is so crucial. Like, if you are not able to collect the information from the patient himself, sometimes a collateral that you would get from a GP would be really helpful, from the police, from the family, from the ambulance staff, from the people around. Sometimes this is the only source of information that you are able to get. You ring the mother or you ring the father and things, and they'll tell you this patient has, there is a huge history of kind of, cardiac problems and things in the family. The patient would not tell you that. Sometimes the de-escalation is the safest thing to do, to talk about, like, to the patient, to the staff and things, without intervening with something that is really hard. And as I said, the complications are so, we have seen all range of, complications, from just talking to somebody who was just, alert and able to talk, and but just all of a sudden they collapse and die. As I said, documentation is so important, very important for the staff. just to help situations, but also the medico-legal things are so important here because, as I said, you are dealing with difficult situations. The communication is also a very important key, and just generally, the least interventions that you are injecting in situations here would be the safest thing to do because, we don't know what we are dealing with. And that usually happens, very sudden, like we have seen how communications can become like. Thanks very much. I hope I didn't exceed my time.
Thank you, Dr. Mustafa. That was an excellent presentation. We'll have to look into both aspects. So whether the cardiac drugs are interfering with the antipsychotic drugs or whether they are interfering. So close monitoring of the patient is important, and age factor is also there. So age-related issues also need to be kept in mind. That was a good presentation. Any questions? Dr. Pragnesh? There's some problem with my video. I'm not able to switch on the video.
So thank you, Dr. Mustafa. Thank you, Dr. Pragnesh and Anuradha, ma'am. Next, we have one more session. Two more sessions we are expecting. One is Dr. Sheetal. Kindly accept the certificate. Dr. Sheetal Naik will be talking on artificial sweeteners in diabetes. She is clinical cardiologist from Vijaypur. Dr. Ziaul Haq to kindly chair the session. He is clinical cardiologist from Deoghar. Over to Dr. Sheetal and Dr. Ziaul Haq.
Sorry. My screen is audible? Sorry, my screen is seen?
Yeah, screen is visible, but you need to make it full screen.
Now, sir?
No.
Now?
Not yet. Yeah, now it's there.
I just wanted to reduce this screen again. Okay.
It's full now.
Okay, a very good evening to all of you all. Thank you very much, Dr. V K Jagnany, for inviting me as a speaker here. First of all, I would like to congratulate you that despite of all the difficulties, we are conducting this web conclave, and it's been successful. I think almost more than 9 to 10 years plus that we are conducting this CME, sir, if I'm not wrong. Hello.
Thanks to Corona, that
Yes,
we are doing this webinar every year now.
Yeah. Okay. So congratulations once again, sir, for that. And
आपके साथ है इसलिए हो रहा है.
yes, sir. Thank you, sir. Thank you. Today, sir has given me a very easy topic. Thank you. So I'm going to be talking about artificial sweeteners. What's the dilemma? Are they really helpful or no? Or what are the pros and cons of it? I'll quickly take it like it would be a 10 minutes presentation. So I'm going to talk about artificial sweeteners. Also, I would be referring it as non-nutritive sweeteners. So artificial sweeteners have gained increasing attention as dietary assessment tools. They help combat the obesity epidemic by providing a sweet taste without those extra calories. So taste has a significant role in human perception of food quality, contributing to its overall pleasure and enjoyment. Development of sweeteners as food additives that mimic the sweet taste of natural sugars definitely suggests promise. Non-nutritive sweeteners, NNS, they have 0 to negligible calories. They're used for purpose of reducing the caloric and glycemic impact of prepared foods, and beverages. Now, non-nutritive sweeteners tend to have significantly higher intensity of sweetness in comparison to sucrose. They reproduce the sweetness of sucrose in the fraction of the quantity that is used as compared to sugar. So, in spite of their intense sweetness, NNS do not directly impact blood sugar levels, and so they are supposed to be useful in the dietary management of diabetic patients, also in Weight Watchers. So, coming to some non-nutritive sweeteners that are available now in the Indian market as well as abroad. We have Acelfame, which is sold sold under the brand name of Sweet One. It is more than 200 times sweeter than sugar, and it is approved by FDA. Aspartame, also sold as a NutraSweet and Equal, 160 to 220 times sweeter than sugar, and it is also approved by FDA in 1981. Luohanguo, it's a monk fruit sweetener, monk fruit extract, almost 150 to 300 times sweeter than sugar. Sorry for my back throat. It was also approved in FDA recently in 2011 to 2012. Neotame is not yet available in the market. Saccharin, which is sold under the brand name of Sweet and Low, is 300 times sweeter than sugar, and it's approved. It's approved long back in around 1958. Stevia extracts approved by FDA in 2008. It's more around 250 times more sweeter than sugar. And then sucralose. It is around 600 times sweeter than sugar, which was approved by FDA in 2000. Advantame is about 20,000 times sweeter than sucrose, and it is an artificial sweetener. If I'm going to compare Advantame with other non-nutritive sweeteners, Advantame is around 20,000 times sweeter to sugar, Neotame 8,000 times, sucralose 600 times, saccharin 300 times, aspartame, acelfame around 200 times more sweeter than sugar. So now, non-nutritive sweeteners, I'll tell in short about all of these in short, one slide each. Aspartame is about 200 times sweeter than sugar, but it is one of the most commonly used non-nutritive sweeteners. It is sold under the brand name NutraSweet, Equal, and Sugar Twin. Phenylalanine is a component of aspartame, but individuals with phenylketonuria are unable to adequately metabolize phenylalanine. Label of foods containing aspartame are required to include a statement to inform consumers about phenylalanine content. The next one is Serratia grosvenori swingle fruit extract, also known as monk fruit extract. The best part of using monk fruit extract sweeteners is that it doesn't leave that aftertaste that we get with other typical sweeteners. It's around 100 to 250 times of sweetness of sugar. Neotame is around 7,000 to 13,000 times the sweetness of sugar, sold under the brand name Nutame. And saccharin is around 200 to 700 times sweeter than sucrose. At one time, earlier saccharin used to come with a warning label as possible carcinogens. But then numerous human studies have demonstrated that it is safe in human consumption. Even the National Toxicology Program of NIH in 2000 had said that saccharin should be removed from the list of potent carcinogens. So it is no longer a carcinogen. The warning label is no longer required. Then the commonly used sweetener is stevia glycosides, stevia. These are 200 to 400 times sweeter than sucrose. The high purity stevia glycosides are considered safe. Stevia leaf and crude stevia extracts have not been approved by FDA as far as FDA is concerned, but they're still being used in the market. Sucralose, it is actually a sweetener which is more like actually made from sugar. It is 600 times sweeter than sucrose. It's a low and no calorie sweetener, and it helps to reduce the calories we consume from sugar. Sucralose is actually made from sugar, but it is not digested like sugar. This means that it provides the taste and the sweet taste of sugar, but without its calories. So these are the sweeteners that are available in the market. Equal aspartame, which is mainly used as a tabletop sweetener to replace sugar. It loses the sweetness when heated. So they are used in frozen and uncooked desserts. Similarly, asulfame, sold as with the brand name of Sweet One. Even this can be frequently used as an ingredient in other sweeteners like of aspartame and equal, but it contains no calories or carbs, which is because of which it is more popular with the diabetics. Sweet and low saccharin, it contains saccharin, and this is ideal for tabletop uses and dissolves easily in liquids. Maintains sweetness at any temperature, meaning that you can use it to freeze and bake, to freeze it, and also for baking stuffs like cakes and etc. Splenda contains sucralose. It maintains sweetness when heated up, making it popular to bake with. Doesn't raise the insulin levels, so again popular with diabetics. Neotame, it is not found in packets because, but it is approved as a general tabletop sweetener. Currently, most sweeteners have been shown to have no beneficial effects on diabetes, possibly because of possibly it is also increasing the risk of diabetes. How? I'll tell you in the coming few slides. Some concerns regarding increased risk of developing cancer and kidney diseases is raised with non-nutritive sweeteners. Non-nutritive sweeteners also provide fewer calories per gram than sucrose, as they are not entirely absorbed by the digestive system. So in the next 2-3 slides, I'll tell you how non-nutritive sweeteners are related to metabolic syndrome. It doesn't have anything a direct ingredient which causes it, but indirectly it leads to metabolic syndrome. How? I'll be telling that to you. There are 3 mechanisms. The first one is this is a proposed mechanism of non-nutritive sweeteners for development of metabolic syndrome. The NNS interact with the T1R receptors of sweet taste receptors through the associated G protein gustodicin, which results in intracellular cyclic AMP levels and increased neurotransmitter release. So it also interferes with microbiota, which is with short chain fatty acids from dietary intake, acting as ligands for GPC receptors in the GI tract, regulating NNS permeability and gut microbiota composition. Now, NNS are also associated with insulin and other hormone secretion, which ultimately impact learned behavior and response to the sweetness. The same slide is being shown depicted in this picture. So, what is cephalic phase stimulation? Phase of early gastric secretion when food is in the mouth but has not yet reached the stomach. So here NNS may affect hunger and appetite at this stage. So NNS have low energy density and they lower the osmotic effect. They alter rate of not only gastric emptying but also digestion and absorption, affecting sensation of satiety. Reduce gut peptide response resulting in lower satiety and more energy intake. They are actually added to increase palatability when without sugar, whatever we have to eat, they increase the palatability of every substance, which increases hunger, it reduces satiety, ultimately increases intake. Assurance of energy saving ends up with overcompensation. So there's a reward feeling, and repeated exposure to NNS may perpetuate a preference for sweet items, including with calorie sweeteners. There's one more theory of signal infidelity. That is, if the sensory cue of sweetness leads to inaccurate or inconsistent predictive power, energy regulation may be disrupted towards positive balance of overconsumption triggered by signal infidelity. There's few trials which have done, and few trials which say good about sweeteners, and few of them say they're not really good with non-nutritive sweeteners. One of such studies of Elsa Brazil study. It was a Brazilian longitudinal study of adult health, and in normal weight individuals, consumption of artificial sweeteners was positively associated with developing diabetes. The same association was not found in overweight and obese individuals, in whom higher artificial sweetener intake was found to be associated with better insulin resistance results. There was another meta-analysis done by Miller in 2014. Here also the same thing. They said that there's a positive association between artificial sweetener intake and body mass index. The data collected from RCT revealed that substitution of NNS for a regular calorie versions of the same food, resulted in modest weight loss. One more, some short-term studies have shown that shown little or no detrimental effect associated with intake of artificial sweeteners. But some long-term studies, population-based studies, indicate that there are negative effects associated with aspartame consumption. But this again merits further investigation. However, animal studies have shown that they are carcinogenic. A large study assessed with effect of aspartame taking intake on rats for the duration of the lifetime found that aspartame intake increased the risk for lymphoma, leukemia, transitional cell carcinoma of pelvic, ureter, and bladder. Another study revealed that aspartame consumption raised blood glucose levels in diabetes-prone mice. Individuals who consumed diets like diet soft drinks, primarily which contains aspartame and also sometimes saccharin and sulfame, they have a 36% higher risk for metabolic syndrome. Metabolic syndrome is hyperglycemia, hypertension, abdominal obesity, and higher triglycerides. A 67% of higher risk for diabetes, type 2 diabetes, also compared with those who do not regularly consume diet soft drinks was noticed here. One more there was one more evidence along with it, which said overweight and obese adults drink more diet beverages than healthy adults. Like 11% of healthy weight, 19% of overweight, and 22% of obese adults consume diet beverages. One more major Framingham Heart study. Even here, long-term community-based study of around 4,300 participants was done. And here, consumption of artificial sweetened, but not sugar sweetened, and soft drink is positively associated with the risk of both dementia and ischemic strokes. Another observational, it was an observational study which results this is the observational study. Its result is not showing us a causal relationship. Further research is necessary to examine the mechanism potentially responsible for these observed association. Muller in 2015 also mentioned the same thing. National Heart, Lung and Blood Institute Growth and Heart Study and Health Study recruited and enrolled 2,379 girls in the age group of 9 to 10 years. Here, it was observed that these girls achieved early menarche. Early menarche is associated with diabetes, non-alcoholic fatty liver diseases, cardiovascular diseases, hormone-related cancers. San Antonio longitudinal study of aging, even it said the same thing, that participants who consumed diet soda had twice the increase in waist circumference of persons who did not consume diet soda. Participants who consumed diet soda daily had 3 times the increase in waist circumference when compared to participants who did not consume diet soda. So what can we do now? Is it good or is it bad? Now we as doctors, we need to become knowledgeable about the physiological effect of consuming non-nutritive sweeteners, accurately assess your patient's personal characteristics and health education needs, share this information with your colleagues, assess your patient's health and diet history for intake of non-nutritive sweeteners, and assess risk factors for obesity, diabetes, and cardiovascular coronary artery diseases. As appropriate, provide your patients with evidence-based information regarding the impact of non-nutritive sweeteners on these conditions. Educate your patients on the benefit of eating a balanced diet that includes unsaturated fats, lean proteins, complex carbohydrates, wide variety of fresh fruits and vegetables. So, artificial sweeteners, are they really helpful? No, but I think we need to take it with a pinch of salt. If it's going to help us with reducing blood sugars by reducing the calorie intake, and but taken smartly, I think it would help. But at the same time, studies are not really showing that it has been beneficial.
Thank you, Dr. Sheetal. That was really, I guess, wonderful thing to know. We all have a lot of misconception about this artificial sweetener thing. Invariably, we prescribe to our patients. Many of us think that having a sugar-free soda, sugar-free drink will not have any adverse effect. But I guess I could gather from this talk that they are probably more dangerous. I do not say by saying that sugar is okay in diabetes, but definitely artificial sweeteners should also be avoided. If I can conclude like this from this particular, or at least we should use it as minimum as possible.
Yeah, yeah. I would say that something artificial sweetness is artificial. So it's not even if we say that they're like there are only some products which some of them which, like I said, the monk fruit sweetener, they say it is derived from the monk fruit, but still it's done the word is that the word comes there as artificial sweetness. Now we have added it as non-nutritive sweetness, so we still don't know actually what would be the side effects. It would help a person who would binge sweet, who would eat binge sweeting. I think it would, that person would help with it. But then if people who can control, when patients, your patients say that I've left drinking tea, I have left my sweets, I think good for him. When they say I cannot leave it, I think this would be the better suggestion to give for them.
Exactly. Very true. Very true. If they leave the sweetness, that is probably the best.
Yes.
Dr. Vineet, just one question can I ask?
No, sure, ma'am.
Yeah. Dr. Sheetal, thank you for the excellent, very explicit presentation. And I would like to know, there are, in spite of all that, there are sometimes we want to use, that's what the patients come and tell. So amongst these, what would you recommend? Not on a daily basis, but even for occasional use.
Ma'am, personally, if you're asking me, I have liked monk fruit extract, a really good one now. The one which is being used now. The aftertaste with monk fruit extract is like negligible. If somebody is really looking for taste, otherwise equal is available. Equal I would give. Sugar-free, 0 calorie. Even that one, it has aspartame. Even that we would suggest. But monk fruit, personally, if you're asking me, if my doctor friends would ask me, I would say please go for that. For patients, I think I would think about the pocket of the patient. So aspartame and aspartame also is a good option for that, ma'am.
Okay, monk fruit, what is the brand name? Is it available? Like,
ma'am, it's available. I've seen it with True Native.
Okay.
Yes, ma'am. Yes, ma'am.
Okay. Thank you. Thank you very much, ma'am.
Yes, ma'am.
Thank you so much, Dr. Sheetal. So with this, we move to the next session. And before that, kindly accept the certificate. Next, we have Dr. Biji Soman is back with us. So we missed him in the afternoon, and that will be probably the last session. And I request Dr. Preeti Shankar ma'am and Dr. Anuradha ma'am to kindly do the honors for that particular session, Dr. Biji Soman session.
Okay, thank you very much. ನಾನು actually ಮಾತಾಡ್ತಾ ಇದ್ದೀನಿ.
Great. Yeah. Thank you, Dr. Jagnany, for this opportunity. Happy Independence Day to all. Dr. Biji Soman is executive member, governing body of IACC, and his education is from UK. Over to Dr. Biji Soman for a talk on cholesterol management in acute coronary syndrome. Over to you, Dr. Biji Soman.
Hello, team. Can you hear me?
Yeah.
Can I have the slides, please? Thank you.
Dr. Sheetal ma'am, can you please stop sharing your screen so that I can share it from my end? Or if you give me the permission, I can like stop share it from my end, ma'am.
Yeah, Swastika, please go ahead.
Okay. So I'm stopping the sharing and sharing Dr. Biji Soman's PPT.
Yeah. Dr. Biji Soman is practicing clinical cardiology in UK. And
I hope my screen is visible to you all.
Yeah. He did his MRCP, FRCP from UK and is consultant cardiologist at James Paget University Hospital, NHS Foundation Trust, UK. Over to you, Dr. Biji.
Yeah. Thanks, everyone. Thank you, Vinit. I'll just rush through the slides. I'm sorry that I'm late. I thought, the most important thing these days is there's so much of focus on dyslipidemia. I'll just touch upon. This is basically the new recommendations as per the guidelines from 2019. So I'll just go through the slides and give you an update on what are the new recommendations and what has been modified. Otherwise, most of the things, they stay from before. Okay, I don't have any conflict of interest, and as I said, these slide set is from the ESC AAC guidelines from 2019. Can you go to the next slide, please? Next slide. Next. The next one, please. Perfect. So these are the first subset of new recommendation. There's a lot of impetus on cardiovascular imaging, even in patients with dyslipidemia. They prefer to have, if you have a low risk patient, to look for the plaque burden, either the carotid or the femoral by ultrasound. Then calcium scoring is another way you can look at it. CT is quite widely used because it's a non-invasive one. And I'm sure back home also that's the trend now. And there was a lot of noise around doing a lipoprotein A measurements. That again is in a very high risk patients or with a familial history. You're looking for values above 180. Can we have the next slide, please? Next. Thank you. And in high risk patients who have got triglycerides, you can start them on either icosapent, which is along with statins. Statins is the cornerstone. You should always have statins on most of the patients unless they are statin intolerant. And with the familial history, we aim for an LDL-C cholesterol of less than 1.4. And among older people, I don't know what the trend currently is. Previously, we used to start on elderly people with diabetes, put them on statins. Currently, there is not much evidence of starting statins for primary prevention in people, elder than, 75, 80 is the cutoff, but they say anything above age of 75. And in older people, there is no evidence. Can we have the next one, please? Next slide. So this is what we look for. This would be our treatment goal in patients with dyslipidemia in diabetic patients. LDL cholesterol of more than, reduction by more than 50%. Aim for a goal of less than 1.4. And oops, I missed the slides. Yeah. And statin intensification is the cornerstone, as I mentioned before. And if we don't reach the goal with statins, then we can add on ezetimibe. And in female patients with diabetes, if they're in the premenopausal age group, considering pregnancy or they are not on contraception, statin is not recommended. Next one, please. Yeah. Lipid lowering in patients with ACS, we all know there is no such criteria as a low LDL. The current guidelines is the lower the better. So we aim for as low as possible. Intensive therapy with statin, and if not achieved, we can add ezetimibe. And again, if we don't achieve the target goals, we can use PCSK9 at the earliest. In fact, they do recommend doing it on the same admission as the ACS event. Now next slide, please. Now there have been some changes from 2016. It is all around the advanced tests which we are doing. in a nutshell, all those things which were previously maybe considered has become as a recommendation now. So they say ApoB is something which is recommended in all familial patients or in patients with metabolic syndrome. Can we have the next slide, please? And then for the LDL-C cholesterol, again, if the statins, with the statins, the highest tolerated dose, if you are not able to achieve the goal, we try for a combination with ezetimibe. Next slide. For secondary prevention, very high, again, maximum tolerated statins plus ezetimibe and a combination of PCSK9 with very high family history, same thing, statin, ezetimibe, and a combination of PCSK9. But then we need to do the marker test before that. Next slide, please. Yeah, again, in patients who have a higher risk of triglyceridemia, we may need something in addition to statins. But statin definitely would be the cornerstone, the first drug of choice. Next slide. Next slide, please. Yeah, thank you. As mentioned before, for the family history of heterozygous, we aim for an LDL below 1.4 or at least 50% from the baseline. And if we cannot achieve that with the statin, obviously we go for a combination therapy. And this is a recommendation. Previously, it was maybe considered. Next one, please. Yeah, same thing, role of PCSK9 in very high risk patient. The major thing in this 2019 guidelines was role of combination therapy and early initiation of PCSK9, which in 2016 was not very much in vogue, but now it has come into the recommendation. So we have a low threshold for not starting on PCSK9. Can we have the next slide, please? Next slide, please. Yeah, in elderly people who have renal impairment and they are usually on multiple drugs, which can cause potential drug interaction, statin should be started at lower dose and then we can possibly build it up. Next slide. This is just a reminder. I'm sure we don't need to go through this slide. ACS patients, all of us handle so many of them. So the protocol remains the same, the lowest LDL achievable, aim for at least 50% from the baseline. Statin would be the first choice. If not achieving the target, we add ezetimibe. And if you don't achieve with that, we can go for PCSK9. I believe bempedoic acid is very much in vogue back home, isn't it? So this is then, I believe it's an old chart, but I just picked it up because this was something which I have never seen before. So you have a score chart which gives us the risk of you developing a cardiovascular disease in the next 10 years. This one is scored for the European population, but I think we can devise our own for a local patient profile. So basically the summary would be initiating aggressive lipid lowering therapy immediately after an ACS to reduce risk of recurrent events. And we prioritize high intensity statin, that will be our first choice. If it doesn't reach our goal, we add ezetimibe. And if we struggle with that, we continue with PCSK9. And the idea would be to reach the lower number as possible, aiming between 1.4 to 1. Recurrent events within a 2 year, we aim further lower, less than 1. Oops, I think I went ahead of the slide. Can we have the next slide, please? Sorry. The next slide. Oh, this was the scoring chart. Sorry, next one.
Sir,
Next
can I
slide.
come to the next slide?
No, can I have the next slide, please?
Yes, sir. Yes.
Yeah, thank you. Yeah, so this was what I was just telling. Aggressive lipid lowering ACS, target would be 1.4 for the first event, less than 1 for the subsequent event. Good. So the take-home message: high intensity statin is the cornerstone. Ezetimibe is the second line. PCSK9 if you want further intensification of treatment, or if you're not reaching the treatment goal, lower LDL cholesterol in recurrent events, target would be less than 1. You need to have an individualized approach, which we all follow. I mean, as we know that one size doesn't fit all. Some patients are intolerant, others don't want statins, and we get so many such issues. And we need to monitor and do a regular follow-up with the liver function test. Make sure that other organs are happy with what we are giving. And these are the references in case somebody wants. Can you go to the next slide? Next slide, please. Thank you. Any questions?
Dr. Biji,
yeah.
We could understand that statin is definitely the cornerstone while treating the dyslipidemia, along with, of course, lifestyle modification. May I ask, amongst the statins, is there any particular statin that should be preferred over the other, or all are almost same?
No, from our practice, what we do here, and I believe even back home we were doing the same thing. Atorvastatin is very much favored in patients who have had ACS and the rest. And if you're doing for a general thing, but then back home, the major problem is the cost factor. Otherwise, rosuvastatin is reasonably better because at a lower dose, you can achieve a more stringent control. So my go-to would be atorvastatin in most of the patients, if they can tolerate that, because then it covers a much wider umbrella. And if they say or feel that they cannot tolerate that, then we probably try rosuvastatin at a smaller dose. If not that, then possibly go for simvastatin and pravastatin.
Okay. Anything else for Dr. Biji? I guess you clarified quite well. So, requesting our chairperson and speakers to kindly accept the certificate, Dr. Biji, Dr. Anuradha, and of course for Dr. Preeti also. So, with this, we come to the end of today's session. I feel very sorry that we have missed some of our sessions, and because of paucity of time, we could not match up to the time. And I'm really seeking excuse from my chairpersons that some of us could not chair, but I'm really sorry for that. But time could not permit us, so kindly excuse me for that. So before ending, I just want to recite one shloka, and that's सभा विसर्जन होत है सुनहु वीर हनुमान जे जन जहां से आए हैं तेतः करें पयान. So with that, on that note, I would like to thank you all for being here, and definitely we look forward to one more session in 2026, as we have been doing for almost a decade now. So I'm really sorry, Dr. Devang, that session could not happen. So kindly
Thank you, Vinit. Thank you so much.
Sorry,
Thank
I
you.
could not. One emergency came immediately, so I couldn't.
Thank you so much.
Thank you, Dr. Vinit.
Yeah, thank you, madam. Thank you so much for being here.
Thank you.
Thank you.
Yeah, thank you. Thank you.
Swastika, may I request that we can have recording of all the sessions so that we can share with our
Yes,
speakers?
sure, sir. The coordinating team will be sending you the links of the doctors.
Okay. One more thing, that all those attendees who were there as a faculty as well as speakers, chairpersons, and delegates, kindly share that also with me.
Okay, I will have a talk with Miss Shomi and she will be doing that.
And one last more request.
Yes, sir.
I need spelling of name of yours, Swami and Rituji.
Sir,
Just
mine.
WhatsApp me.
Okay,
Full
okay,
name,
okay,
full
sir.
name.
Okay, sir, sure, sir.
I guess you're taking screenshots also.
Sir, I haven't take like that much of the screenshots cause and the first I didn't know about the screenshot, so I just took 2 to 3 screenshots only. So I would like to request to all the faculty members who are there if they can turn on their videos so we can have a screenshot as like right now for with all the faculties.
Dr. Vineet,
Yes,
I
ma'am.
congratulate you for this excellent session. I really admire your patience. Right from morning 8 o'clock, 5 to 8, I think you have started and you're there till now.
Thank you
It's
so much,
fine,
ma'am.
but you finished on time. That's nice.
But we missed some of the sessions, ma'am. Sorry, really sorry
That's
for that.
okay. If you had taken that, then Independence Day evening, we would have been independent with you. Okay.
Thank you. Thank you so
Thank
much.
you. Thank you. Thank you for
Taking
the
a leave
opportunity.
now. I guess
Yeah.
we shall close the session now. Thank you so much.
Yeah.
Thank you.
Okay.
Thank you.
I leave
Thank
now.
you
I'm
so
in.
Where you will be
Thank
sharing
you so much.
where you will be sharing these presentations and links, I mean, on the WhatsApp group or where?
We are requesting Clarinet to share the recording with us, and then we will share it you with all of us. Once we get it from that, it will take some time. Generally, it
Yes,
takes
yes,
two, three
yes.
days.
Yes, sir. It will take a few days for the editing purpose, and we will be sending you within 2 to 3 days.
Okay, okay. Thank you, thank you.
Thank you. Thanks,
So thank
Swastika.
you
Thank you
so
so
much.
much.
Thank you so much to all the increased present here. Clarinet is really glad to have all these brilliant people together in this session today, and I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much to all.
Thank you. Thank you so much, Vai.
Thank you,
Thank
sir.
you. Taking
Have
a
a good
leave
day.
now.
Yes, sir. Thank you, sir.
Thank you.